I have no conflicts.
Thank you. Dr. Lair?
Dr. Jamie Lair, private practice, family medicine, Ithaca, New York. No conflicts.
Thank you. Ms. Bata?
Good morning, Lynn Bata, public health nurse, clinical immunization consultant at the Minnesota Department of Health, and I have no conflicts.
Thank you. Dr. Brooks?
Good morning, Oliver Brooks, Chief Medical Officer, Watts Healthcare Corporation, South Los Angeles.
Thank you. Dr. Daly?
Matt Daly, Senior Investigator, Kaiser Permanente, Colorado, University of Colorado School of Medicine, no conflicts.
Thank you. Dr. Bell?
Beth Bell, Clinical Professor, Department of Global Health, University of Washington, no conflicts.
Thank you. Ms. McNally?
Good morning, Veronica McNally, President of the Franny Strong Foundation based in Michigan, and I have no conflicts.
Thank you. Dr. Sanchez?
Pablo Sanchez, neonatologist and pediatric infectious disease at Nationwide Children's Hospital and The Ohio State University in Columbus. I have no conflict.
Thank you. Dr. Shaw?
Good morning. Nirav Shah, the Director of the State of Maine Center for Disease Control and Prevention, and I have no conflicts.
Thank you. Dr. Long?
Good morning. This is Sarah. I'm Sarah Long, pediatric infectious disease doctor and professor of pediatrics at Drexel University College of Medicine in Philadelphia. I have no conflict to disclose.
Thank you. Dr. Cotton?
Good morning, Camille Cotton. I'm the Clinical Director of Transplant and Immunocompromised Host Infectious Diseases at Massachusetts General Hospital and Associate Professor at Harvard Medical School. I have no conflicts.
Thank you. Dr. Sineas?
Good morning. I'm Sybil Sineas. I'm an internist and pediatrician, Associate Professor of Medicine and Pediatrics at the Warren Alpert Medical School of Brown University, and I have no conflicts.
Thank you. Dr. Paling?
Good morning. I'm Kathy Paling. I'm Professor of Pediatrics and Epidemiology and Prevention at Wake Forest School of Medicine, Atrium Health, Wake Forest Baptist. I have no conflict.
Thank you. And I'm Grace Lee, Professor of Pediatrics at Stanford University School of Medicine, and I have no conflicts. So we are...
Note Oliver Brooks, I have no conflicts.
Oh, thank you, Dr. Brooks. Thank you, team. I appreciate that. So we will now proceed to the agency updates. And we should start with the Centers for Disease Control and Prevention.
Good morning. I beg your indulgence. We have a lot of updates to give. It'll be a little bit longer than usual. So I will begin with current efforts on maintaining childhood vaccination coverage. During the 2020 and 2021 school year, national vaccination coverage among kindergartners dropped in comparison to the pre-SARS-CoV-2 pandemic period. CDC is working to recover ground lost during the pandemic and is working with healthcare providers and families to get the children caught up on recommended childhood vaccines through its Back to School call to action, which outlines steps to encourage catch-up vaccination, as well as its Let's Play Catch-Up communication campaign, which encourages parents to prioritize the need to bring their children up to date on routine childhood vaccinations. In the area of seasonal influenza, this month, the National Foundation for Infectious Diseases and CDC hosted joint influenza pneumococcal press conference at the National Press Club in Washington, D.C. to kick off the 2022-2023 influenza season. CDC has partnered with the Ad Council and the American Medical Association for their annual Get My Flu Shot campaign, which has also been translated into Spanish. This campaign, with emphasis on Black and Hispanic audiences, encourages the American public to get vaccinated against influenza for the coming season. The first weekly flu view report for this season was published on October 14th. Early increases in influenza activity have been reported in most of the United States, with the highest levels of activity occurring in the southeast and south central parts of the country. This may portend a significant influenza season. No pediatric deaths have been reported to the CDC for the current season. However, last week, unfortunately, the CDC received reports of 2 new pediatric deaths from the previous influenza season, bringing that season's total to 43 deaths and reminding us about the significance of this disease for children. For the current season, based on current claims data for 18-year-olds and older, approximately 12 million doses of influenza vaccination have been administered in pharmacies and physicians' offices as of the week of September 24th. Polio, you all heard about the outbreak that occurred in New York yesterday. Just some highlights. CDC has been actively involved with the New York State Department of Health leading the response. CDC is supporting them. CDC has been working at the local, state, and international levels to control this outbreak. We have deployed staff to New York since August 4th in efforts to assist investigation and vaccination efforts in Rockland and Orange counties. Among its many salient actions include for the CDC conducting testing of poliovirus and wastewater samples in New York and neighboring states, providing confirmatory testing for clinical specimens, collaborating with Israel, the United Kingdom, and the World Health Organization to understand the origins and relatedness of this virus to those found in those countries, ensuring safe and secure handling and transport of potentially infectious materials through the National Authority of Containment, and lastly, facilitating the procurement of polio vaccine for the affected areas. The latest wastewater report will be published at the end of this month in the MMWR. The acute flaccid myelitis patient under investigation reports have declined over the last 4 weeks, indicating that the expected surge in AFM cases failed to materialize this year. So it's now the fifth or sixth year that we've not seen a large increase. Concerning meningococcal disease, Florida is experiencing an outbreak of serotype C meningococcal disease, primarily among men who have sex with men, MSM, since December of 2021. This is one of the largest meningococcal outbreaks among MSM in the United States history. As of October 18th, there have been 35 cases, including 7 non-MSM cases and 7 deaths. MSM living in Florida are recommended to receive meningococcal vaccination. MSM who are traveling to Florida are encouraged to talk to their healthcare providers about getting ACWY vaccine. CDC has been responding to this outbreak with laboratory epidemiology and communications support using multiple channels to provide vaccination. With regard to measles, as of October 18th of this year, provisional data indicate that there have been 29 cases of measles in the United States. 5 jurisdictions have been involved: Arizona, Minnesota, Ohio, Virginia, and the state of Washington. All cases have occurred in unvaccinated individuals, and all but 1 case were in individuals less than 20 years of age. All confirmed cases were associated with importation by individuals who have traveled to Kenya, Somalia, and Tanzania, where measles outbreaks are ongoing. Again, highlighting the importance of pre-travel vaccination for children. With regard to monkeypox, as of the 19th of October, there have been 27,635 confirmed cases of monkeypox, orthopox cases in the United States. There are 539 new cases reported between October 13th and October 19th. CDC's mission to contain this multinational outbreak of monkeypox has been through preventing continued spread of disease by education, medical countermeasures for treatment and post-exposure prophylaxis, expanding laboratory testing availability, coordinating vaccination activities in the United States, and monitoring travel-associated cases. Lastly, I want to turn to a success story from the ACIP. This concerns varicella. In 1995, the ACIP took the scientifically informed yet bold and move to recommend routine immunization with varicella vaccine. The United States was the first country to introduce varicella vaccine into routine childhood vaccination schedule and program in 1995. Over the quarter century of this effort, the United States has prevented among children 0 to 49 years of age an estimated 91 million cases of varicella. 238 hospitalizations, 1.1 million hospitalization days, and almost 2,000 deaths. This has led to a life year savings of 118,000 years and a net societal savings of over $23 billion in that quarter century. Congratulations to the ACIP for their wise decision. That ends my report. Thank you very much.
Thank you very much, Dr. O'Mara, for that update and for the good news. Next, we'll move on to the Centers for Medicare and Medicaid Services.
Good morning. This is Mary Beth Hance, and I have a few updates for CMS. First, I'm sure that you are all aware that the Inflation Reduction Act included immunization provisions that made changes to adult vaccine coverage and related costs for beneficiaries in Medicare, Medicaid, and the Children's Health Insurance Program. For Medicare, Part D generally covers commercially available vaccines, except for those covered under Part B, as in B as in boy. Starting in January 2023, Part D plans may not apply a deductible coinsurance or other enrollee cost-sharing requirement for Part D covered adult vaccines recommended by the ACIP. CMS has issued guidance to Medicare Part D sponsors to address this provision. For Medicaid and CHIP, beginning in October 2023, coverage of ACIP recommended adult vaccines without cost sharing is mandated for enrollees who receive coverage under traditional Medicaid and for all Medicaid medically needy enrollees in specified states, and CHIP enrollees who are 19 years of age or older. And CMS anticipates releasing guidance on this provision. Shifting to seasonal flu, CMS has made updates to cms.gov to provide updated seasonal flu vaccine information and pricing for the 2022-23 flu season. And in addition, just wanted to highlight that CMS continues to amplify guidance regarding COVID vaccines and is issuing press announcements whenever there are changes around COVID vaccines. And that's the end of my report. Thank you very much.
Thank you so much. And I just wanted to say thank you for continuing to ensure access to vaccines for our adult populations. Next, we'll have the Food and Drug Administration. We'll move on to Health Resources and Services Administration.
Good morning. This is Melinda LaSalle. The National Vaccine Injury Compensation Program, or VICP, continues to process an increased number of claims. In fiscal year 2021, petitioners filed 2,057 claims with the VICP, and nearly $208.3 million was awarded to petitioners, and $36 million was awarded to pay attorneys' fees and costs for compensated and dismissed cases. In fiscal year 2022, petitioners filed 995 claims with VICP, and nearly $196 million was awarded to petitioners, and $34.2 million was awarded to pay attorneys' fees and costs for compensated and dismissed cases. Fiscal year 2023 data collection has now begun. In addition, as of October 12, 2022, the VICP had a backlog of 1,536 claims alleging vaccine injury, which are awaiting review. As of October 1st, 2022, 10,323 claims alleging injuries or deaths from COVID-19 countermeasures have been filed with the Countermeasures Injury Compensation Program, or CICP, including 7,412 claims alleging injuries from COVID-19 vaccines. 6 COVID-19 countermeasure claims, all of which are COVID-19 vaccine claims, have been determined eligible for compensation and are pending a review of eligible expenses. 48 COVID-19 countermeasure claims have been denied compensation because of the standard of proof for causation was not met and/or a covered injury was not sustained. In addition to claims alleging injuries or deaths from COVID-19 countermeasures, as of October 1st, 2022, the CICP has received 2 claims alleging injuries from monkeypox vaccine. More information about both programs can be found at the HRSA.gov CICP or VICP website. That's the end of my report. Thank you.
Thank you very much. Next, we'll move on to the Indian Health Service.
Good morning. This is Dr. Matthew Clark. The Indian Health Service continues to confront the SARS-CoV-2 pandemic and its significant impact in tribal communities. Collaborating with our federal, tribal, and urban Indian organization partners, the IHS has prioritized equitable access to COVID vaccines throughout Indian country. To date, participating federal, tribal, and urban facilities within the IHS jurisdiction have administered over 2.3 million COVID vaccines. Following recent regulatory actions by the FDA and CDC, the IHS rapidly communicated information regarding bivalent COVID vaccine boosters. We anticipate that a majority of our service population will be vaccinated in their IHS medical home, and federal, tribal, and urban facilities are now actively engaged in implementation. To date, nearly 40,000 bivalent booster doses have been administered throughout Indian country. Across its 3 surveillance systems to date, IHS COVID vaccine safety monitoring has demonstrated a reassuring safety profile consistent with other national vaccine safety surveillance systems. Meanwhile, the IHS routinely collaborates with the CDC and engages with tribal leaders to support vaccine confidence among the American Indian and Alaska Native service population. Beginning this past spring, IHS has been working also proactively to ensure access to Jynneos vaccine to mitigate the risks of monkeypox in tribal communities. Over 10,000 doses of Jynneos have been pre-positioned across our 12 areas. On September 9th, IHS announced a monkeypox PrEP initiative to expand eligibility for Jynneos vaccine to include not only PEP and PEP++, but also pre-exposure prophylaxis for at-risk populations. In collaboration with our federal and tribal partners, IHS has also implemented a simple process for onboarding sites to participate in the National Monkeypox Equity Pilot Program to further expand access in our vulnerable service population. Finally, I'm pleased to report that in the coming weeks, IHS will be rolling out a new national vaccine strategy. The E3 vaccine initiative is designed to promote access for every patient at every encounter to every recommended vaccine when clinically indicated. This includes all ACIP recommended vaccines in all age groups. We look forward to continued collaboration with our tribal, urban, and federal partners to ensure access to safe and effective vaccines across the age spectrum for American Indians and Alaska Natives served by the Indian Health Service. That concludes my report. Thank you.
Thank you, Dr. Clark. Next, we'll move on to the National Institutes of Health.
Good morning. This is John Beigel from the National Institute of Allergy and Infectious Disease. Just a few high-level updates that we think would be of interest to the committee related to our vaccine work. Most of our updates are actually outside of COVID, reflecting the need to continue advancing these other vaccines. For hepatitis B, the NIH updated its strategic plan on research to cure hepatitis B. It's a roadmap that tries to plot a course towards ending the hepatitis B epidemic, focused on treatment strategies, but also vaccination strategies and screening. As far as influenza, the trial started, we continued to make advancements for universal influenza vaccines, and another clinical trial started at the clinical center, the NIH Clinical Center, for a universal influenza vaccine that, at least in preclinical models, suggested might again develop broad neutralizing responses. We also continue to worry about pandemic flu and have started additional strategies, additional studies for H5 influenza. This most recent trial that we'll give you the details of looked at an intranasal H5 influenza vaccine, and it includes adjuvant as a way to try to improve the antibody response and to block the pandemic influenza. Lassa fever vaccine started. This was a phase 1 study, started in Liberia. It's a collaboration called PREVAIL, which is a collaboration between the NIAID and the Liberian Ministry of Health. And then this particular study was done in additional collaborations with IAVI and CEPI. But it's a novel Lassa vaccine, and we worry about Lassa fever outbreaks and the potential for broad disease from that. So I think this study is a significant advancement. We are doing studies in monkeypox. We are doing additional intradermal studies to verify and look again at the intradermal dosing, the 2 × 10⁷ and the subcutaneous dosing. And then we're also looking at a lower intradermal dosing, and we'll look at both vaccinia neutralizing responses and monkeypox virus-specific neutralizing responses. So we think that will add considerable data to the use of intradermal vaccines for monkeypox. Lastly, there's a Nipah vaccine study that started at the NIH. This is based off an mRNA platform and is done in collaboration with Moderna. Nipah is also one of the diseases we worry about the pandemic potential, and having an immunogenic vaccine is going to be the first step towards doing studies to see if we can have a new vaccine in the armamentarium for Nipah. That concludes the updates from the National Institute of Health. Thank you.
Thank you, Dr. Weigel. Next, we'll move on to the Office of Infectious Disease and HIV/AIDS Policy.
Well, good morning. This is David Kim with the Office of the Infectious Disease and HIV/AIDS Policy and the Office of the Assistant Secretary for Health. The National Vaccine Advisory Committee met on September 22 and 23. At the meeting, as Dr. Duchin, who's a member of NVAC, mentioned yesterday, the committee approved the report with 25 recommendations to sustain and increase confidence in vaccines across the lifespan. The report will be made available on the NVAC website, and the next NVAC meeting will be on February 2 and 3 in 2023. Healthy People 2030 seeks to establish a national prevention agenda with evidence-based measurable targets to be achieved by the end of the decade. The OIDP National Vaccine Program is working with the HHS Office of Disease Prevention and Health Promotion and CDC to formalize 2 immunization objectives as a part of the HP 2030 immunization and infectious diseases core objectives. And the first of this is to increase the proportion of people who receive Tdap during pregnancy. And the second is to increase the proportion of adults aged 19 years old or older who have received recommended age-appropriate vaccines. As a reminder of its importance, in Healthy People 2030, the annual flu vaccination objective is one of 10 leading health indicators for all ages. Of course, the flu season is now upon us. HHS supports efforts to prevent the flu with the campaign Flu to the Flu to drive home the message for people to get the flu vaccine by the end of October. HHS has also recently launched several audience-specific digital media toolkits on hhs.gov/immunizations to promote the flu vaccine in racial and ethnic minority populations and for the first time, small businesses. And then lastly, now available on hiv.gov is a video series featuring the OIDP Director, Tay Hayes, and the White House National Monkeypox Response Deputy Coordinator, Dr. Dimitri Daskalakis of CDC. In the videos, the importance of equity and wellness, federal monkeypox response, and monkeypox vaccine efficacy and vaccine availability are discussed. And that concludes my remarks for the Office of Infectious Disease and HIV/AIDS Policy. Thank you.
Thank you, Dr. Kim. And with that, our agency updates have concluded. So now I'm going to launch into our first session for today. And as a reminder, we're going to finish up our business from yesterday regarding the votes for the pneumococcal vaccine. Dr. Kobayashi will first provide an overview to address some of the questions raised by the committee yesterday, and then we will review the motions on the table one at a time. So Dr. Kobayashi, please go ahead.
Thank you and good morning. So previously, PCV13 was recommended for high-risk adults, and in 2021, ACIP recommended use of PCV15 or PCV20 for certain high-risk adults who have not previously received PCV or whose previous vaccination history is unknown. So adults who receive PCV13 are currently recommended to complete the series with PPSV23. We know that conjugate vaccines have immunologic advantages over polysaccharide vaccines, and PCV20 currently provides the broadest serotype coverage among available conjugate vaccines. Okay. So the proposed recommendations address two questions from the current recommendations. One, should we add PCV20 as an option to PPSV23 for adults who received PCV13 but have not completed their series? And two, should we add PCV20 for adults 65 and older who completed their series with both PCV13 and PPSV23 for added protection? In the next few slides, I will walk through these in more detail. Next slide, please. So this shows the current recommendation. Use of PCV20 alone or PCV15 in series with PPSV23 is recommended for high-risk adults who have not previously received PCV or whose previous vaccination history is unknown. So this includes adults 65 and older and younger adults with certain risk conditions. And adults who have not received any pneumococcal vaccination are not recommended to receive PCV13 anymore under the current recommendations. Next slide. For adults who started their series with PCV13 before the update, these adults are currently recommended to complete the series with PPSV23. So in the next few slides, I will go over each of the three groups we are considering and how the proposed recommendations look like. Next slide. So please note that we changed the order of the groups from yesterday. So now group 1 is adults with an immunocompromising condition, cochlear implant, or CSF leak, who received PCV13 and PPSV23, but have not completed their recommended series. The estimated size of this group is 0.2 million based on vaccine coverage data. And the intent is to add an option of PCV20 for pneumococcal vaccine series completion. Next slide. So this is how the updated recommendation will look like. There will be an option to complete the series with PCV20, which is shown as the green box. Next slide. So the second group are adults 65 and older who received both PCV13 and PPSV23. So these adults are currently have completed their series under current recommendations, and the estimated population size is 17 million, again based on vaccine coverage data. Next slide. And so the proposed policy option is whether or not to add another dose of PCV20 to these adults who have currently completed the recommended series. Next slide. So the final group, group 3, are adults who started the series with PCV13 under the previous recommendation, but have not received PPV yet. Next slide, please. And I forgot to mention the estimated population size is 0.2 million could you go back to the previous slide, please? Sorry, so for 19 to 64 years, the estimated population size is 0.2 million, and then for adults 65 and older, the estimated population size is 9 million. Next slide, please. So the new policy option is to add an option of PCV20 for pneumococcal conjugate vaccine series. So this is the end of my additional presentation. Thank you.
Thank you, Dr. Kobayashi. So since we spent a significant amount of time in discussion yesterday about the pneumococcal votes, I'm just going to ask the committee to keep our discussion focused on clarifying questions regarding what Dr. Kobayashi just presented or any new key issues that will impact the decisions in front of us. So actually, Dr. Kobayashi, if you could please go to the first motion you'd like to present today.
Okay, thank you. Next slide, please. Could you go to the policy language, please?
But are there any clarifying questions our members might have? Dr. Cotton.
Could you just go to the immunocompromised? So for the side with the immunocompromised. So it would be PCV13 plus PCV20, but nothing after 5 years,
Correct.
even though we know immunity wanes significantly in that population.
So currently, no, and then this is just to try to be as consistent as possible as the current recommendation. And could you please go to slide 2, please? 2. So actually, I wanted to highlight that currently adults who are immunocompromised, have chronic medical conditions, they are recommended to receive 1 dose of PCV20. And then as of now, we don't have repeat vaccine recommendations for this group. And in part, this is because there are some uncertainties about how the future would look like. We have new higher valency pneumococcal vaccines in advanced stages of development. We know that PCV20, we anticipate that PCV20 will be used in children in the near future. So it's possible that we will be revisiting these recommendations.
Thank you.
Any additional clarifying questions? Dr. Talbot.
Sitting to, no, you're fine. The only question I have is why wait 5 years for the PCV20? If we can give them better protection, I don't understand why we're waiting. Oh, yeah, I can. I've never been told I'm too quiet. I don't understand why we're waiting 5 years for PCV20, because it seems like these are a high-risk population and they would benefit to getting this at about 1 year after getting the previous vaccine.
So thank you for your question. So this was based on understanding of the current duration protection of these vaccines, plus also the economic analysis to understand, when would be the timing that would maximize protection, but would also make sense from the economic perspective.
Dr. Paling.
The third reason was a strong sense from the practicing clinicians that it was important that you have the same time frame and that you don't use a different time frame if you're using one vaccine than the other, and to try to simplify and use the same time frame for whichever vaccine you're using.
All right, can we please go back to the first motion that Dr. Kobayashi would like to discuss. These are in slightly different order from yesterday. Go ahead, Dr. Kobayashi.
So this is what I presented yesterday. And so for adults with an immunocompromising condition, cochlear implant, or cerebral spinal fluid leak who have received both PCV13 and PPSV23 before age 65 years with incomplete vaccination status are recommended to receive a dose of PCV20 at least 5 years after the last pneumococcal vaccine dose, or PPSV23 as previously recommended, to complete their pneumococcal vaccine series.
And this motion is still on the table. Any questions about this particular motion? Any additional comments? Okay, I don't see, Dr. Long.
I would think it would be clear if this is not a change, but not saying before 65, because then it seems that the interpretation is when you get to be 65, you need something else. And I'm wondering what, I would think that should say 19 to 64, 18 to 64, or whatever.
Could you go to the next slide, please? So
even a clearer way to say that would be so everybody gets who these people are, who are more than 5 years out from their PPSV23 and haven't yet received such. I think then everybody would know who exactly these people are. because that's the only reason they're not really incomplete. They are needing the booster if they're more than 5 years out.
Dr. Talbot?
Am I
Actually,
missing
so
something?
I think what you're just saying, Dr. Long, to me looks consistent with the recommendation or the vote language that is on the table. If we need to add clarifications, I think we can defer to the work group to make sure that the intent is as clear as possible. But I do want to make sure we can move forward with the vote language if there is no substantial differences in terms of what the vote should be.
I'd like to propose an amendment. I'd like to propose that it's 1 year, because I don't know why we're using polysaccharide at all in an immunocompromised group.
So you're making a motion?
I'm making a motion to do an amendment. Thank you.
Is there anybody who would like to second the motion?
I would like to second that motion.
Okay, Dr. Cotton has decided to second the motion. So we now have an amendment on the table that's been moved and seconded. So Dr. Long, did you have an additional comment?
I would. You know, we looked at this very carefully in the work group. And if one has received both a conjugate vaccine and a PPSV23, they really are pretty well protected for 5 years, so that it really adds very little to give them another vaccine right after that. It's not as if they're just getting PPSV23, but PPSV23 after PCV13 is pretty good. It's just not sustainable over 10 years.
Dr. Paley?
Can I ask a clarifying question? I assume that's based on serologic data, not clinical data, so we don't actually know about protection?
Dr. Kobayashi?
One thing that may help, when we did the cost effectiveness analysis, we did assume lower vaccine effectiveness specifically for the immunocompromised conditions. And I don't know if that information helps, but just wanted to share that to try to reflect the possible differences in the clinical protection in these adults, high-risk adults.
Dr. Paley?
One of the perspectives that I'd like to share from the work group is that not only do the infectious disease physicians need to be treating and vaccinating the immunocompromised, but your primary care physicians need to be doing that. And so one of the important principles that we've used to guide the work group is simplifying the recommendations. And so the perspective that was shared from the treating physicians is if you could use the same regimen for the same groups, that would enhance coverage, because we know the coverage in this group is very low. Thank you.
Yeah, thank you. I'm also going to endorse staying consistent with the current recommendations, in part because I just think if we start to change this for this small group, it's going to get really confusing for most clinicians. So while I understand the point made, I feel like we have to make it easier for people to just use this as an opportunity. Dr. Cotton.
I'd like to emphasize that approximately 3% of the U.S. population is immunocompromised, and as we showed in the presenting slides, 9 to 18 times at greater risk for invasive pneumococcal disease. Many of these decision-making analyses are run by computer with alerts, and so I think in the era of many people using electronic medical records, that could be of assistance. So I don't know that we need to make a decision that is likely to be less protective to a highly vulnerable population just to make one size fits all.
I think we should put it to a vote. So let's plan to proceed. To the voting members, I'm going to actually ask you to state your name, whether you have any conflicts of interest, and your vote. And I'm going to start with Dr. Daly.
Excuse me, sorry, this is Dr. Bell. Could you clarify, are we voting on the amendment, or are we voting on the wording that's in front of us on the slide?
Actually, we are voting on the amendment before we can go back to the motion. And the amendment is to change this language to say at least 1 year after the last pneumococcal vaccine dose. So it is not exactly what's up there. And if our team here can just change it to 1, at least right here for the moment, so we can make sure that everybody is voting on the same issue. Thank you, Dr. Bell.
Point of order, Madam Chair. If we're voting, should we have our camera on?
And thank you. We need our cameras on.
Why is my mouse acting up? Come on, Mr. Mouse.
Okay, Dr. Daly.
Daily, no conflicts, no.
Dr. Brooks.
Brooks, no conflicts, no.
Ms. Bata.
Bata, no conflicts, no.
Dr. Lair.
Lair, no conflicts, no.
Dr. Chen.
Chen. Chen, no conflicts, no.
Talbot.
Talbot, no conflicts, yes.
Dr. Paling.
Paling, no conflict, no.
Dr. Sineas.
Sineas, no conflict, no.
Dr. Cotton. Oh, okay. We will move on to Dr. Long.
No conflict, no.
Dr. Shaw.
Shaw, no conflicts, no.
Dr. Sanchez.
Sanchez, no conflict, no.
Dr. Bell.
Bell, no conflicts, no.
Ms. McNally.
McNally, no conflicts, no.
Dr. Cotton.
Cotton, no conflicts, yes.
Thank you. Dr. Wharton. What is the count? Oh, I have to vote. Thank you. Oh my gosh, I need everybody at this table today. Lee, no conflicts, no.
Thank you. The vote on the amendment did not pass. There were 2 votes yes and 13 votes no.
Thank you, Dr. Wharton. So this amendment to the motion does not pass. We will move back to the original motion. And oh, thank you. You already put up the 5 years. So the original motion is up on the slide. Any quick questions? Okay, I'm going to move forward and I'm going to call on Dr. Shaw first. Name conflicts of interest in your vote.
Shaw, no conflicts, yes.
Dr. Long?
Long, no conflict, yes.
Dr. Cotton?
Cotton, no conflicts, no.
Dr. Sineas?
Sineas, no conflict, yes.
Dr. Paling?
Paling, no conflict, yes.
Lee, no conflicts, yes. Dr. Talbot?
Talbot, no conflicts, yes.
Dr. Chen?
Chen, no conflicts, yes.
Dr. Lair?
Lair, no conflicts, yes.
Ms. Bata?
Bata, no conflicts, yes.
Dr. Brooks?
Brooks, no conflicts, yes.
Dr. Daly?
And Daily, no conflicts, yes.
Ms. McNally?
McNally, no conflicts, yes.
Dr. Bell?
Bell, no conflicts, yes.
Dr. Sanchez?
Sanchez, no conflict, yes.
And the motion passed 14-1.
Thank you. Thank you to my committee members. We will now move on to the second motion. I should just have stated that that vote did pass. We'll move on to the second vote. Dr. Kobayashi, vote language for the second motion on the table. Please go ahead.
Shared clinical decision-making is recommended regarding administration of PCV20 for adults aged 65 years and older who completed their vaccine series with both PCV13 and PPSV23. If a decision to administer PCV20 is made, a dose of PCV20 is recommended at least 5 years after the last pneumococcal vaccine dose.
I see Dr. Talbot's hand is raised. Dr. Talbot.
I'd like I want a motion, that's the word, to do an amendment to this, to make it, we recommend and not do shared clinical decision-making. I'd also like to do it for 1 year, but I won't even try. So just to change this from shared clinical decision-making to recommended.
Sorry, do we have a second?
I second that.
Okay, Dr. Cotton.
Along with the full remarks of Dr. Talbot.
Okay, thank you. Thank you, Dr. Cotton and Dr. Talbot. So it's been moved and seconded that we amend this current motion from shared clinical decision-making to a recommendation. A full recommendation. Okay. Dr. Long, you have a question?
Are we discussing?
Please go ahead. If you have any questions about it, please do.
Yes.
And we have the amendment on the table right now.
Yeah, discuss the amendment and then vote on the amendment. Dr. Kobayashi maybe should come back. I wonder if you, Dr. Kobayashi, or you, Dr. Paling, can tell us again the effect in numbers and dollars of this if we made this amendment.
I'm sorry, so the question was the economic analysis?
If we make this a recommendation rather than shared decision-making, can you remind us what's the number in this population and remind us one more time what the cost effectiveness was per quality?
Yeah, so the cost per quality, so it really depended on the model that we looked at. So the one that was in the middle of the three models was the estimate by Merck, which was around like 227,000. But then the CDC model ranged, and depending on the assumptions that we used, the higher range was about like 440,000 per quality gained. And the lowest estimate was the one from Pfizer, excuse me.
And Milwaukee, am I correct, this impacts about 17 million adults over the age of 65?
So the size of the population, that is correct. It is about 17 million based on vaccine coverage data.
Thank you. Dr. Bell?
Thank you. I just wanted to voice my opinion that I'm not going to support this amendment. I think while we all want to quote to sort of save as much lives as possible, we do have to, in my opinion, I also feel like I have to look at the big picture. This is a change which has a small incremental benefit. The idea of boosting, essentially revaccinating with a new vaccine that provides small incremental benefit for a very large population is just not, I don't think, prudent. And I do have, while I don't make my decisions based only on cost effectiveness, I don't feel like it's a good idea to endorse something which involves, as I say, essentially revaccinating a very large number of people for a very small incremental benefit. I don't love this shared clinical decision-making as a way to communicate an idea that this is something that, could be done, but we don't have a better way to do it. I think this population, being a member of this group myself, is a very heterogeneous population. And there may be some people who, don't feel like it's worth it to get another dose of vaccine, and other people where it might really be very important, and this provides this as an option. So I think that there are other considerations besides providing even, the most possible benefit. And I don't think revaccinating with an updated vaccine of a very large number of people in this circumstance is warranted, in my opinion.
Thank you, Dr. Bell. Dr. Talbot.
So quickly, I just want to remind everyone that those cost effectiveness analyses greatly underestimated the impact on both the children of older adults and older adults. 2, I also want to remind everyone at 5 years, the polysaccharide vaccine is very, is waned. It's waned. It's gone. It's a B-cell vaccine, and 5 years later, it's not good. And so this is not only boosting to improve the polysaccharide, but also gives them extra protection. So I really don't think this is just an incremental benefit. It's a huge benefit. And many older adults are still working, and some of them are at the table with us, and we would like to keep them working because they have brilliant minds and should be able to continue to contribute.
Thank you. Dr. Brooks?
Yeah, it's a dilemma. The cost effectiveness data is compelling. It's the largest population we're discussing. But I also remember the data yesterday that the higher rate of pneumococcal disease in African Americans with those types that are not in PCV13 is a concern. And then I also think when it becomes shared decision-making, that concept will not necessarily serve that particular population well. So I can see both sides of it, but I lean more toward what Dr. Talbot said and my impression of what communities and what population will be mostly served by this additional vaccine.
Ms. McNally.
Dr. Lee, I wonder if we might hear from the American Geriatric Society and any other liaisons who are interested in weighing in on this issue. Thank you.
Dr. Schmader, are you on the line?
I am. And as I stated yesterday, I fully support Dr. Talbot's position. The AGS believes that shared decision-making is simply not pragmatic, and all the other arguments Dr. Talbot made, we agree with.
Any other comments?
If I may, Dr. Grace, Dr. Lee.
Actually, I think we're going to, Dr. Goldman, we are almost at time. I'm not sure we're going to get through the 3 votes. I'm going to limit it to voting members for this discussion. My apologies.
Okay, just if I may, I did ask for input. If Dr. Goldman may be able to reply.
Okay. Dr. Goldman, if you can be extremely brief.
Extremely brief. I absolutely support Dr. Talbot's suggestion. I also support 1 year. As a practicing physician, I think it's extremely important to not look just at the cost effectiveness, but the effect on the individual. And so I absolutely support making this a strong recommendation.
Thank you. I'll just add my 2 cents that, I think this committee not only deliberates on the recommendations themselves, but also has a fiscal responsibility. So we just have to be aware of the fact that we are tied to both insurance requirements as well as, the Vaccines for Children's program. Obviously, this is targeting the older adult population, but it does have impact. So on Medicare, thank you. All right. I don't see any additional hands raised. Dr. Kobayashi, did you want to add anything? Okay. Let's put a vote to this proposed amendment that is listed on the slide. Thank you for your help. And I'm going to actually start with, let's see, I'm going to start with Dr. Saneas. Dr. Saneas.
Saneas, no conflict, yes.
Oh, if everybody, I think we have cameras on still. No? If you don't have your camera on. Okay, Dr. Paling?
Paling, no conflict, no.
Lee, no conflict, no.
Talbot, no conflict, yes.
Dr. Chen?
Chen, no conflict, yes.
Dr. Lair?
Lair, no conflicts, no.
Ms. Bata?
Bata, no conflict, no.
Dr. Brooks?
Brooks, no conflicts, yes.
Dr. Daly?
Daily, no conflicts, no.
Dr. Bell?
Bell, no conflicts, no.
Ms. McNally?
McNally, no conflicts, yes.
Dr. Sanchez?
Sanchez, no conflict, no.
Dr. Shaw?
Shaw, no conflicts, yes.
Dr. Long?
Long, no conflict, no.
Dr. Cotton?
Cotton, no conflicts, no.
I'm going to give her a moment to tally this because I couldn't count in my head.
The motion for the amendment did not pass. The vote was 6-9.
6 yeses, 9 noes. The amendment does not pass. So we will return to the original motion that was on the table for shared clinical decision-making. And we will unmark those now. I'm hoping, are there any other important comments? Okay, we're going to move forward because Dr. Wharton's bell just rang. And I'm going to just, while we're waiting for the wording to be changed, I'm just going to warn my committee members that we are going to have an abbreviated lunch today and probably some shorter breaks. So my apologies in advance. And we are going to try and keep this meeting on time as much as possible. Thank you. So we have the original motion back on the table. I'm going to start this time to my right and ask Ms. Bata if you would be willing to vote first.
Bata, no conflict, yes.
Dr. Brooks?
Brooks, no conflicts, yes.
Dr. Daly?
Daly, no conflicts, yes.
Dr. Bell?
Bell, no conflicts, yes.
Ms. McNally?
McNally, no conflicts, yes.
Dr. Sanchez?
Sanchez, no conflict, yes.
Dr. Shaw?
Shaw, no conflicts, yes.
Dr. Long?
Long, no conflict, yes.
Dr. Cotton?
Cotton, no conflicts, no.
Dr. Sineas?
Sineas, no conflicts, yes.
Dr. Paling?
Paling, no conflict, yes.
Lee, no conflicts, yes. Dr. Talbot?
Talbot, no conflicts, yes.
Dr. Chen?
Chen, no conflicts, yes.
Dr. Lair?
Lair, no conflicts, no.
Okay. I'll defer to Dr. Wharton on the count again.
The motion passed, 13 yes, 2 no.
Thank you. So the second motion passes. We are going to move on to the third, and I'm going to ask people to keep comments extremely brief if there are any. Dr. Kobayashi, could you please read the current motion?
Yes. Adults who have received PCV13 only are recommended to receive a dose of PCV20 at least 1 year after the PCV13 dose, or PPSV23 as previously recommended to complete their pneumococcal vaccine series.
Okay. I don't see any member hands. Okay, Dr. Long.
I propose we accept.
Okay. Motion is on the table, so I think we can move to a vote if there's no additional objections to moving to a vote. Okay.
I would just say in the clarifying language for that, that you would need to say that if 5 years passes after PPSV 23, they may need another dose of something. These are presumably people who got 13 for a reason.
I'm going to ask that if our members will allow that we will take this motion on the table. If there's additional discussion that needs to be had, I'm going to actually bring it back and ask Dr. Kobayashi and Dr. Paling to take it back to the work group. Okay. All right. Well, Dr. Long, since you raised your hand, I'm going to ask you if you'd be willing to put forward the first vote.
Absolutely. Long, no conflict, yes.
Cotton,
Cotton.
no conflict, yes.
Dr. Sineas.
Sineas, no conflict, yes.
Dr. Paling.
Paling, no conflict, yes.
Lee, no conflicts, yes. Dr. Talbot.
Talbot, no conflicts, yes.
Dr. Chen.
Chen, no conflict, yes.
Dr. Lair.
Lair, no conflicts, yes.
Ms. Bata.
Bata, no conflict, yes.
Dr. Brooks.
Brooks, no conflicts, yes.
Dr. Daly.
Daly, no conflicts, yes.
Ms. McNally.
McNally, no conflicts, yes.
Dr. Bell.
Bell, no conflicts, yes.
No, okay. Dr. Sanchez.
Sanchez, no conflict, yes.
Dr. Shaw.
Shaw, no conflicts, yes.
And the motion passes unanimously, 15-0.
Thank you, everyone, for your work today. Appreciate it. And Dr. Freihofer, my apologies. Did you want to make a very brief comment?
Yeah, so this is just a Sandra Freihofer, American Medical Association, speaking as a practicing physician who administers vaccines in my office. A clarifying question. In the first vote, it said PPSV 23 is previously recommended. Could you add the 5? I think in the first vote it was 5 years, and now in this one it's 1 year. So that kind of clarifying language would be helpful for practitioners because there have been.
Yeah, thank you, Dr. Freihofer. We really appreciate the clarifications to help our frontline providers. Dr. Kobayashi will take that back to the CDC team, and we will make sure that that is incorporated in some way in the MMWR statement. And with that, we will move on to our original first session for the morning, which will be on combined immunization schedules. And it looks like Dr. Sineas, who is chair of this who is chair of this work group, will provide an introduction and overview. Dr. Sineas.
Thank you, Dr. Lee. Next slide. The Combined Immunization Schedule Work Group updates the child and adolescent and adult immunization schedules annually. The child-adolescent immunization schedule summarizes ACIP's vaccination recommendations for persons 18 years of age or younger, and the adult immunization schedule summarizes ACIP's vaccination recommendations for persons 19 years or older. The goal of the Combined Immunization Schedule Workgroup is to better harmonize the child-adolescent and adult schedules. No new policy is established by the schedule, rather it reflects a summary of ACIP recommendations. Next slide. The working group includes 3 ACIP members, myself and Dr. Alt as our outgoing chair, and Veronica McNally. I would like to acknowledge our liaison representatives listed here, our workgroup consultants, ex officio members, and consultants, and the leadership of our CDC co-leads, Dr. Patricia Woody and Dr. Neil Murthy. Next slide. We wanted to take a moment to thank Dr. Kevin Alt, the outgoing chair, for his leadership over the last 4 years. Next slide. I must also acknowledge all the CDC subject matter experts listed here that contribute to the workgroup activities. Next slide. I would like to remind the committee and the audience why we present the schedule for vote every fall. ACIP's approval is necessary prior to publication of the schedule in February of the following year. In addition, ACIP approval is necessary before we have our partners from the professional organizations listed here to review and approve the schedule. Of note, this is the first year that the American Pharmacists Association will be listed as an approving organization for the adult schedule. We welcome them and their input. Next slide. Presentations on revisions to both schedules may include the use of vaccine trade names. This is for identification purposes only and does not imply endorsement by the CDC. The proposed edits that will be discussed are subject to change based on ACIP's discussion and vote. Next slide. For the remainder of this presentation, Dr. Woody will discuss the proposed edits for the child and adolescent schedule, and Dr. Murthy will discuss the proposed edits for the 2023 adult immunization schedule. These edits are intended to incorporate ACIP recommendations and MMWR publications that have occurred since November of 2021, and improve readability and utility of the schedule into language that is easy to interpret for the busy provider. In addition to the harmonization for both schedules, there are proposed edits to the tables, content changes in the notes section, and changes to the appendix listing the contraindications and precautions for each vaccine type. This session will conclude with discussion of the proposed edits, followed by a vote on the adult schedule and child and adolescent schedule. I will now ask Dr. Woody to take us through the proposed edits in the child and adolescent schedule. Thank you.
Thank you. Please go ahead, Dr. Woody. Thank you.
Thank you, Dr. Seniors. My name is Dr. Woody, and I'll present the proposed edits for the 2023 child and adolescent schedule.
Dr. Woody, could you please speak up just a little bit? Thank you.
Oh, okay. Can you hear me now? Is this better? Thank you. Okay. This is an outline of my presentation today. First, I will present changes to the tables, then the vaccination notes, and then I'll finish with the proposed edits to the appendix. Beginning with the cover page. In the table of vaccine abbreviations and trade names, we are proposing 3 edits. The first edit is to add COVID-19 vaccines, and we've used separate abbreviations for the monovalent and bivalent mRNA vaccines. We also have a separate abbreviation for the monovalent protein subunit vaccine. In the measles, mumps, and rubella vaccine role, we've added Priorix, and in the pneumococcal conjugate vaccine role, we've added PCV15. Our table 1 is the routine immunization schedule by age. In table 1, we have added a role for COVID-19 vaccines, and we've shaded age 6 months through 18 years in yellow, indicating the recommended age for vaccination. We have also included an overline text prompting providers to review the notes section for more details on the primary and booster vaccination. In the pneumococcal vaccination role, we have added PCV15. And in the inactivated poliovirus vaccine role, for age 18 years, we've added C notes, prompting providers to look at the notes section for more details. Table 2 is the catch-up immunization schedule for children who have started late or are more than 1 month behind. We have 1 proposed edit for Table 2. In the pneumococcal conjugate role, for the minimum interval between those 3 and 4, we have revised the text to indicate when the 4th dose is recommended. Table 3 is the immunization schedule by medical indication. In Table 3, we have added a role for COVID-19 vaccine, and in the columns for HIV infection and immunocompromised status, excluding HIV, we've added the overline text C notes. Next, I'll present the edits to the notes section. Under additional information, in the bullet for injury compensation, we've added COVID-19 vaccines, and we've added a sentence stating that COVID-19 vaccines that are authorized or approved by the FDA are covered by the Countermeasures Injury Compensation Program, and we've included a link to the webpage for the program. We've deleted the previous COVID-19 vaccination box, and we've added a new section for COVID-19 vaccination. We use the format, the age-based format in the infographics present on the CDC webpage for use of the COVID-19 vaccines. The routine vaccination section summarizes the recommendations for children and adolescents who are not moderately or severely immunocompromised. For the primary series section, based on the age of the child, we've included the dose series and the recommended interval between doses for each product. Because booster dose recommendations are still evolving, we've included a link to the webpage with the most current recommendations. In the special situations section, we've summarized the recommendations for children and adolescents who are moderately or severely immunocompromised. And for the primary series, we've included the dose series and the recommended minimum interval for each product. For booster vaccination, we've included the link to the web page. We also added a bullet reminding providers that pre-exposure prophylaxis may be considered to complement COVID-19 vaccination in this population. And then at the end, we've added a note reminding providers that an age-appropriate vaccine product should be administered for each dose. We've included links to the current COVID-19 schedule and the dosage formulations. And we also have a link to where the emergency use authorizations are located. Now, moving on to dengue vaccination, we have a new bullet stating that dengue vaccine should not be administered to children traveling to or visiting endemic dengue areas. And for hepatitis B vaccination, there are no new recommendations, but we've reorganized the section so that healthcare providers can easily find recommendations based on the mother's hepatitis B surface antigen status. So we have a section for children whose mothers are hepatitis B surface antigen positive. Sorry, there's a delay. Sorry, I'm going to go back. Okay, and then we have another section for children whose mother's hepatitis B surface antigen status is unknown. We also included information reminding providers that if, for these infants, if the mothers have evidence suggestive of hepatitis B infection, the infant should be managed as if the mother is hepatitis B surface antigen positive. In the catch-up vaccination for hepatitis B, we've added Heplisav B and Prehebreo as options for adolescents aged 18 years and older. For influenza vaccination, we added back the recommendations for persons with egg allergy with symptoms other than hives. Last year, this information was in the appendix as a precaution, but we realized it's not a precaution and we brought it back to this section. We have a new bullet in the special situations section stating that LAIV4 should not be given to close contacts of severely immunosuppressed persons who require a protective environment. In the MMR vaccination notes, we have a new bullet in the special situations section addressing the use of additional doses in a month outbreak setting. For meningococcal ACWY, we've included information on the newly licensed one-vial liquid formulation of Menveo. So we have that Menveo now has two formulations, the one vial all liquid and the previous two vial formulation. The Menveo one vial formulation should not be used before age 10 years. And in the MenB vaccination notes, we have in the special situations section, we have just harmonized this with the adult schedule, where we added the language in parentheses for if dose 2 is administered at least 6 months after dose 1, or dose 3 is administered earlier than 4 months after dose 2. In the pneumococcal vaccination notes, we've added PCV15, which was approved for children and adolescents in June. We've replaced PCV13 with PCV in all the sections. We've added a note stating that PCV13 and PCV15 can be used interchangeably for children who are healthy or have underlying conditions. No additional PCV15 is indicated for children who have received 4 doses of PCV13 or another age-appropriate complete PCV13 series. We have deleted the chronic liver disease and alcoholism bullets because those are not risk factors for invasive pneumococcal disease in children and adolescents. And then in the polio vaccination note, we've added a new special situation section to address adolescents aged 18 years at increased risk of exposure to polio virus. Those in this age group who do not have evidence of a complete polio vaccination series, which is defined as at least 3 doses, should get the remaining doses to complete a 3-dose series. And those who have evidence of having at least 3 doses may receive a 1 lifetime IPV booster. We've included the link to a web page the CDC created with more details on this information. Lastly, I will go over the proposed edits for the appendix. The appendix was added last year, and it lists the contraindications and precautions for the vaccines in the schedule. We changed the header from contraindications to contraindicated or not recommended. In the hepatitis B rule, we've added a new bullet stating that Heplisav and Prehebril are not recommended during pregnancy due to lack of safety data in pregnant women. Healthcare providers are advised to use other hepatitis B vaccines if indicated. In the footnote, we've added links to the pregnancy registries for both vaccines. In the HPV rule, we've added a new bullet stating that HPV vaccination is not recommended during pregnancy. And in the MMR rule, we've added MMRV vaccine product. And in the precautions column, we've added a new bullet saying that personal or family history of seizure of any etiology is a precaution for using MMRV. And then in the varicella rule, in the precautions column, we've added a new bullet saying that if healthcare providers are going to use MMRV, they should see the MMR rule for additional precautions. And that's the end of my updates. I'll now take questions. Thank you.
Presentation is now open for questions. Ms. Bata?
Just a point of clarification. I know that we have already recommended COVID-19 for children, but it's under an EUA. Is it okay for us to include that in the routinely recommended schedule if it's a EUA interim recommendation?
Yeah, before we brought this to the work group, we had a conversation about this with our Office of General Counsel, and we're told that it was okay to add it to the schedule.
Dr. Brooks.
Can you go to the one on polio? It was
Polio?
age 18, about 5 slides back or so. 39? Thanks, Jamie.
This one, yeah.
Yeah, it says adolescents age 18 years, so is it only for an 18-year-old, not a 17 or a 19-year-old?
It's only, the current polio policy has a routine recommendation up to age 17 years. So beginning at age 18 years, the routine vaccination is not recommended, and this policy is from 2000. So for persons who are age 18 years and older, polio vaccine is recommended if they are at increased risk of exposure. So in the child and adolescent schedule, which is up to 18 years, this only applies to adolescents age 18 years, and those 19 years and older will be reflected in the adult schedule.
Okay, thank you for the clarification.
Any additional questions? Actually, I have one question on slide 37. When you, replacing, for the pneumococcal conjugate vaccines, my simple question is, why did we delete chronic liver disease? Is that no longer a risk factor for anybody?
Miwako can help me here, but my understanding is that it was, in the last policy note, it was added in error for the children and adolescents, and when the new policy note for use of PCV15 was written, that error was corrected. She's asking why we deleted chronic liver disease and alcoholism from the child and adolescent schedule. Miwako.
Just for clarification, I think alcoholism makes sense. I think chronic liver disease, we definitely see children with chronic liver disease who need liver transplants. So
So yes, thank you for that question. So what happened in the past was chronic liver disease was never part of the table that lists the risk conditions for the pediatric table, and then that's reflected in the current MMWR R&R that was published in 2010. And when there was a vote on use of PCV13 in children with underlying conditions, immunocompromised conditions, age 6 to 18 years, and that was back in 2013. When the MMWR was published, the table that was included in the published MMWR was reflected the conditions that's used in the adult group. So there's always been this confusion because it was never the intent to change the table. It was not something that was presented to ACIP, but then when the MMWR was published, the table for that age group was switched over. So with the update, with the recent MMWR that was published for the PCV15 recommendation, we tried to just address that previous confusion that happened.
And maybe I'll just ask if the pneumococcal work group will consider that in the future.
I would like to clarify, we're going to be addressing PCV20, and this would be a very easy way to include that in that conversation.
Thank you so much. Any other clarifying questions? Oh, Dr. Daly.
Yeah, so I'd like to make a couple sort of overarching comments, and this is in response to public comment that we've received. So is that okay, Dr. Lee? Do we have time for that? Okay. So, you know, we've received comments from the public that are concerned about adding COVID-19 to the routine schedule, to the routine childhood schedule, and I just want to address that directly. You know, this doesn't represent new recommendations. This represents sort of a summary of existing recommendations. But I will acknowledge, I appreciate that there is symbolism in adding COVID-19 to the childhood immunization schedule. And that symbolism is that we view this as routine and that we view this as COVID is here to stay. And so when I think about the routine immunization schedule as a practicing pediatrician, I think about it as an opportunity in my patients to prevent serious disease and death. That's what I view that as. And if something is added to the schedule, it's because I feel like the benefits continue to strongly outweigh the risks. And so I just want to make those points. The other point I will make is that this does not constitute a mandate, but there are mandates, but those are really state Board of Health largely decisions, and this doesn't represent a mandate. But then I appreciate that if parents are concerned about COVID-19 vaccines, then they're concerned that this could be turned into a mandate. And again, I would want to turn that conversation in a different direction. I've had parents who've come in my office and I say, oh, what are you here for? And they say, well, we're here for vaccines so that our kids can go to school. And I've said, okay, I understand that, but really I'm not vaccinating so you can go to school. I'm vaccinating because I want to prevent serious disease and death in your kids. And the fact that there's a school immunization requirement helps because it brought you into the office, but that's not my goal. My goal is to prevent serious disease. So those are overarching comments. I just want to acknowledge that we heard the public's concern about this in the public comments, but just to reiterate that the reason things are added to the schedule is that we feel like the benefits strongly outweigh the risks, and these are opportunities for disease prevention, but we acknowledge that there's concern on the part of the parents. I guess the last point I'll make is we just need to continue to do better at communicating why we think the benefits strongly outweigh the risks. Thank you.
Thank you, Dr. Daly. I don't see any additional hands raised. Oh, Dr. Shah, please go ahead.
I'd like to underscore the importance of Dr. Daly's comments, and I wanted to add one or two other pieces of clarification. The vote and the discussion around the addition of COVID-19 vaccines to the recommended immunization schedule is separate and distinct from yesterday's vote in support of a resolution to add COVID-19 to the Vaccines for Children program schedule at the point that the vaccines become commercialized. Yesterday's vote, in effect, was a resolution about the coverage of the vaccine for un- and underinsured children, not a discussion of what pediatricians ought to be doing in an office setting. This discussion today around adding the COVID-19 vaccine to the recommended childhood immunization schedule does not constitute a requirement that any child receive the vaccine. That decision remains where it did before. This is rather a codification of a pre-existing recommendation. We recognize that there is concern around this, But moving COVID-19 to the recommended immunization schedule does not impact what vaccines are required for school entrance, if any. Indeed, there are vaccines that are on the schedule right now that are not required for school attendance in many jurisdictions, such as seasonal influenza. Local control matters, and we honor that. The decision around school entrance for vaccines rests where it did before, which is with the state level, the county level, and at the municipal level, if it exists at all. They are the arbiters of what vaccines are required, if any, for school entry. This discussion does not change that. Thank you.
Thank you, Dr. Shah. And with those comments, I think what I'd like to do is move on to the next session by Dr. Neil Murthy on the 2023 adult schedule revisions.
They're trying to move the...
Technological issues, sorry about that.
It says here control, yeah, it's moving now.
Oh, okay, it's moving, yeah. All right.
There you go.
Thank you so much, Dr. Lee, and good morning, everyone. My name is Lieutenant Commander Neil Murthy, and along with Dr. Patricia Wody, I serve as the co-lead for the Combined Immunization Schedules Work Group. And this morning, I'm very grateful to have the opportunity to present to you all the proposed updates to the 2023 adult immunization schedule. This is an overview of what I'll be covering in the next couple of slides. I'll present only substantive changes to the 2023 adult schedule. Minor grammatical or formatting edits that are meant to improve clarity in the language will not be presented. I'll begin this discussion by walking through the proposed edits to the cover page and tables, followed by discussion of the proposed vaccine-specific changes in the notes section, and finish with a brief discussion of the proposed changes to the appendix section, which lists the contraindications and precautions to all vaccines that are recommended in the schedule. Let's start with the cover page. There are 6 main changes on the cover page. The first edit is to the upper right-hand corner of the cover page, where we have added the American Pharmacists Association as a partner organization approving the adult schedule. The next couple of edits are in the list of adult vaccines. You'll notice that for the first time, we have added COVID-19 vaccines to this list of recommended vaccines. The first abbreviation shown here refers to the monovalent mRNA vaccines. The second abbreviation refers to the bivalent mRNA vaccines. And the last abbreviation on this list refers to the monovalent protein subunit vaccine. In the Hep B row, we have now added Prehevbrio to this list. Similarly, in the MMR row, we have added Priorix to this list. Compared to the 2022 schedule, you will notice that we have combined the pneumococcal conjugate vaccines, PCV15 and PCV20, into one row in this table. And finally, under the injury claims section, we have included information here about COVID-19 vaccines and the Countermeasures Injury Compensation Program. We'll now turn to the changes recommended in Table 1 that outlines the age-based recommendations for adult vaccines. Table 1 has 3 proposed edits. The first edit is the addition of the COVID-19 vaccine row. You'll see here that the entire row is yellow, indicating that COVID-19 vaccination is recommended for adults of all age groups. Guidance regarding the COVID-19 primary series and booster doses is provided in the overlaying text. The second edit is to the MMR row, where overlaying text has been added to the greater than or equal to 65 years of age column. We now refer providers to the notes section for vaccination considerations for healthcare personnel who are older than 65 years of age. And the final edit is to the hepatitis A row, where the overlaying text now states 2, 3, or 4 doses, depending on vaccines, to include the 4-dose accelerated twin risk schedule that can be used for hepatitis A vaccination. Let us now turn to Table 2, which is the medical indications table. Compared to the 2022 schedule, there's only one major change to Table 2, and that is that COVID-19 has been added as a row to this table. The HIV and immunocompromised conditions columns has a C notes as an overlaying text, since such patients may have different primary series requirements and may have additional considerations for pre-exposure prophylaxis to complement COVID-19 vaccination. We'll now turn to changes proposed in the notes section of the adult immunization schedule. In each of the subsequent slides, I'll walk through the notes section and explain the proposed changes in each of the vaccine-specific sections. For your reference, the page number of the notes section can be found in the upper right-hand corner. And we'll begin our discussion with the addition of the COVID-19 section on the first page of the notes section. You'll notice that in the 2023 schedule, COVID-19 is now formally incorporated into the schedules and is no longer in a special call-out box like how it was in previous years. The COVID-19 section begins with the routine vaccination guidance portion that describes the primary series for the mRNA vaccines and for the protein subunit vaccine for the general population. Because guidance on booster dose recommendations may change based on evolving data, providers are encouraged to review the latest booster dose recommendations at the website presented here. The special situations section starts off with a brief description of the recommended primary series for persons who are moderately or severely immunocompromised. Again, a hyperlink is provided here for providers to refer to the booster dose recommendations for persons who are moderately or severely immunocompromised. The last bullet in this section reminds providers to consider pre-exposure prophylaxis in addition to COVID-19 vaccination for persons who are moderately or severely immunocompromised. And the COVID-19 vaccination section ends with a note referring providers to additional resources on COVID-19 schedules and emergency use authorization indications for these vaccines. We'll now move on to the hepatitis B section. As you're aware, hepatitis B vaccination is routinely recommended for all adults 19 through 59 years of age. The descriptions of the 2, 3, and 4-dose series are provided here in the routine vaccination section. Compared to last year's schedule, these descriptions have been slightly revised. Any reference to the 4-dose series for persons on hemodialysis has been moved to the special situations section, which we'll see later in this Hep B section. Prehevbrio was also added to the description of the 3-dose series. And the note at the end of this section states that Heplisav-B and Prehevbrio are not recommended in pregnancy due to a lack of safety data in pregnant women. The hepatitis B section continues on to the second page of the notes. 2 bullets have now been added here describing the recommendations for persons 60 years of age and older. The first bullet states that anyone aged 60 years or older with known risk factors for hepatitis B virus infection should complete a Hep B vaccine series. And the second bullet states that anyone aged 60 years or older without known risk factors for hepatitis B virus infection may complete a Hep B vaccine series. Risk factors for Hep B virus infection are then listed. Minor edits were made in this section to improve clarity in the language. The hepatitis B notes section ends with a special situation section describing the vaccination regimen for patients on hemodialysis. Moving on now to influenza. A sub-bullet was added to the routine vaccination section for persons who are 65 years of age or older. This sub-bullet states that any one of the quadrivalent high-dose inactivated influenza vaccine, quadrivalent recombinant influenza vaccine, or quadrivalent adjuvanted inactivated influenza vaccine is preferred. If none of these 3 vaccines are available, then any other age-appropriate influenza vaccine should be used. We have added the hyperlink to the 2022-2023 influenza recommendations, and we have a bullet for the 2023-2024 influenza recommendations here as well. In the special situations section, we have modified the bullet describing guidance for persons with an egg allergy who experienced any other symptoms other than hives. This bullet now reads that any influenza vaccine appropriate for age and health status may be administered to such patients. If using egg-based IIV4 or LAIV4, administer in a medical setting under supervision of healthcare providers who can recognize and manage severe allergic reactions. We have added a bullet here in the special situations section describing the guidance for persons who are close contacts of patients who are severely immunocompromised. This bullet states that close contacts of severely immunosuppressed patients should not receive live attenuated influenza vaccine. If LAIV is used, they should avoid contact with or caring for such immunosuppressed persons for 7 days after vaccination. We'll now move on to the third page of the notes section, where we begin with the MMR section. The MMR section has only one major addition this year. A bullet has been added referring providers to the guidance that describes administering an additional dose of MMR in the context of a mumps outbreak setting. Finally, because I had mentioned the change in the MMR row in Table 1 earlier in this presentation, I wanted to just mention here that you may consider MMR vaccination for healthcare providers born before 1957 who do not have any evidence of immunity to measles, mumps, or rubella. This is why the overlaying text was added to the MMR row back in Table 1. We'll now move on to the meningococcal section. The only change to the meningococcal section this year is the addition of the guidance highlighted in yellow in this slide. This guidance describes that if the third dose of Tremenba is administered earlier than 4 months after the second dose, a fourth dose should be administered at least 4 months after the third dose. The fourth page of the notes section begins with the pneumococcal vaccination section. Please note that this pneumococcal section does not incorporate today's ACIP vote. Today's vote will be incorporated into this notes section as soon as possible. A bullet has been added to both the routine vaccination and special situations sections, referring providers to the CDC app that providers can use as a resource to help determine a patient's pneumococcal vaccination needs. In light of the ongoing polio response that started this summer, we have also included a new polio section to the notes this year. Although we do state in the routine vaccination section that routine poliovirus vaccination of adults residing in the United States is not necessary, we do provide in the special situations section vaccine recommendations for adults who are at increased risk of exposure to poliovirus. Adults who have no evidence of a complete polio vaccination series should complete a 3-dose series, while adults who have evidence of completing a polio vaccination series may receive a 1 lifetime booster of IPV. Detailed information about these recommendations can be found at the hyperlink presented here. The last section on page 4 of the notes is the Tdap section. Here, minor edits were made in the guidance listed under the special situations section to improve clarity in the language. And this language now states that for persons who previously did not receive the primary vaccination series for tetanus, diphtheria, or pertussis, they should receive 1 dose of Tdap followed by 1 dose of TD or Tdap at least 4 weeks later, and a 3rd dose of TD or Tdap 6 to 12 months later. We'll now finish with the final page of the notes section. A few changes were made to the zoster section this year. A note was added at the end of the routine vaccination section, providing some background on serologic evidence of prior varicella. This note reads, serologic evidence of prior varicella is not necessary for zoster vaccination. However, if serologic evidence of varicella susceptibility becomes available, providers should follow ACIP guidelines for varicella vaccination first. RSV is not indicated for the prevention of varicella, and there are limited data on the use of RSV in persons without a history of varicella infection or varicella vaccination. In the special situations section, the language in the immunocompromising conditions bullet has changed. This bullet now clarifies that immunocompromising conditions include persons living with HIV regardless of CD4 count. Additionally, the zoster vaccine regimen is provided here, along with a hyperlink for providers to learn more. Finally, a note has been added at the end of the special situations section to provide some background for persons with immunocompromising conditions who do not have a documented history of prior varicella infection, varicella vaccination, or prior herpes zoster. This note reads, if there is no documented history of varicella infection, varicella vaccination, or prior history of herpes zoster, providers should refer to the clinical considerations for the use of RSV in immunocompromised adults aged greater than or equal to 19 years and the ACIP varicella vaccine recommendations for further guidance. And that resource is hyperlinked here. Let's now turn to the appendix section that lists all of the contraindications and precautions to each of the adult vaccines. To see changes in the appendix section, let's zoom in and look at the subsections on this appendix in detail. The first change is to the header of the appendix table, where we have changed the header of the contraindications column to contraindicated or not recommended. And just like last year's appendix, the first page of the appendix lists all of the contraindications and precautions to the influenza vaccines. You will notice that the precautions column no longer lists having an egg allergy in the precautions column, since any influenza vaccine appropriate for age and health status may be administered to persons with an egg allergy. The second page of the appendix lists all of the contraindications and precautions to all of the non-influenza vaccines. Again, let's zoom in here to see the edits to the second page of the appendix. In the Hep B row, the language regarding pregnancy has changed. The language now reads that Heplisav-B and Prehevbrio are not recommended due to the lack of safety data in pregnant persons. Use other hepatitis B vaccines if Hep B is indicated. The language for the pregnancy row, the language for pregnancy in the HPV row has also changed. The language now states pregnancy HPV vaccination not recommended. With that, I'd like to thank you all so much for your attention, and I'll pause here for any questions. Thank you all so much.
Thank you, Dr. Murthy. This presentation is now open for questions. I actually have two for you. One is on the slide that, oh my goodness. Actually, I'm going to see if anybody else has questions because I want to find it for you. Oh, no. Sorry. That was a lot of slides. On slide, I think it's 65 in our PDF, Table 1, Hepatitis A.
Yes.
My question is really, it says 2, 3, or 4 doses depending on vaccine, and I'm assuming that's because it's tied to the hepatitis B vaccine, but are we really recommending 4 doses of hepatitis A vaccine?
This is just to accommodate for the dosing regimen if you use Twinrix. So that would also confer protection with hepatitis A. So that was just to be comprehensive and to include that regimen. That was the reason for that change.
Okay. It might, like, I think from a recommendation standpoint, to me it would be clearer if we said, 2 or 3, and then, but 4 is acceptable kind of a thing. Because I don't believe we have a recommendation for 4. We have a recommendation for the combined vaccine.
Okay. Yeah.
Just to consider.
Okay.
And then my other question was, since COVID vaccines are on the schedule, should we also include them in the contraindications precautions section? Did I miss it? I apologize if I did.
Yeah, yes, we discussed adding that in the table in the appendix, but in discussions with vaccine safety, they are reviewing those contraindications and precautions, and there might be an update before the 2024 schedule. So we decided not to make a change at this time.
Any other questions, Dr. Cotton?
I have a question on Table 2 with the new COVID. So it says see notes for immunocompromised and for various HIV populations. but then it's blank to the right of that. And I guess I would suggest considering putting in the same language as Table 1, where it says 2 or 3 dose primary series and booster, see notes, but just for clarification. Seems like that was sort of left off. I can show you.
Yeah,
I can
that
show
would be
you
helpful.
manually too. I just want a copy and paste.
Thank you, Dr. Cotton. Yeah.
Thank you.
Dr. Goldman?
Thank you. Excellent presentation. I have a question on the note section for hepatitis B. For 60 and above, where it says may receive. For clarification, I think in the past it said anyone seeking protection from hepatitis B. I'm just wondering if we can clear up that language a bit, because it's very vague when it says they may receive it, but why would they receive it after age 60? You know, in the past it's been for seeking protection, so I don't know if we can just clarify that a little for those who don't have the absolute indication of risk versus age. And that's my only concern with that.
Thank you, Dr. Goldman. We can talk to the hepatitis B folks here about that suggestion.
I don't see any additional hands raised. Just to go back to the COVID-19 comment, I think, well, I would appreciate it if recognizing there's constantly dynamic changes that happen, if we could link back to the, at least the clinical guidance or something in the schedule, just so people can look it up and link back to the original.
So there is a link on the, in a box at the very top of the appendix that links providers
perfect.
to the contraindications, precautions for COVID-19 vaccination.
Okay.
But I mean, once, you know, we hope to incorporate that formally as a row in that appendix once we're able to.
Thank you very much. Okay, I can't believe this, but we're not only running on time, we are a little bit early. Are there any additional questions, clarifications? I'll open up to our liaisons. Okay. Well, I'm going to ask that we reconvene at, I'm going to, oh, gosh, we didn't finish, apologies. Dr. Paling.
I would like to make a motion to approve this with the recommendation, with the considerations that have been discussed. Thank you.
Thank you. I got too excited. Do I have a second? I'm going to go with Dr. Sanchez. Dr. Sanchez.
I'd like to second the motion.
Thank you. Is there a vote language that we can just clarify and put up about the adult and childhood immunization schedules, please? We're going to pause on this. We are going to take a 5-minute break, and I'm going to ask people to be here at 25 minutes after the hour, and we'll come back to this. Thank you. Oh, you got it? Okay. I take it back. Don't leave. Here is the language for the vote, just to approve the recommended child and adolescent immunization schedule, U.S. 2023, and the recommended adult immunization schedule, U.S. 2023. So Dr. Paling moved, Dr. Sanchez seconded. Any concerns? Okay, terrific. We have this motion on the table for a vote later today, and we will now break until 25 minutes after the hour. Thank you, everyone.
across to the very end, in the corner. Oh, okay. Yeah.
Okay, so you have your notes here. You got, all right.
You're not on mute.
Oh, we're not on mute.
Thank you, everyone. We'll reconvene in exactly 1 minute. Thank you, everybody. We're going to go ahead and get started with the next session today, which is on respiratory syncytial virus vaccines in older adults. And Dr. Camille Cotton is our work group chair for this particular work group. Dr. Cotton?
Good morning, everyone. So we will initiate discussion of the adult respiratory syncytial virus vaccine. Next slide, please. Next slide, please. Who controls? We are very lucky to have a wonderful adult RSV work group. As you can see, there are various ACIP members, ex officio members. We have a wonderful CDC lead, Dr. Michael Melgar. We have a host of consultants and liaisons, and we are greatly appreciative to everyone for their wonderful input and excellent discussions during the working group. Next slide, please. We also have a whole host of CDC contributors who really have been incredibly helpful developing this knowledge on this vaccine. Next slide, please. And so just to recap, last February, sorry, that should say 2022, we had the introduction to the adult RSV working group. We had orientation to the multiple vaccine products in development to prevent RSV disease in adults. We had an overview of RSV virology and immunology, and also an introduction to the seasonality and burden of RSV disease in the United States. Next slide, please. Recent working group discussions included selection of efficacy and safety outcomes for the review of RSV vaccines for older adults. And we were also fortunate to have two presentations. The first was from GSK on the safety and efficacy of adjuvanted RSV pre-F3 vaccine in adults 60 years and older, and then a presentation from Pfizer on the safety and efficacy of bivalent RSV pre-F vaccine in adults 60 years and older. In addition, we have had some work group discussions regarding potential barriers to uptake of a novel RSV vaccine for older adults. And several of the things that we discussed included a lack of patient and provider awareness of the importance of RSV as a pathogen in older adults. And we think that that will actually be something that we will need to do a lot more education and enhance knowledge and understanding of the importance of this, and that it is in some seasons actually quite similar to influenza, but many providers may not be aware of that overall impact. Furthermore, we have some concerns about vaccine fatigue, given that there have been multiple COVID-19 boosters. We are also expanding pneumococcal vaccines and the ongoing need for influenza vaccines, et cetera, et cetera. So there may just be some vaccine fatigue out there. In addition, there is some increasing complexity of the adult immunization schedule, although we greatly appreciate the work that was just presented at decreasing the complexity or simplifying it, but nonetheless, with each rendition, it is somewhat there's more volume in the adult immunization schedule. And then we also have some concerns about potential either public or provider hesitancy to co-administer RSV vaccine with other indicated vaccines, which may make a vaccine rollout somewhat complicated. So the agenda today is that we will have two presentations, the first from GSK, the second from Pfizer, and then Dr. Michael Melgar will present our work group considerations. Thank you.
Thank you, Dr. Cotton. We'll move on to the next presentation by Dr. Rizkallah on GSK safety and efficacy.
Thank you so much. Just checking that you can hear me okay?
Yes, we can hear you. Thank you very much.
Thank you. Well, firstly, thank you to the ACIP for the opportunity today to present the results from the GSK RSV older adult vaccine clinical development program. Just by way of, we can't see the slides. If you're able to recall those, perfect, thank you. Just by way of introduction, my name is Bishor Rizkallah and I'm the Global Medical Lead for our RSV program. If we can have the next slide, please. Now, the journey to a viable vaccine that addresses the significant burden of disease associated with RSV in adults 60 years of age and older and those with underlying comorbidity has been multiple decades long. It's really with great appreciation and thanks to all of the study participants, all of the site staff, study investigators, the GSK scientists, our R&D organisation that I'm able to present these positive results to the ACIP today on their behalf. Next slide, please. Today, I'll present key results from 3 of our phase 3 studies. Firstly, I will share results from our immunogenicity and immune persistence study, which demonstrate the robust and persistent humoral and cellular immune response following a single dose of the vaccine. Then I'll present results from our pivotal efficacy study, which demonstrates the high and consistent efficacy of the vaccine candidate across the full spectrum of RSV disease, regardless of RSV-A or RSV-B subtypes. This study also demonstrates the vaccine is well tolerated with a favorable safety profile. I will then present immunogenicity results from our RSV and flu QIV co-administration study, which supports the co-administration of these 2 vaccines. Next slide, please. To begin, I will review the final formulation of the vaccine selected and used in our phase 3 program. Our vaccine is an antigen adjuvant combination that is designed to induce both a robust humoral and cellular mediated immune response to help protect older adults and those with underlying comorbidity. Our vaccine targets the RSV F protein and is engineered to maintain the pre-fusion conformation of this protein. 120 micrograms of the RSV pre-F3 antigen is combined with our AS01E adjuvant system to help boost the RSV CD4 T-cell response in older adults. This is the same adjuvant system that's used in our GSK shingles vaccine. However, the AS01E that is used in our RSV vaccine contains half the dose of adjuvant. Next slide, please. Moving now from our formulation to the immune response elicited by our vaccine, I'll present results from our immunogenicity and immune persistence study, Study 004. Next slide, please. As a summary of the design of the study, this is an open label study that evaluates the immunogenicity, safety, reactogenicity, and persistence of the immune response following a single dose of the vaccine in adults 60 years and older. This study evaluates the immune response of varying vaccination schedules as denoted by the 3 arms that you can see on the slide. The study is ongoing and today I'll present data 12 months following initial vaccination. Next slide, please. This slide summarizes the immune response from varying perspective 12 months following the administration of a single dose of our vaccine. The 2 panels on the left describe the functional antibody responses with RSV-A NAb titers on the very left, RSV-B NAb titers in the middle, and looking specifically at the RSV polyfunctional CD4 T-cell response on the very right. There are 3 data sets in each of the panels which denote the immune response by different age strata. So those that are 60 to 69 years of age, those that are 70 to 79 years of age, and those 80 years of age and older. The vaccine induces a robust humoral and polyfunctional CD4 T cell response as seen by the peak 30 days following vaccination. This immune response is sustained over the 360 days following a single dose of the vaccine to levels well above those pre-vaccination in all the age groups. This data supports that the vaccine is able to induce a robust and persistent immune response consistently across the broad spectrum of age in this older adult population. Next slide, please. Moving now from immunogenicity to efficacy, I'll take you through the results of our RSV 006 study. Next slide, please. Our ongoing pivotal efficacy study will evaluate the efficacy and safety of our vaccine over the course of 3 RSV seasons. Today, I'll present data following the first RSV season, as you can see denoted on the slide with current analysis. Approximately 25,000 study participants aged 60 years of age and older were recruited across 17 countries. Participants were 1-to-1 randomized to receive either an RSV pre-F3 vaccine or to receive placebo. The primary endpoint of the study is to demonstrate the efficacy of a single dose of our RSV vaccine in the prevention of RSV-associated lower respiratory tract disease in this first RSV season. Through the subsequent 2 seasons of the study, we'll be also able to demonstrate the efficacy of a single dose of our vaccine over the 3 RSV seasons, but also to be able to demonstrate the efficacy of our vaccine when administered annually. Lower respiratory tract disease in our study is defined as a participant that experiences at least 2 lower respiratory signs or symptoms, of which at least 1 must be a lower respiratory sign, or a participant that experiences at least 3 lower respiratory symptoms. All cases of RSV-associated lower respiratory tract disease were adjudicated by an independent external adjudication committee. Next slide, please. The demographic characteristics of participants recruited are representative of the older adult population. On the left, you can see the demography of the overall population, and in the box in blue on the right, you can see the demographics from the US perspective. The subjects recruited from the US represent 28% of the overall study population. Sites across 23 states and 8 human and health service regions recruited approximately 7,000 study participants. One important detail in the bottom of the slide is that participants with a medically stable chronic condition could participate in the study. Approximately 39% of the overall population had at least 1 pre-existing comorbidity of interest. What this means is a comorbidity that is known to increase the risk of severe RSV disease. So those that have underlying COPD, asthma, congestive heart failure, diabetes, advanced renal or liver disease make up this 39% proportion. Next slide, please. Moving now to the primary endpoint, and it's a real privilege on behalf of my GSK colleagues to present to the ACIP for the first time an RSV vaccine for older adults that has met its primary endpoint through a phase 3 program. Our vaccine demonstrated an efficacy of 82.6% in the prevention of RSV-associated lower respiratory tract disease. There is great confidence around this point estimate, with the lower bound of the confidence interval being well above the pre-specified criteria for success that has been agreed with regulatory authorities. Next slide, please. Continuing from the primary endpoint, we're also able to observe consistently high vaccine efficacy across the full spectrum of RSV disease. Specifically, we observed efficacy of 71.7% in the prevention of RSV-associated acute respiratory illness. This endpoint really casts a wide net to capture broadly upper and lower respiratory symptomatic RSV cases. This is an important result in the context of the millions of symptomatic cases experienced by older adults annually, as presented by the CDC at the June ACIP meeting. Moving to the more severe end of the disease spectrum, we observed very high vaccine efficacy of 94.1% in the prevention of severe RSV-associated lower respiratory tract disease. Although we observed a lower frequency of hospitalizations with 2 cases in the first season, this can be expected due to several reasons. The first season of this ongoing study took place during the COVID-19 pandemic. This is a period when adults enrolled were commonly practicing social distancing, wearing masks, and investigators worldwide reported declines in hospitalizations due to non-COVID respiratory infections. Additionally, this is in the context of the clinical trial setting where there is close follow-up and protocol-defined medical attendance visits. We will continue to collect data to demonstrate the impact on hospitalization and other patient-reported outcomes over the upcoming seasons of the study. Importantly, however, consistently high efficacy of this vaccine across the full spectrum of RSV disease has the potential to deliver clinically meaningful impact on the significant annual burden of RSV disease in older adults. Next slide, please. The high vaccine efficacy against RSV-associated lower respiratory tract disease was observed over the 6.7 months follow-up period. As you can see in this cumulative incidence curve, there is clear separation between the RSV and placebo groups very early, which is sustained over the duration of the follow-up period. This supports the efficacy of our vaccine candidate over the course of an entire RSV season. Next slide, please. Looking now at efficacy in the more vulnerable subgroups, we observed high and consistent efficacy in these at-risk populations, with an efficacy of 92.9% in the prevention of RSV-associated lower respiratory tract disease in the pre-frail population, and efficacy of 93.8% in those with advancing age 70 to 79 years of age, and efficacy of 94.6% in those with pre-existing comorbidities of interest. And these are the comorbidities that are known to increase the risk of severe RSV-associated disease. In the bottom, you can see a call out, which is important. So due to too few cases being observed in adults aged 80 years and older and those that are considered frail, we are unable to conclude vaccine efficacy in these subgroups. In this regard, it is important to evaluate the immune response in these specific subgroups. Next slide, please. This slide shows the immunogenicity data from a subset of participants in this efficacy study by the same age strata that I showed earlier. This demonstrates that the vaccine induces a robust and consistent functional antibody response regardless of the underlying age of the study participant. Next slide, please. The same trend is observed when we look at the immune response by baseline frailty status, with again the vaccine inducing this consistent immune response regardless of the underlying frailty status of the participants. Next slide, please. Looking now at the efficacy by RSV subtype, it's important to note that the high efficacy seen in this study was in the context of an RSV-B dominant season, with almost 2/3 of all RSV lower respiratory tract disease cases associated with an underlying RSV-B infection. However, the RSV F protein is highly conserved across both RSV-A and RSV-B, and the vaccine demonstrates this high efficacy consistently, regardless of RSV-A or RSV-B subtype. Next slide, please. Transitioning now to safety. The study evaluated solicited adverse events following vaccination through the use of daily diary cards in a subset of study participants. This graph shows the local and systemic events for the 4 days following vaccination by event severity. So grade 1 events are shown in blue, grade 2 events are shown in orange, and grade 3 events in yellow. The most frequent local event was pain. The most frequent systemic event was fatigue. Most of these events were mild to moderate in severity, with very low frequency of grade 3 events observed following vaccination. The events were transient, with the median duration of the event subsiding between 1 to 2 days. Next slide, please. Unsolicited adverse events within 30 days in all participants are shown on the left. Most of the events were mild to moderate in severity, with a low frequency of grade 3 events seen within 30 days of vaccination. This is the largest and only placebo-controlled study in our phase 3 program with approximately 25,000 study participants. The rate of SAEs, fatal SAEs, or potential immune-mediated diseases were balanced between the two arms 6 months following vaccination. Of note, there was a single case of GBS observed in a participant in the open-label immunogenicity study that I presented earlier, who has since recovered. The association was temporal in nature. However, with the evidence available, we cannot confirm the diagnosis or exclude an alternative etiology. Importantly, the independent data monitoring committee overseeing this efficacy study have not identified any safety concerns during the regular reviews of unblinded safety data. Next slide, please. Moving now to co-administration of our RSV vaccine with seasonal influenza vaccines. This is really an important feature in the context of the overlapping seasonality of RSV and influenza. This may be an important feature to support programmatic flexibility and implementation of RSV vaccination potentially in the future. The study looks specifically at co-administration of our RSV vaccine with inactivated quadrivalent influenza vaccine. Next slide, please. The primary endpoint of the study is the non-inferiority of the functional immune response of the vaccines when co-administered versus administration of either vaccine alone. A GMT ratio of 1.5 was set as the criteria for success for non-inferiority. The primary endpoint was met with all influenza antigen HI titers and RSV-A and RSV-B lab responses not exceeding the GMT ratio 1 month after vaccination. This supports that our vaccine can be co-administered with inactivated quadrivalent influenza vaccine without immune interference of either vaccine. In light of the ACIP flu recommendations that were made in June for older adults, we're also conducting 2 additional co-administration studies with high-dose and adjuvanted flu vaccines, and we'll present these data as they become available. Next slide, please. So to conclude, the GSK RSV vaccine candidate for adults aged 60 years and older provides high and consistent efficacy across the full spectrum of RSV disease, regardless of RSV-A or RSV-B subtypes. The vaccine induces a robust and persistent immune response consistently across the broad spectrum of age in this older adult population. Supporting programmatic and implementation flexibility, the vaccine can be co-administered with inactivated quadrivalent influenza vaccines. The vaccine was well tolerated with a favorable safety profile. So really to conclude and bring this all together, in the context of the significant annual burden of disease in older adults and those with underlying comorbidity, the GSK RSV vaccine candidate has the potential to deliver clinically meaningful impact for older adults and for public health. We look forward to continuing to work with the RSV Adult Working Group over the coming months. Pending FDA approval, we look to enable access to the vaccine ahead of the 23-24 RSV season. With that, I'll thank you once again for your valuable time today, and we'll stop here for any potential questions.
Thank you very much for that presentation. I see 3 hands raised. We'll go to Dr. Talbot first.
I have to say I'm extremely excited for this vaccine for someone who's done RSV research in older adults for a while. And I'm also excited to see the prevention of acute respiratory illness, because that will likely also have large impacts on hospitalization. So way to go. I had a couple comments and a question. First comment was that really those over 70 and over 80 should have been a much higher number of those enrolled, so that you could actually look at vaccine efficacy in those groups, because those are actually the groups that have the highest morbidity and mortality over the 60 to 69-year-olds. The real question that I have is, there have been a couple cases of GBS reported. Can you talk about that? And were they in the placebo group or the vaccine group? Thanks.
Thank you so much for your question. There was one case of GBS, a single case throughout the program that was observed in the open label immunogenicity study. I'll invite my colleague Peggy Webster, Head of Safety for Vaccines, to make a comment.
Thank you. I just want to do a quick sound check and make sure that you can hear me.
Very clear.
Thank you, Bish. So as Bishoy alluded, the single case of Guillain-Barré syndrome was reported from our open label RSV 004 study. And this was the only case that was observed in the aggregated safety analysis across all studies in the RSV older adult project, with data from more than 15,000 exposed participants. For this particular case, the investigator considered that there was a reasonable possibility that the event was associated with the RSV older adult vaccine. With the information we received, the case met the third level of diagnostic certainty according to the Brighton Collaboration case definition of GBS. It did occur within the risk window for GBS as a vaccine-related reaction. However, the clinical signs and serological parameters reported to us can be present in several neurological disorders, and neither a neurological consultation or electrophysiologic testing were reported. Additionally, it was not reported if alternative causes for the participants' symptoms were investigated. As such, the company concluded that the reported information was not sufficient to either confirm the diagnosis of Guillain-Barré syndrome or exclude possible alternative etiologies. And again, as Bishoy noted during his presentation, the participant fully recovered.
Thank you. Next, we'll go to Dr. Paling.
Oh, to me?
Yes, Dr. Paling, yeah.
Oh, I'm sorry. I heard Dr. Cannon. My apologies. All right. So thank you, Dr. Rizkallah, for a fantastic presentation. This is really important, and I'm thrilled that you're doing a 3-year studies. I can report from the children's hospitals across the United States are seeing a very significant early RSV season, and there will be lots of very important data. I also want to applaud the approach of comparing placebo, a 1-dose, and an annual dose. I think this is going to be really important. My question to you is about the adjuvant. Could you please, my question to you is about the placebo. What is the placebo in this study?
It's saline.
It's a saline, okay. And then my second question is, if I understood correctly, the adjuvant is also used in the shingles vaccine. And have you compared persons that have received the shingles vaccine with those who haven't in the trial? And is there any information about getting both? Thank you.
Thank you for the question. So yes, the adjuvant in our RSV vaccine is using the ASO-1E adjuvant system. This is distinct from the ASO-1B that is used in our shingles vaccine, which contains double the amount of adjuvant in that vaccine. We haven't looked specifically at those that have received shingles vaccine in our study. So I can't really make a comment about that today.
Thank you. Dr. Cotton?
Yes.
Apologies, I'm going out of order. Ms. Bata next.
I just wanted to hear a little bit more expansion about the criteria of frailty. The notes here are just too small, and I just would wonder if you could please talk a little bit more about that criteria.
Yeah, thank you for your question. We do have one backup slide in the deck that might help the voiceover here. So slide 25, if you can go to slide 25. Yeah. The frailty was assessed using the gait speed test, but I'll hand over to my colleague, Veronica Hulstrom, who's the head of clinical for the program, to take you through a bit more of the details.
Thank you, Bishop. So basically, as you can see on the slide, we assessed frailty as by a gait speed test. Basically, the test allows 2 lengths of a walk where you have 3 meters or 4 meters, and the participant walks down the hallway through a 1 meter zone for acceleration, a central 4 meter testing zone, and 1 meter zone for deceleration. as you can see illustrated on the slide. Then you can see that the timing is recorded and reported to us in the ECRF and further grouped as follows. So we looked into the fit participants. That is a participant with a walking speed above 1 meter per second or equal. Then we have the pre-frail participants with a walking speed between 0.4 and 0.099 meter per second. And you have the frail participants assessed as participants with a walking speed below 0.5 meter that is not able to be performed the test. And the reason, as you can see, we have also included a few examples, is could be tired but unable, could not walk unassisted, not attempted, and study staff or participant felt unsafe. Or a participant that was unable to understand the instructions. And as you can see that the gait speed test is a component of the short physical performance battery measurements.
Does that help answer your question?
Yes, thank you so much.
Thank you.
Thank you. Now, Dr. Cotton.
Thank you very much for presenting this interesting information. This could really be a significant vaccine for the immunocompromised host community in that they really can suffer from severe, life-threatening, and deadly RSV infections. I know that that population was omitted from this initial from the initial trials, but hopefully, eventually, they will be included and hopefully will benefit from this vaccine. I remain concerned about the case of GBS, especially Guillain-Barré syndrome. Even though it's a different adjuvant, Guillain-Barré syndrome was also seen with Shingrix, and actually the package insert for Shingrix has been amended to include information about Guillain-Barré syndrome. And I'm wondering if the company is doing further work to look at this, or and it's unfortunate that they did not have a neurologic evaluation of that patient with presumed GBS. That's makes things challenging for everybody. But I do remain significantly concerned about this in that the elderly population for whom this vaccine is geared is at higher risk for developing Guillain-Barré syndrome. And when we talk to patients about safety, it's something that is somewhat concerning with Shingrix, and I guess it remains to be seen what the overall outcome will be with this, but I am concerned, and I'm wondering if the company has thoughts about whether it could be related to adjuvant in that both of those vaccines are adjuvanted.
Thank you for your question, Dr. Cotton. I will invite my colleague, Peggy Webster, to comment.
Yes, thank you, Dr. Cotton, for your question and for your comments there. So yes, last year, the findings from a post-marketing observational study among the US Medicare beneficiary population, which was performed to evaluate for an association between vaccination with Shingrix and GBS, Guillain-Barré syndrome, those were published. And the primary analysis, which was claims-based and included all doses, found a slightly increased risk of Guillain-Barré syndrome during the 42 days following vaccination with Shingrix, with an estimated 3 excess cases of Guillain-Barré syndrome per million doses administered. The benefit-risk balance remained in favor of vaccination, as Shingrix is efficacious in decreasing the risk of herpes zoster and its complications. The analysis that was performed by the CDC, CMS, and FDA was robust and provided new and significant safety information for Shingrix about a potential risk that is serious or otherwise clinically significant, and therefore has implications for prescribing decisions or for patient management. The company continues to closely monitor reports of GBS associated with Shingrix vaccination through proactive enhanced pharmacovigilance. And incident cases of GBS are being measured as one of the objectives of an ongoing targeted safety study. We would be happy to follow up with the working group after the meeting to provide a response with additional information regarding the safety profile of Shingrix if that's desired.
Thanks. I think that that would be very helpful for us to have that information. Furthermore, so it's good to hear, I guess, that there will be more, purely with respect to the trial, that there'll be hopefully more RSV disease activity this year so we can better analyze the vaccine. I guess I remain concerned that there were overall very small numbers of patients who developed RSV infection, and then what the impact would be on the data. I don't think that the company can really answer that question, other than we all remain concerned that the overall numbers of infected patients was quite low.
Thank you for the comment, Dr. Cotton. I'll invite the head of our R&D organization, Dr. Phil Dometer, to make a comment.
I think it's important to distinguish between the number of overall cases of RSV illness and severe RSV illness. We actually had quite a good number of cases of RSV illness. There were relatively few hospitalizations, however, and cases of severe illness. We will be following through the successive 2 seasons, so expect to accumulate much more data over the course of those 2 seasons.
Thank you.
We'll go next to Dr. Chen.
Yeah, congratulations for the positive efficacy signal. I think it's really exciting for the RSV vaccine field to see, a successful candidate. I think I'll just reiterate some of the comments that you've heard from some of the other members, is that it would be nice to see this kind of efficacy in frailer older adults, to also kind of make sure that we can understand the efficacy of this vaccine in older adults that have limited independence, as opposed to what this population looks like, are mostly persons who are able to, again, be fit or fall into the pre-frail category. Certainly, nursing home, homebound population of older adults continue to be a concerning part of the population that suffer from the burden of RSV disease. So just continuing to look at older adults with also multiple chronic medical conditions, the immunocompromised, again, will be very helpful for us to understand the efficacy of this vaccine. Thanks.
Thank you so much for your comment. The frail population, as assessed by the Gates speed test, represents approximately 1.2% of the recruited population. So we haven't been able to accrue enough cases to be conclusive on the efficacy there. However, when you look at the efficacy in the pre-frail population, which was observed to be 92.9% in our study, you look at the efficacy in those with at least one pre-existing comorbidity of interest, 94.6%, gives us good confidence that this vaccine will infer a protective benefit in these at-risk subpopulations in the older adult population.
Thank you. And we have 5 more hands raised. So I'm going to ask our members to keep the questions brief and the responses brief as well. I'm going to move to Ms. McNally.
Thank you. I'm the consumer representative, and I just wanted to see if you could answer this question for me. Dr. Cotton mentioned that there may be providers who have some reluctance about co-administration of this vaccine with other vaccines, and I wondered if GSK has a response to that.
So we today have demonstrated the immune response when co-administration of our RSV vaccine with inactivated quadrivalent influenza vaccine. There is an extensive program in place that evaluates the co-administration of other vaccines that are used in older adults, starting with a priority those of flu, so looking at high-dose flu and looking at adjuvanted flu. These studies have been posted on clinicaltrials.gov and have initiated recruitment, and we'll come back to the working group with further details of those studies. Now, moving beyond influenza, there will be other co-administration studies in this older adult population that will be initiated, including COVID with mRNA vaccination, which potentially in an endemic context could be potentially used with overlapping seasonality.
Thank you.
Thank you. Dr. Sanchez?
Thank you, and thank you for the presentation. It certainly is exciting news, and hopefully it can spur adults to more respiratory viral testing as many enter my NICUs. But my question is, among those who developed RSV who had received the vaccine, did you see any more severe illness? What was the characteristic of the illness in those patients? And secondly, are you studying at all any prevention of transmission? Are you doing any asymptomatic testing? Will it prevent transmission within the household to others? I presume these adults probably obtained it from children, but I think to look at other modes of transmission would be important. Thank you.
No, thank you so much for your question, Dr. Sanchez. So the trigger for this study is symptomatic disease, both upper and lower respiratory tract disease. That's our ARI definition, and that's the trigger. So we haven't looked at asymptomatic cases. This is acute respiratory illness as the trigger. But to answer your question about medical utility or medical attendance, we do have a study, a slide in the backup, slide 32, if we can call that up. But it's a very good question. So slide 32. Excellent. The previous one. This is excellent. So this is looking at medical attendance beyond the protocol defined visits in the study. And on the left, you can see the RSV pre-F3 arm, and on the right, you can see the placebo. This is looking at those participants that experienced a ARI or a lower respiratory tract disease, looking at the number of those participants that requested or required additional medical attendance. So if you look at the ARI arm, for example, in the active arm, 29% of participants experiencing an ARI sought additional medical attendance. Those in the placebo, 40% sought additional medical attendance for an ARI-related visit, diagnosis. For those with lower respiratory tract disease in the vaccine arm, 42.8% sought additional medical attendance compared to 60% in the placebo arm. We also have patient-reported outcomes, which has demonstrated a symptomatic benefit in these cases in the active arm.
Actually, Dr. Sanchez, I'm going to move on. We have 2 quick questions, and we have another presentation, and I still need to get us done on time today. So Dr. Lair, Dr. Long, and then we're going to move on to the next session.
2 clarifications. You said this is engineered antigen. Is that recombinant engineering?
Yeah, I'll invite my colleague, Phil Dormitzer, head of R&D, to make a comment.
That is correct. There are mutations in the protein sequence to stabilize it in the prefusion conformation. These are the mutations developed at the NIH as part of their DS1, which was the prototype for this vaccine.
And on slide 12, you have a list of, on the right-hand side, the cases of placebo. Are those all 3 cases, 3 lines separate? So when you have 95 ARIs and 40 LRTDs and 17 severe, are those 3 separate categories, or the severe subset of the LRTD is subset of the ARI?
Thank you for your question. I'll invite my colleague, Veronica Hillstrom, head of clinical, to make a comment.
Thank you. Just to kind of make sure that I understood the question correctly. The question was whether or not the RSV-RE vaccine efficacy was containing the subset of the remaining.
Is there overlap in the cases? So yes.
No.
Yes.
No, actually, my question is more, if I count the placebo groups, I could either have 3 different groups adding up to about 150, or I could have 1 group of 95 and then 2 subsets.
So it is a subset, yes.
Thank you.
So it is a subset, thank you. So it's the 95 cases that experienced, according to the definition of ARI, of which 40 went on to be classified as lower respiratory tract disease, of which 17 were considered severe.
Thank you.
Thank you, Dr. Long. Last quick question.
Yes, do you have information on all-cause acute respiratory illness or lower respiratory tract disease to answer the safety question that this is not detrimental for other infections, or possibly is it helpful and the burden is underappreciated? And did you have anybody in this group that had coronavirus infection, and how did they do?
Thank you for the question. For the coronavirus, I believe we do have a slide in backup. Let me just...
I don't know the number for that. So maybe based while you're finding the slide is, we also looked into vaccine against any ARI on the efficacy, where we did not observe any effect of the vaccine. So it was...
Yeah, I don't have the slide in backup in terms of the COVID, but from memory, it was about 0.5%.
For COVID, we did not analyze per COVID occurrence group as such. So we have not done that subgroup analysis.
But thank you for the question.
I just want to clarify really quickly. Dr. Long, your question was, were there any cases of RSV in the LRTI? Is that essentially it? Yeah. Do you know what proportion, where are these all? These are all RSV related. Not
yes,
all
they
cause.
are. So,
okay.
They meet the definition for ARI. They go on to be confirmed as RSV associated by RT-PCR.
Okay. Thank you.
And looking beyond at other respiratory viruses, that was not part of the design of the study.
Okay, thank you very much. All right, we'll move on to the next session. And thank you very much for your presentation, and really great to see this data. We'll move on to a presentation by Pfizer. Dr. Gertman will be speaking about the safety and efficacy of bivalent RSV vaccines in adults 60 and older.
Good morning. I'm just checking that my voice comes across.
Yes, we can hear you. Thank you.
Thank you very much.
And sorry, could you please give me the sharing privileges, please? Oh, I see it now. Thank you. Can the slides be seen, please? Can you confirm?
No.
Are they showing?
Nothing showing.
This is Michael Melgar, the CDC lead for the work group. Give us 1 second to give control.
Okay.
Dr. Snow, you should be able to share your screen now.
Thank you.
Good morning. Thank you to the ACIP for the opportunity to present today. My name is Alejandra Gertman, and I am in the Vaccine Clinical Research and Development Group at Pfizer. I am pleased to present to you the safety and efficacy data for the Pfizer bivalent RSV prefusion F vaccine in adults 60 years of age and older. The Pfizer RSV pre-F consists of bivalent stabilized prefusion F proteins based on prefusion F conformations from the RSV-A and RSV-B strains. RSV pre-F elicited high neutralizing titers for both RSV-A and RSV-B in phase 1-2 studies that initially supported both of our targeted indications, which include maternal immunization for the prevention of RSV lower respiratory tract illness in infants, and active immunization of older adults for the prevention of RSV-associated lower respiratory tract illness. Our older adult clinical development program has been comprehensive and includes adults 18 years of age and older in 6 different studies. We tested 3 dose levels with and without aluminum, and also formulations with and without CpG. Early on, we demonstrated that RSV pre-F was immunogenic in a non-adjuvanted formulation, and adding aluminum or CpG conferred no immunological benefit. The final dose selected is 120 micrograms containing 60 micrograms of A and 60 micrograms of B strains, and the vaccine is unadjuvanted. For this presentation today, I will focus on the results of our phase 3 pivotal efficacy study. RENOIR, which is the vaccine efficacy study in older adults, is a global phase 3 study designed to evaluate efficacy, immunogenicity, and safety of the bivalent Prefusion F subunit vaccine. The RENOIR study is being conducted at 240 sites in 7 countries, including the US. The study is targeted to enroll up to 40,000 participants 60 years of age and older. Participants are randomized 1-to-1 to receive either RSV pre-F or placebo, and randomization is stratified by age. Participants are eligible if they are healthy or have stable chronic conditions, including stable cardiopulmonary disease, diabetes, asthma, or COPD. Immunocompromised persons or those who have serious chronic disorders are excluded. Regarding safety monitoring, a subset of participants completed a daily e-diary to monitor local reactions and systemic events for 7 days after vaccination. Unsolicited adverse events are captured through 1 month after vaccination in all participants, and serious adverse events and newly diagnosed chronic medical conditions are captured through the end of the study. In addition, all participants undergo active surveillance for acute respiratory illness by completing a weekly e-diary. If acute respiratory illness symptoms arise, participants perform a self-nasal swab and they contact the investigational site. The site conducts a clinical assessment capturing details of any ARI symptoms. Depending on the investigator's judgment, the illness visit may be conducted in person or remotely. When an in-person visit is completed, an additional nasal swab is collected. Finally, a subset of participants have blood draws at 3 pre-specified time points to assess immunogenicity. I will not be presenting that data today. Now, I would like to describe the key study definitions, starting with acute respiratory illness, which is defined as having one or more of the following symptoms lasting more than 1 day: nasal discharge, nasal congestion, sore throat, cough, sputum production, wheezing, or shortness of breath. These are the symptoms for which all participants complete the weekly e-diary surveillance entry, which triggers the self-nasal swab and the contact with the investigational site that I described to you on the prior slide. Lower respiratory tract illness is an acute respiratory illness with 2 or 3 signs or symptoms of new or worsening cough, sputum production, wheezing, shortness of breath, or tachypnea. And severe LRTI is defined as LRTI plus at least one of the following objective criteria: hospitalization due to RSV, new or increased oxygen supplementation, and new or increased mechanical ventilation, including CPAP. I will not be presenting today an analysis on severe illness, as we didn't accumulate enough severe cases at the time of this analysis. A case definition of RSV-associated ARI or RSV-associated LRTI is made when a participant has at least 2 or 3 symptoms or severe illness and a positive validated RSV PCR test. Now that I described to you the study definitions, I would like to go over the study objectives of the study. For safety, the objective was to describe the safety profile of the RSV pre-F vaccine. The primary efficacy objective was to demonstrate the efficacy of RSV pre-F in preventing RSV-associated lower respiratory tract illness with at least 2 or at least 3 signs or symptoms in the first RSV season following vaccination. There are several secondary efficacy objectives, including efficacy against RSV-associated acute respiratory illness and severe RSV-associated LRTI in the first season. Additional objectives include efficacy of the vaccine in the second season and across 2 seasons. The focus of today's presentation is safety, LRTI, and ARI. As with many vaccine efficacy studies, RENOIR was designed as a fixed event trial. The analysis I'm presenting today was a per-protocol pre-planned interim analysis. For the endpoints I'm presenting today, these are considered the final analysis. We have agreement with regulatory agencies on licensure criteria, including vaccine efficacy with a lower bound of at least 20%, as well as agreement on the case definitions for lower respiratory illness. We have adjusted the type 1 error for this interim analysis. I will now present the interim analysis results of the study, starting with enrollment and demography. We enrolled 34,284 participants, and they're all included in the safety database. In terms of demographic characteristics, the RSV pre-F and placebo groups were balanced when looking at sex, race, ethnicity, and age. About a third of the participants were 70 to 79, and about 6% in each group were 80 years of age or older. In terms of pre-specified significant conditions, approximately 50% of the participants had one medical condition. 15% in each group had at least one chronic cardiopulmonary condition, and about 19% in each group had diabetes. I will now share local reactions by maximum severity within 7 days of vaccination, which were more frequently reported in the vaccine group than in the placebo group, with a 12.1% versus 6.6% respectively. The most frequently reported local reaction was pain at the injection site, followed by redness and swelling. Most local reactions were mild, lasted 1 to 2 days, and resolved. Systemic events are shown on this slide by maximum severity within 7 days after vaccination. As you can see, the proportion of participants who reported a systemic event within 7 days were similar in the vaccine and the placebo group, with 27.4% and 25.7% respectively. The most frequently reported systemic events were fatigue, headaches, and muscle pain, and were similar across the groups. There was only one grade 4 event of a fever of 40 centigrades on the day of vaccination in a participant who is in the placebo group. Most events were mild or moderate and of short duration. And for unsolicited adverse events from vaccination through the 1-month follow-up, about 9% of participants in each group reported any adverse event. The frequency of related, immediate, severe, and life-threatening adverse events were similar in the vaccine and in the placebo group. At the bottom part of the table, you can see that newly diagnosed chronic medical conditions were also similar in both groups. There were 3 serious adverse events deemed by the investigators to be related to the vaccine, and I will present them to you in the next slide. Adverse events leading to withdrawal from the study or leading to death were similar in the vaccine and in the placebo group. Adverse events leading to death were reported in 52 RSV pre-F recipients and 49 placebo recipients. The primary causes of death most frequently reported were in the system organ class of cardiac disorders, and none of the deaths were assessed as related to the study. As I just mentioned, 3 RSV pre-F recipients reported SAEs assessed as related by the investigator. In the interest of time, I will review them briefly. The first was an allergic reaction in a 61-year-old female 7 hours after vaccination, which resolved on the same day. It was deemed to be a delayed allergic reaction and not anaphylaxis. The second event is a retrospective diagnosis of a Miller-Fisher syndrome in a 66-year-old female in Japan with a limited workup. An anti-GQ1B IgG was negative and no conduction studies were done. This case meets level 4 of the Brighton collaboration. And the third event is a Guillain-Barré syndrome in a 66-year-old male in the United States who developed a non-ST myocardial infarction requiring angioplasty 7 days after vaccination, followed by slow progression of lower extremity weakness and ataxia. The conduction study was consistent with acute demyelinating polyneuritis of the lower extremities, and this case meets Brighton collaboration level 1. All of these cases were evaluated by our external DMC, who didn't identify any safety signal and recommended to continue enrollment into the study. As of today, we have more than 20,000 participants who have been exposed to the vaccine, and we have not seen any additional unexpected serious adverse event. Now I would like to turn your attention to the efficacy of the vaccine. At this pre-planned analysis, when looking at RSV-associated LRTI defined by at least 2 symptoms, there were 11 cases in the vaccine group and 33 in the placebo, with an observed efficacy of 66.7 and a lower confidence interval of 28.8%. For those who had at least 3 symptoms, there were 2 cases in the vaccine group and 14 cases in the placebo group, resulting in vaccine efficacy of 85.7 with a lower confidence interval of 32%, indicating an even higher efficacy against more severe disease. In terms of the difference between the 2 groups, the figure here shows the frequency of LRTI signs and symptoms for the RSV LRTI cases with 2 or more symptoms on the top part of the figure. And this is also displayed at the bottom with 3 or more symptoms or only 2 symptoms. Among the RSV LRTI cases with 2 or more symptoms, cough and sputum production were the most common symptoms reported. But in the dark blue bars, for the cases involving 3 or more LRTI symptoms, wheezing, shortness of breath, and tachypnea were more frequently reported, which is consistent with more severe disease. This slide shows the cumulative case accrual curve from day of vaccination for RSV-associated LRTI with at least 2 symptoms. The blue line is in the vaccine group, and the gray line represents the placebo group. Vaccine efficacy is shown after day 15 and persists for at least 6 months, sufficient to cover a typical RSV season. And similarly, this is the cumulative figure for RSV LRTI with at least 3 symptoms. And again, vaccine efficacy also persists for at least 6 months. Vaccine efficacy in those with 2 symptoms at the top or 3 symptoms at the bottom of the slide was consistent across different subgroups, including age and those with pre-specified high-risk conditions. Please note that for each subgroup, the numbers are small and the confidence intervals are a little bit wider. Finally, when looking at RSV-associated acute respiratory illness, RSV-PreF was also efficacious with a case split of 22 cases in the vaccine group and 58 cases in the placebo group, for a vaccine efficacy of 62% with a lower confidence interval of 37%, which indicates that RSV-PreF also protects against less severe disease, primarily upper respiratory disease. On the right side, you see the cumulative curve for acute respiratory illness, where the light blue is the vaccine group and the gray is in the placebo. When looking at efficacy by subgroup A and B across those with 3 symptoms, 2 symptoms, or just ARI, vaccine efficacy was consistent for both strains as well. In conclusion, the interim analysis for the Renoir phase 3 pivotal trial has demonstrated that RSV-PreF was safe and well tolerated. Local and systemic events were mostly mild to moderate and short-lived, and the adverse event profile did not suggest any safety concerns for RSV-PreF vaccination in adults 60 years of age and older. RSV-PreF was highly efficacious in reducing RSV-associated lower respiratory tract illness in adults 60 years and older, and also in reducing RSV-associated ARI in this age group. The study is ongoing, and we anticipate having additional data in the future. I want to conclude my presentation by acknowledging and thanking all of those who make this possible: the clinical trial participants, their families, the sites, our investigators, the CRO, our partners, and their staff. I'm happy to take any questions now. Thank you.
Thank you very much for that presentation. I'm just going to ask my colleagues if you still have a question or if it's residual from last time, if you could put down your signs, and then I'm going to ask the favor that you turn your signs towards me just so I can see them. I have trouble on the angle. Dr. Talbot.
Thank you for the great presentation, and thank you for the very exciting data. Once again, we can prevent ARI, we can prevent hospitalizations. I was hoping you could go back to the slide that showed the numbers of participants by age.
Yes.
So it's great that are testing we're testing a vaccine designed for older adults and older adults, but it is really underpowered for those 70 and above. And I think it's really important when we do these studies, we do them in the adults that we intend to use them in with the most morbidity and mortality. Second thing is I didn't see any data on frailty, which is incredibly important for us to distinguish. VE is higher in those who are not frail and lower than those who are frail. And so that gives us a concept of how well they'll be used and how effective they'll be. My second question is about the GBS Miller-Fisher. You showed those cases. Were those in the placebo or the active component?
Thank you, Dr. Talbot. So to answer your first question, we have about 30% of the participants in the 7 to 79. And I agree that the number on those who are 80 and older is not as good as maybe we will all want to have. As you probably know, it's harder to enroll those subjects in clinical trials. But we studied, we met the numbers that we targeted per protocol. And we will have, hopefully additional data. We will continue to do other studies where I fully agree that it would be good to have more participants who are older than 80. With respect to the GBS and Miller-Fisher syndrome, both cases were in the vaccine. They were active recipients of the RSV pre-F vaccine. The Miller-Fisher syndrome, which, as I mentioned, was a Brighton 4 collaboration, it didn't have enough information to really document, and it has also an alternative diagnosis, potential alternative cause, as this subject developed a sore throat, and what it seems to be like a viral syndrome, approximately 7 to 8 days after vaccination. The second case, which is the GBS, the case is confounded by a participant who had a myocardial infarction, which required a procedure. Immediately after that, he developed, as I mentioned, back pain that progressed to lower extremity weakness. So it's a complicated case as well. And so both cases have potential additional causes other than the vaccine. In the opinion of the company and our evaluation, it's hard to confirm that these cases could have been related to the vaccine.
Yes, but both were in the vaccine group and not the placebo. Correct?
They were not in the placebo.
Okay, and then last question, do you have any data on re-immunization?
So I want to come back to the frailty that you mentioned is something that has not been assessed, particularly in this study. We have data on revaccination from our phase 1/2 study on subjects who received a different dose, was 240 micrograms, and they have been revaccinated a year later. And actually, we see that the GMTs, actually the neutralizing antibody titers, go up again, and I believe that they have a backup if you want to see. But I, in the interest of time, I'm not sure if we want to show that. We anticipate potential revaccination in the study depending on what happened during the second season and the cases that we accumulate.
Thank you. We'll move on to Dr. Paling. And I'll just remind folks, if you can do brief questions and brief responses, we'd really appreciate it.
Okay, 2 quick questions. Thank you, Dr. Gertman. Can you please clarify what is the placebo?
The placebo is a matched lyophilized that looks identical to the vaccine, which obviously doesn't have the active ingredients.
Okay, could you say that a little louder? It was hard to hear in this room. I apologize.
Oh, the placebo is a lyophilized match that doesn't have the active ingredients. It doesn't have RSV pre-F. But it looks exactly the same. It's the same cake, and it's diluted in the same way than the active vaccine.
Okay, so what I wanted to also understand is in the vaccine, we understand that it's a bivalent stabilized prefusion F, but what else is in there? Is there adjuvants or anything else in there? And I'm assuming that the placebo is just whatever is making up the vaccine without the active component. Thank you.
Yeah, so you are correct. The vaccine has no adjuvants. It's just the active ingredients. And as you said, the placebo is exactly the same without the active ingredients.
Thank you, Dr. Sanchez.
Yes, thank you for the presentation. I had a question about the primary outcome on slide 7. And I was a bit confused about the differentiation between the acute and the lower respiratory tract symptoms. If you could explain that. And then my other question is, any enhancement of RSV disease after immunization with the active vaccine? Thanks.
Yeah, so if you can go back to the prior slide, please. Yeah, so the ARI symptoms are the ones that the subject may experience, and they have to last for at least 1 day, and are the ones that you see on the first row. So that is what triggers a swab and a consultation with the investigational site. Once that happens, so once the site is aware that the subject has at least one of those lasting more than a day, the information about the LRTI, which is the combination of 2 or 3 symptoms of what you see on the second row, is collected by the site, and that's what is entered into our information to make the case. Of course, it has to be has to have a positive PCR as well.
So acute would only be one of those symptoms, not one or
Exactly.
more.
For a day, yes.
And then the lower is 2 or more of those.
Correct.
Okay, thank you.
Dr. Cotton.
Thank you very much for your presentation. I had just a small follow-up question about the GBS cases. And in general, we call Guillain-Barré syndrome, we use the term Guillain-Barré syndrome. My understanding is that Miller-Fisher is related to Guillain-Barré syndrome. And can I ask for further specification as to why it was called Miller-Fisher syndrome? Was there something different about that case? Or could it be classified as Guillain-Barré syndrome? And yeah, if you could elaborate on that, and also on the timing of when that occurred. Was it within the first few weeks after vaccine exposure? Thank you.
Yeah, thank you. I would like to invite my colleague, Maria Magdalena Lino, who is the Global Safety Lead for the RSV program, to comment and answer your question.
So as you mentioned, I mean, this was diagnosed as Miller-Fisher because it has mainly ocular features, and respectively has a cranial nerve disorder, mainly the third cranial nerve. And I would like to underline this is a diabetic patient, and this is quite often seen in diabetic patients. Now, regarding the
I'm sorry, it's really hard. Sorry, it's hard to hear in this room. There's an echo. Can you repeat what you said? Sorry for that.
To be, an ascending paralysis or we have to say that the subject, aside of being diabetic, she 8 days after vaccination reported to be with fatigue, sore throat, dizziness, and 3 weeks later then presented with diplopia and paresthesia palm and soles. Another important point to make is that the subject didn't need any therapy and then recuperate completely within a couple of weeks, and did not perform any single diagnosis test to confirm the GBS. And the diagnosis was a retrospective diagnosis, and important to confirm that the only test was done to confirm for the GBS, the GIQ antibodies was negative.
Thank you. I'm gonna, we have one more hand raised, but just, to both Pfizer and GSK, we'll defer to their work group, who I know is going to be asking questions about safety, just to make sure we can capture more details so that we can see that consistently. Thank you very much. And last question to almost last question to Ms. McNally.
Thank you. I'm wondering if you could also provide a response to the potential concern that providers may have regarding the co-administration of this with other vaccines. Thank you.
Ms. McNally, I'm not sure if I got the last part of your question. Are you asking about co-administration with the COVID vaccine?
Yeah, not necessarily just COVID, but yes, vaccines in general.
Yeah, so we have an ongoing study currently, which already is completed, and we will co-administration of flu vaccine, and we expect to have results for those, within the next few months. And we have additional plans to evaluate this vaccine with other vaccines that are given to older adults.
Thank you so much.
Thank you. And last question is, do you have any data on asymptomatic infection or transmissibility? Because I think for all of our respiratory vaccines, it's going to be really important for us to make sure we have information on that. It's been critical for COVID, and I feel like we haven't seen that data, so we're asking for it up front from both companies.
Thank you, Dr. Lee, for the question. At the present time, we don't have data on either one.
Do you have plans to incorporate that in future work?
We will take this under consideration and see if we can execute those studies.
Thank you very much. Okay, with that, we are going to move on to Dr. Michael Melgar, who is going to present on the adult RSV workgroup considerations.
Good morning. My name is Michael Melgar, and I serve as the CDC lead for the work group for RSV vaccines in adults. Today, I'll present a brief summary of the data reviewed by the work group and the current work group considerations. First, here are the current policy questions being considered by the work group. Should vaccination with GSK's investigational RSV vaccine be recommended for all older adults? And should vaccination with Pfizer's investigational RSV vaccine be recommended for all older adults? The definition of older adults should be aligned across the policy questions unless there's a strong reason for a different threshold. Potential age thresholds being considered by the work group include, but are not limited to, 60 years and older and 65 years and older. As we've seen from both manufacturers, vaccine efficacy was largely invariant to participant age in the trials, provided there were enough events to evaluate it in each stratum. Therefore, the age threshold for a policy recommendation must be informed by other considerations. To revisit evidence pertaining to RSV-associated risks by age, here are seasonal rates of RSV-associated hospitalizations among U.S. adults, stratified by age, estimated from CDC's RSV Hospitalization Surveillance Network, or RSVNet, during the 4 most recent RSV seasons before the COVID-19 pandemic. RSVNet provides active, population-based surveillance of laboratory-confirmed RSV-associated hospitalizations at sites in 12 U.S. states. The combined catchment areas are estimated to account for almost 9% of the U.S. population. You can see that hospitalization rates were substantially higher among adults 70 to 79 and 80 years or older compared with younger age groups. Adults 60 to 64 and 65 to 69 experienced intermediate rates of hospitalization. Additional evaluation, including number of hospitalizations potentially averted by vaccination, will be shared with the work group and with ACIP before a policy recommendation is brought forward. Evidence reviewed by the work group to date includes the epidemiology and burden of RSV in U.S. adults, including seasonality, population-based rates of medical visits, hospitalizations, for example, those that I just showed, and deaths, as well as basic RSV virology and immunology, and the safety and efficacy data presented by GSK and by Pfizer. Now I'll discuss the work group's summary and interpretation of the data shared by the manufacturers. Both clinical trials showed significant efficacy against RSV, lower respiratory tract disease or illness, which was the primary endpoint in both trials. The efficacy point estimates exceeded 60%. Notably, efficacy cannot be compared between trials due to differences in outcome definitions. However, in each trial, efficacy estimates were based on fewer than 50 total events of the primary outcome. The table here shows the number of events of the primary outcome by trial and by vaccine or placebo arm. So, why were there so few cases of symptomatic RSV infection? For one, clinical trials often enroll a healthier population compared with the general US population. And also, we know that both trials were conducted during periods of atypical RSV seasonality in the United States, likely attributable to the COVID-19 pandemic. To characterize that a bit better, I'm showing here monthly number of RSV-associated hospitalizations among adults 65 years and older that were reported to RSVNet during the 3 most recent pre-COVID-19 pandemic RSV seasons and during the COVID-19 pandemic. Importantly, RSVNet has historically only conducted surveillance during October to April of each season, which is why the data are disjoint in this figure. Continuous surveillance was temporarily established during the COVID-19 pandemic in response to atypical RSV seasonality. Pre-pandemic, RSV hospitalizations in this population reliably peaked every January. However, there were almost no RSV hospitalizations in January of 2021, and there was an unusual summer rise in hospitalizations, which eventually peaked in December 2021 before dropping quickly. The GSK and Pfizer trial periods are labeled here as well, showing that they coincided with the unusual RSV seasonality. The work group notes that the RSV vaccine trials were underpowered to estimate efficacy against more severe clinical outcomes such as hospitalization and death. There were fewer than 5 RSV-associated hospitalizations in each trial, and neither trial recorded any RSV-associated deaths. However, we know that the burden of RSV-associated hospitalizations is high among older adults in the United States. Here are RSVNet estimates for total RSV-associated hospitalizations among adults 60 years and older in the US occurring during the 4 most recent pre-COVID-19 pandemic RSV seasons. I would note that estimates have wide 95% confidence intervals, but the lower bounds exceed 40,000 hospitalizations during every season. Notably, estimates from the 2 most recent pre-pandemic seasons were presented by Dr. Fiona Havers at the 12th International RSV Symposium in Belfast last month. And RSVNet estimates are conservative compared to published literature. A recent Pfizer-sponsored meta-analysis estimated that at least 106,000 annual RSV hospitalizations in the United States among US adults 65 years and older. Although neither trial can provide efficacy against RSV-associated hospitalization, we might expect efficacy against more severe clinical outcomes to be at least as high as efficacy against the primary outcome. This is based on the trend evident in both trials of increasing efficacy with increasing severity of the clinical outcome, with point estimates of efficacy against lower respiratory tract involvement exceeding those against any acute respiratory illness, and efficacy against more severe lower respiratory tract involvement exceeding that against less severe. Again, due to different outcome definitions, efficacy cannot be compared across trials. The efficacy of either vaccine beyond the first RSV season is unknown. Both trials are ongoing with multiple years of follow-up planned. However, data from only the first year will be available for consideration of these first policy recommendations. There's no established immunologic correlate of protection for RSV, limiting the utility of immunogenicity data in informing duration of protection. The need for revaccination and the appropriate time interval are yet to be determined. The work group also noted that cases of Guillain-Barré syndrome were reported after vaccination with both investigational vaccines. GSK reported no cases in their pivotal phase 3 trial that enrolled almost 25,000 participants. However, they did report 1 case in a different phase 3 study evaluating the safety and long-term immunogenicity of different revaccination intervals with their vaccine. To date, of over 1,650 participants in that trial, all received exactly 1 dose of the vaccine, In other words, none have yet been revaccinated. The case of Guillain-Barré syndrome occurred 9 days after participant vaccination. In total, GSK reported 1 case of Guillain-Barré syndrome among over 15,000 older adults who received their investigational vaccine across all studies. Meanwhile, Pfizer reported 2 cases of Guillain-Barré syndrome, including one which was classified as a case of the Miller-Fisher variant. In their main phase 3 trial, which was somewhat larger than GSK's, the cases had onset 8 and 11 days after vaccination, respectively. Pfizer did not report any additional cases of Guillain-Barré syndrome in their other trials of this vaccine. So in total, there were 2 cases among approximately 26,000 persons who received their investigational vaccine. All cases had onset during the 42-day risk window post-vaccination used in CDC surveillance. However, the significance of 1 to 2 cases observed in safety databases of 15 to 26,000 persons is unclear, and the population-based background rates of Guillain-Barré syndrome are known to increase with increasing age. Notably, RSV infection has also been associated with Guillain-Barré syndrome in case reports and case series, but a causal link has not been established. The work group continues to review and interpret the safety evidence. Finally, uptake of a novel RSV vaccine among older adults will depend on patient and clinician education. The adult immunization schedule, as Dr. Cotton noted, is becoming more complex, including multiple vaccines with revaccination intervals. While RSV is well known as an important pediatric pathogen, it's likely less well known as a pathogen in adults, compared with influenza and with SARS-CoV-2. Therefore, without a dedicated education effort, RSV vaccination has the potential to be deprioritized relative to these other vaccines. And the work group notes that safety and efficacy of co-administration of influenza, COVID-19, and RSV vaccines must be established. The next steps for the work group are to review grade of the evidence for the GSK and Pfizer investigational vaccines, review analyses on the cost effectiveness of vaccinating older adults against RSV, review evidence to recommendations for each investigational vaccine, and to determine final policy questions. The age threshold in the policy question will be informed by each of these pieces of evidence, as well as other considerations. With that, I'd like to thank my CDC colleagues who have contributed to this presentation through review and discussion, some of whom are named here. And I'd like to close with a few questions to our ACIP members. First, are there additional data needed prior to ACIP voting on recommendations for the use of either of these investigational vaccines in older adults? What additional data would ACIP like to see to determine an appropriate age threshold for an adult RSV vaccine recommendation? And are there additional questions that ACIP would like answered regarding an adult RSV vaccination program? And with that, thank you.
Thank you so much. I'm going to ask if there's any key questions people will want to see come back to a future meeting that are critical, because we need to move on to the pediatric section of the RSV vaccines. Ms. Bata.
As we think about the age threshold for recommendation, do we have, and this may have been presented in June, but racial and ethnic breakdown of RSV, because I think we need to be considering the equity aspect of this.
Great. Thank you. Dr. Paley? While you're thinking, I'm just going to, put in a generic plea that, well, welcome to pediatrics in terms of the complexity of the vaccination schedule. The second thing I'll just say is I really hope we can get to a place where we can get an age-based platform that is a lot more straightforward and really focuses on respiratory diseases sort of across the board. Having that data and actually some types of rates would be really helpful. So I'm looking at absolute numbers here and relative rates in another presentation. Having that consistency of that presentation would give me a better sense of the relative burden of these infections. And then I'll end there and see if Dr. Paling has any questions.
The other thing I wanted is if we could help so that we're using the same definition for like lower respiratory tract infection, because the number of symptoms is not really as important to me. And so if we could be able to compare across, that would be helpful to me. And then I would like to see the breakdown on the safety data by age.
Thank you.
Thank you. And while we're on safety data by age, I'll ask for background rates too, as well. Anything else? Dr. Sanchez, thank you.
Thank you. I think in some comment about enhancement of disease after vaccination is important. It doesn't appear to be, but I think we should be able to comment on that.
Thank you very much, Dr. Sanchez. Terrific. Thank you, Dr. Melgar. Thank you for that excellent session. It produced a lot of questions, and it was really great data. So we really appreciate how much progress has been made. We're going to move on to Dr. Long, who is going to present. She is chair of the Maternal Pediatric RSV Work Group, and she will present on the work group activities.
May I have the next slide, please? We have a very wonderful, large work group with many, many questions. It's not exactly pneumococcal vaccine, but the strategies and the policies are as complicated. Dr. Sanchez, Brooks, and Cotton are members of this work group, as well as many liaisons from other groups and from the Centers for Disease Control. So RSV is the leading cause of hospitalizations in U.S. infants. It can infect the small airways and lungs, particularly in infants, and in about 40% of infants who are infected, they will have lower respiratory tract disease. Most infants, or 2/3, are infected in the first year of life, and nearly all by the age of 2 years. Premature infants who are born less than 30 weeks gestation have hospitalizations that are 3 times higher than term infants, and their admission to intensive care unit and need for ventilation is also increased compared with term infants. 79% of children hospitalized with RSV, however, are under 2 years of age, have no underlying medical condition. So although we identify risk groups, we know that all children are in fact susceptible and are susceptible to lower respiratory tract disease and hospitalization. So it is the cause of hospitalization, most common cause of hospitalization is RSV for previously healthy term infants as well. In fact, 2 to 3% of infants who are born are hospitalized for RSV. So the burden of disease and the outcome, the severity of disease is significant. Next slide, please. Am I doing something?
You're good.
I'm sorry. Can you go back slide? When we previously presented to this group, we presented the epidemiology and burden of RSV disease in infants, the seasonality that prior to the pandemic was very tight and repetitive, and now has become slightly different for the last 2 or 3 years, with our worst season in all of my colleagues, both early and more hospitalizations, stretching resources throughout the United States. We talked about the virology and immunology of infection, and we have talked about the safety and efficacy of Nirsevimab. Now, since we've been talking about vaccines, everybody should realize that this is not a vaccine. This is an antibody passive protection. So the initial results of the pivotal phase 3 study in infants born nearer term, above 35 weeks and above, has been presented previously. The phase 2b study in infants born 29 to 34 weeks gestation who would have been candidates for palivizumab, and a phase 2-3 safety and pharmacokinetic study in high-risk infants with chronic lung disease and congenital heart disease. Now, the phase 3 study, the one on the top, was halted, went on hiatus in the middle of COVID because of lack of cases of RSV. So between 20 and 21, it was paused and began again in 21. So today we will have the results of the entire phase 3 study to evaluate. We also will have some second-year data on those phase 3 infants given Nirsevimab in the first year of life, as well as phase 2-3 safety data on infants who have been given 2 doses. Next slide, please. So the back one slide, please. The presentations today will first be from Sanofi, Dr. Christian Felter, and then from our very able work group leader at the CDC, Dr. Jefferson Jones, with comments by Meredith McMorrow. Thank you.
Thank you, Dr. Long. We'll move on to the presentation by Dr. Felter, if we can get his slides up.
Thank you very much. If you could stop sharing your screen and I can bring my slides up. Okay, thank you very much. Hopefully, I'm just going to check. Are you able to hear me okay?
We can, but if you can step a little closer to the mic, that would be helpful.
Not a problem. Thank you very much. To introduce myself, my name is Dr. Christian Felter on behalf of Sanofi, and here with me I have Dr. Tanya Villafana and Dr. Amanda Leach representing AstraZeneca, and we're very pleased to be bringing you this update on Nirsevimab for the prevention of RSV in all infants, and thank you, Dr. Long, for the introduction. Next slide, please. So we're going to go through 2 major portions of this presentation. The first part is going to be a brief background on the studies to set the stage, and then to focus on the new data that is coming from the ongoing clinical trials, as was discussed by Dr. Long. Thank you. Next slide. So to set the stage, the Nirsevimab clinical development program was set over 3 separate studies. So the phase 3 pivotal study, also known as MELODY, which was done in infants greater than or equal to 35 weeks of gestational age. There was the pivotal phase 2B study, which was in infants 29 to 35 weeks of gestational age, and then a phase 2-3 study in the palivizumab eligible population. When we take these studies together as a whole, we see a clinical development program across the entire infant population, which is what is being proposed for Nirsevimab. Next slide, please. As Dr. Long was discussing, the MELODY study, which began in 2019, was impacted severely by the COVID-19 pandemic. We know that RSV circulation did disappear at that time when the non-pharmaceutical measures came into effect. Because the study was intended to run over several seasons, it was put on hold at that point. We went then into discussions with the FDA about the data that we had at that point. And it was decided to move forward with our initial FDA filing based on the primary cohort of the MELODY study. So essentially the first half of the MELODY analysis. It's important to note the MELODY study was intended to include approximately 3,000 infants, 35 weeks gestational age or older. So approximately half of them were in the primary analysis. MELODY enrollment did resume in 2021 and has since completed, and we are here today to present to you the results of that further cohort, so what we term the MELODY all subjects analysis, as well as several other important data points from the follow-ups from this study, as well as the phase 2-3 study in the palivizumab eligible population that is also called MEDLEY. Next slide, please. So this is the data that was presented previously to the ACIP, and you can see here on the left column under the medley phase 3 pivotal study, you can see the results of the primary efficacy cohort analysis. You can notice that the number included in this analysis was 1,490, and you can see that efficacy was demonstrated with the primary endpoint being medically attended lower respiratory tract infection, and you can also see the results of the secondary endpoint, which was hospitalization due to RSV lower respiratory tract infection. So what I'm going to be presenting throughout this presentation is the completion of the MELODY study to see what the study was as it was originally intended. Next slide, please. So the additional data that we will be going through today is the MELODY all subjects analysis. Again, what this is the full 3,000 cohort that was intended for the MELODY study as it was designed through day 151 with regards to its efficacy and safety. And we've also now pooled together the MELODY all subjects data with the phase 2B recommended dose. That phase 2B study, as a reminder, was done originally in infants, again, 29 to 35 weeks of gestational age, and was done with 50 milligrams in all subjects entering the phase 2B study. What was found at the end of the phase 2B study was those infants that were greater than 5 kilograms at dosing did not have a sufficient efficacy response. So moving into the phase 3 study, it was decided that infants that are greater than 5 kilos needed a 100 milligram dose. And further analyses on the phase 2B were taken forward looking only at those under 5 kilograms, the ones that would have gotten the dose that is going to be put forward for FDA approval. In that analysis, we will be looking at efficacy through day 151, efficacy by subgroup. We also have data looking at RSV-A and RSV-B. We're also going to be looking at the follow-up of the primary cohort, so the first half of the MELODY study, into their second year of life. So they were dosed in the first year, and we followed them up through their second RSV season. And then to look at the medley, that again is the palivizumab eligible population who, going into their second RSV season, were given Nirsevimab again. Next slide, please. So now we will be talking about the MELODY all subjects data, so the full MELODY study as it was originally conceived. Next slide, please. So what you see here are the 3 main endpoints of the efficacy through day 151 in the greater than or equal to 35 weeks of gestational age population. What you can see there is consistent efficacy across the different endpoints, and you'll actually see this goes throughout the data that we will be presenting here today, where the efficacy remains consistent and high in between approximately 75% and 80%, which is to be expected when you look at the mechanism of action of this product. It is a directly protective monoclonal antibody, which does not rely on an immune response from the infant that is being protected. So when we look across different endpoints and we look across different cohorts, you see that the efficacy remains consistent across it, as you can see here. From a definition standpoint, and this will be used throughout this presentation, we have medically attended RSV lower respiratory tract infection with or without hospitalization, and then what we have termed very severe lower respiratory tract infection, which means hospitalization that also required either intravenous fluids or supplemental oxygen. Next slide, please. What you see here is an excerpt from the FDA. Oh, sorry, if you go back one slide, please. You wouldn't mind going back one slide, because what you saw there on that slide, very briefly, was an excerpt of the safety data from the FDA filing for the MELODY all subjects population, which showed that across the commonly seen adverse events, if you could, when you have an opportunity to go back one slide, you'll see that the adverse events of rash and pyrexia there were a rash, pyrexia, and injection site reaction were uncommon, which by definition means they happened in less than 1 in 100, but more than 1 in 1,000 subjects. There were no serious adverse events or deaths considered related to Nirsevimab by the investigator, and no anaphylaxis or serious allergic reactions that were attributable to Nirsevimab. And this is supplemental safety data based on the all subjects, the complete MELODY study. Next slide, please. So we have pulled together the all subjects and the phase 2B recommended dose. Again, this is the phase 2B subjects that were less than 5 kilograms that then received the 50 milligram dose, which is the one that is being proposed to be brought forward to essentially look at the efficacy and impact of Nirsevimab across the all-infant population. So next slide, please. To remind why we felt it was okay to do this, you can see that the phase 3 MELODY study and the phase 2B study were complementary and similar in design. This was done on purpose and was intended to be pooled from the beginning. What you can also see in the phase 3 MELODY study is the follow-up that went into the second RSV season, and I will show you the data for that in the near future. Next slide. When this data is pulled together, you can see again the consistent and high efficacy that was seen in the MELODY all subjects data. Here at 79% for the primary endpoint of medically attended RSV lower respiratory tract infection. I would also note that one of the other reasons we see consistency across these 3 different endpoints is our medically attended lower respiratory tract definition that was used in this study was looking at clinically important disease. So essentially, we're looking at small variations across the pathophysiology of this lower respiratory tract infection. So we see, again, consistent results across the different endpoints. Next slide, please. Here, you see a demonstration of that continued high and consistent efficacy. So a line has been drawn there. The dashed line represents 80%. And you can see, depending on the different cohorts and analyses, whether they're Northern Hemisphere, Southern Hemisphere, age at randomization, male, female, the ancestry, the weight, and where they were, we see this consistent efficacy across these different cohorts. You can see here. Next slide, please. We also were able to look in the MELODY all subjects data at RSV-A and RSV-B, and we can see here that Nirsevimab provided similar efficacy across the 2 different subtypes of RSV. Next slide, please. So to look in here, the data that I'm going to be showing you now is those subjects in the primary cohort of MELODY, the ones that were enrolled prior to the pandemic, that were then followed into their second RSV season. So please, next slide. What you can see here is a comparison of the placebo versus Nirsevimab. Do note the randomization of 2-to-1 in the Nirsevimab arm, looking to see if there was any difference in medically attended lower respiratory tract infection due to RSV, or on this slide you can see all-cause medically attended lower respiratory tract infection. And you can see that there is no difference between the 2 different groups. So there is no increase or change in the RSV incidence or severity going into the second season. Next slide, please. Thank you. Just to make a comment about the duration of protection, if you go to the next slide, what we did see was in the MELODY study that there was consistent efficacy demonstrated across the 150 days of the primary analysis. There was not a decline in the efficacy over this period of evaluation. And there is some data that suggests that this efficacy may extend beyond this time frame of 150 days. So there was an analysis of the South African cohort that experienced a delayed RSV season due to the pandemic that showed a hazard ratio of 0.491 out to approximately 1 year. And this is also consistent with neutralizing antibody titers that were done that showed that they were 7 times higher than baseline at essentially a year later in Nirsevimab treated subjects, and that was significantly higher than those that experienced natural infection. Next slide, please. So now to speak about the second RSV season, this is going to be data that we're looking at for those who were dosed a second time because they remained vulnerable to RSV going into their second RSV season. This is distinct from the data that I showed you previously, which was in the healthy infants that were followed into a second season. Next slide, please. So when we look at Nirsevimab, the proposed second season indication that has been submitted and will be discussed with the FDA is for children up to 24 months of age who remain vulnerable to severe RSV disease through their second RSV season, which may include but is not limited to, you can see there, CLD and CHD, which formed the medley cohorts that we had in our study, as well as some other proposed groups that we believe remain vulnerable going into their second season. Next slide, please. So to speak about medley, again, this is the Palivizumab eligible population looking into their second RSV season, and they were dosed again because they remained vulnerable. So this would just be the CHD and CLD cohorts going into the second season. Next slide, please. What you can see here is the safety from the second season. Be aware that the medley study, the study in the Palivizumab eligible population, was a comparative safety and pharmacokinetic study comparing Palivizumab with Nirsevimab. The efficacy from this study was extrapolated based on pharmacokinetic data, which I will show you in the next slide. But what you can see here is the safety for those that were given Palivizumab in both seasons, Palivizumab followed by Nirsevimab, or Nirsevimab followed by Nirsevimab. Again, I will note to you the differences in the cohort size based on the randomization, where you can see the N is 180 for the column on the right and approximately 40 for the others. It was determined that there is no significant difference between the safety in these populations, and we felt that this safety data was acceptable to be bringing forward for the indication that is sought. Next slide, please. What you see here is the pharmacokinetic data, and what that really is looking at the plotting of the area under the curve, or the exposure of Nirsevimab in the different subjects in their different cohorts of the CHD in their second season, CLD in their second season. And the dotted line that you see there is the 12.8 threshold that was determined clinically in the phase 2b study and was actually the basis of the dose selection going into the phase 3 MELODY study. The predetermined criteria of success, as discussed with the regulatory authorities in Europe, was that 80% of the children must be above this efficacy threshold, and actually significantly more were above this efficacy threshold. It's also important to note that going into the second season, since these infants were larger when we got to this season, they were given 200 milligrams of Nirsevimab going into the second season. Next slide, please. So this is my last slide, and just as a conclusion, to state that Nirsevimab has shown consistent and high efficacy and good safety across the different studies and populations that is consistent with the mechanism of action and with the data that has been presented here previously. The new data does confirm the safety and efficacy against medically attended RSV LRTI, as well as hospitalization, across the different cohorts that have been presented, including the MELODY all subjects, has shown consistent data with the primary cohort, and the MELODY all subjects analysis has also demonstrated strong efficacy against hospitalization endpoints with an efficacy of greater than 75%. The efficacy does not wane over the 150 days of the primary analysis, and there's a suggestion of potential extended efficacy, and the efficacy has been extrapolated into the first and second seasons for the eligible populations. The safety profile is favorable with low levels of reactogenicity, and the season 2 RSV cases were low and balanced between the Nirsevimab and placebo groups. And with that, I'll conclude my presentation, and thank you all very much.
Thank you for that presentation. We'll move on to questions from the committee. Dr. Sanchez, do you have your hand up? No. Okay, Dr. Paling.
Yes, thank you, Dr. Felter, for this great presentation. I wanted a clarification on the original MELODY study. I do see that it says you enrolled infants over 35 weeks and older. And so that's late preterm. Could you give us the range of what was included in that? And how many of the children enrolled were considered full term, defined as 37 weeks and older? Thank you.
Thank you very much for your question. I'll pass it over to Dr. Leach.
Thank you very much. We indeed conducted MELODY in children who were late preterm and term. And overall, the enrollment was approximately 85% in the term infant population.
To confirm, 85% in the term population. Okay, thank you.
Right.
Dr. Sanchez.
Thank you for that presentation. Certainly, it's exciting to have an RSV protection for even term babies. But my question is the determination of the level of protection. Can you explain that a little bit further? Because it certainly seems that the levels are higher, continue to be elevated based on a placebo group beyond 150 days, which has a lot of implications for when it can be administered or should. But can you explain a little bit about your level of protection?
Thank you very much for your question, Dr. Sanchez. Just to clarify, are you speaking about the AUC threshold that was shown in the pharmacokinetic extrapolation?
Yes.
Or yes, that one. Yeah, certainly. I can turn that question over to Dr. Leach. I can state as a framing, this was based on the analysis of the exposure data from the phase 2B study, and as I stated, led to the decision of the differing doses of Nirsevimab going into the MELODY study based on the weight. But I'll turn it over to Dr. Leach for further comment.
So when we designed all our clinical trials, they were designed to capture disease data over a full year of follow-up. But we have analyzed, and our primary endpoint was concluded based on the day 151, which is corresponding to the typical length of a season. At this present point in time, we do not have a correlative protection which allows us to accurately predict the duration of protection, but that is something that we are collecting a lot of data on in terms of PK and neutralizing antibody responses. So whereas we are sure that the efficacy extends beyond day 151, we need to have more work to precise this level of protection.
Yes, as well. And if you could look at in the backup slide, slide 27, that is the data from the South African cohort. So that's clinical efficacy data. Again, this was in a season where the season was delayed due to COVID measures that were put into place, and then RSV did return. So this is from South Africa. And what you can see here is that while we were looking at the area under the curve and the exposure, we can see clinically that there is ongoing protection that does seem to last out to approximately 1 year, and that is again consistent with the neutralizing antibody data.
Thank you. I have one last clarifying question, and then we'll go on to Dr. Jones's presentation. So slide 23, I just want to confirm that I understand what is in the second to last row of slide 23, at least in our presentation. Yes, that's it. So at least one serious and/or greater than or equal to grade 3 severity event. It looks like for the last two columns, it's 10 to 11% versus 2.4% in that first column. Could you please comment on what those adverse events are, please?
Yes, I'll turn that question over to my colleague, Dr. Leach.
Give me just looking at the slides closely.
What, did you ask for a certain slide?
No, that's correct. We're just looking at it to make sure.
While you're looking at that, data, I was going to actually, Dr. Lair has one quick question as well related to a slide, so maybe we can answer both at once.
So on slide 12, again, it's a question about subsets. In your groups for placebo and the treatment arms, you have for the placebo 80 LRTIs, 33 with hospitalization, and 20 or something. Are those subsets of the original 80, or are they separate groups?
Thank you for your question. And yes, they are subsets of each other. So what you actually see is an increasingly severe definition going down. So they will all be subsets of each other. So that's why you see the numbers going down as we go there. But as I was stating, even the baseline or primary endpoint of medically attended lower respiratory tract infection were clinically important diseases, which is why we see this consistent level of efficacy across the different ways of looking at it across these endpoints.
Thank you. And while we're moving to, I'm going to actually ask Dr. Jones if you can put up your slides. We're going to, but I would love to have the answer to that question, which is, what are those grade 3 or serious safety events in those columns? And what are the differences really between the Nirsevimab and then the Pelavismab arms?
I don't have the clinical picture pertaining to all those events to hand, but we can certainly provide them to you after this meeting.
Thank you. If you could please provide them to the work group, that would be really helpful, and we'd love to reconsider it. Thank
we'll
you.
take that as an action item, no problem, to share those with you, all of those events.
Thank you so much for your presentation. We'll move on to Dr. Jones, who will be, I hope this is, yes, Dr. Jefferson Jones, presenting on work group considerations.
It's better than him.
All right, good afternoon. We can move to the next slide. So there are two policy questions being considered by the maternal and pediatric work group regarding Nirsevimab. First, should Nirsevimab be recommended for all infants less than 8 months of age entering their first RSV season and all infants born during the RSV season? And second, should Nirsevimab be recommended for children less than 24 months of age entering their second RSV season who remain at risk, increased risk of severe disease? The previous presentation gave examples of groups of children who might remain at risk of severe disease. However, the work group is yet to review the evidence of this list, and I will discuss this more in a later slide. Next slide. We're having a little bit of trouble getting our slides to advance. Bear with us. So the work group has reviewed evidence related to these policies that includes, but is not limited to, the epidemiology and burden of RSV in infants and young children, including RSV seasonality in the United States, and incidence of RSV illness in outpatient settings, emergency department visits, hospitalizations, and deaths, also virology and immunology of RSV, the safety and efficacy of Nirsevimab, including the phase 3 study in infants born 35 weeks gestation or later, both the initial and updated results presented today, the phase 2b study in infants born 29 to 34 weeks gestation, and the phase 2-3 safety and pharmacokinetic study in infants eligible for palivizumab. And this includes, in that last study, both the first and second RSV seasons. Next slide. So in future workgroup meetings, we plan to review evidence to identify children. I think we're on the previous. All right, sorry, I think we're good. Identified children less than 24 months of age entering their second RSV season who remain at increased risk of disease. Review the grade of evidence for both policy questions, and review the evidence to the recommendations framework, including the domains of public health problem, benefits and harms, values, equity, resource use, acceptability, and feasibility. Next slide. So during the February ACIP meeting, we plan on presenting a summary of the grade of evidence, cost effectiveness analysis, and the evidence to recommendations framework in preparation of a potential vote by ACIP for use of Nirsevimab in June 2023, pending licensure of the product. Additional agenda items might be added if additional products become available. Next slide. Thank you, and that's the close of the presentation.
Thank you, Dr. Johnson. Appreciate your efficiency. Are there any critical questions individuals would like to raise so that we can make sure that we address them in future meetings? Yep, Dr. Lair.
So I'm sure you're going to be covering this in grade anyways, but the feasibility of doing this in an outpatient office, because it looks like for all the children who are born out of season in the month before the season starts, I'll be giving them this product. And so how to store it and how hard that is and costs would be very important for the outpatient community. Thank you.
Thank you. I can comment, or we can just wait until next time if you prefer.
Dr. Paling.
Another thing that I'd like to look at is looking at our late preterm and preterms and seeing the difference among those would be very helpful. Thank you.
Thank you. Anything else? Oh, I'll add on to the list of things to consider, just co-administration, because the timing is going to be tough with the RSV season and sort of the durability of protection throughout the season. And I feel like the RSV seasons are all out of whack right now. So, Dr. Cotton?
I'd just like to state in general that for ACIP, it's interesting that we are taking a monoclonal antibody to a vote when we did not vote for Evusheld for COVID-19 protection in immunocompromised patients. And I think we should just have clarity and guidance as to what ACIP does vote on and does not vote on. Thank you.
I think that would be great to discuss next time, and also considering the coverage would be really helpful to understand. Dr. Sanchez?
I just wanted to comment that the studies were done during the study period, concomitant vaccines were allowed. So we do have data on the fact that they were that other vaccines could be given at the same time.
Thank you so much. Okay, I am.
So could I ask a qualifying question on one of those?
Of course.
For the difference between term versus preterm, are you specifically asking about vaccine efficacy, safety, both?
Both, thank you.
Thank you. All right, with that, we are going to promptly reconvene at 1 p.m. Oh, one more thing, Dr. Long.
I just want to clarify, have the CDC clarify, could a product that's not a vaccine be in the Vaccines for Children program?
That's under discussion.
All right, we will reconvene at 1 p.m. for public comment. I hope everybody enjoys their very brief lunch. Thank you, everyone. Apologies, we're getting started 2 minutes late, but I would like to welcome and thank our public comment speakers for addressing the committee today. All the speakers submitted a request in advance of the meeting, and the final list of public commenters was determined via a lottery. For our speakers today, we have a limited public comment period, and in order to make it through all of the listed speakers, it's extremely important each speaker limits his, her, or their remarks to 3 minutes. As a gentle reminder, our committee appreciates diverse viewpoints that are respectful in nature and focused on the issues being discussed at our meeting today. We thank our speakers again, and we look forward to your comments. Our first public comment speaker is Mr. Jack Baker.
Good afternoon. I am Jack Baker with the National Foundation for Infectious Diseases, or NFID. On behalf of NFID, as a longstanding partner of CDC, thank you for the opportunity to address ACIP, and thank you for your valuable work in guiding U.S. immunization policy and protecting public health. My comments today will address 3 respiratory viruses of concern: respiratory syncytial virus, or RSV, COVID-19, and influenza. ACIP has reviewed data on the safety and effectiveness of potential new tools to prevent RSV, which can be serious among both children and older adults. In fact, in the US, RSV is the leading cause of hospitalization among infants and is a major cause of hospitalization and mortality for adults aged 65 years and older. Each year in the US, thousands of young children as well as older adults are hospitalized due to RSV. New RSV prevention tools offer the promise of substantially reducing the burden of RSV. NFID issued a report in January 2022 urging a stronger public health focus on RSV, and we thank ACIP for its work in this area. NFID also commends ACIP for voting to include COVID-19 vaccines in the Vaccines for Children, or VFC program, which makes free or low-cost vaccines available to uninsured or underinsured children. In the US, thousands of children have been hospitalized and hundreds have died due to COVID-19. Vaccines can help prevent those tragic complications. Adding COVID-19 vaccines to the VFC program will help to address disparities in childhood immunization rates. Later today, ACIP will also discuss an update on influenza or flu. A recent NFID national survey of US adults found that although 69% believe vaccination is the best protection against flu, only 49% plan to get a flu vaccine during the 2022-2023 flu season. Of concern, the NFID survey revealed that nearly 1 in 5 individuals who are at higher risk for flu-related complications, including older adults and those with chronic health conditions, said that they were not planning to get vaccinated this season. Likewise, only 29% of US adults at higher risk for pneumococcal disease said they have been advised by a healthcare professional to receive a pneumococcal vaccine. But of those who have been advised, 74% have been vaccinated against pneumococcal disease. All these data underscore the importance of strong vaccine recommendations by all healthcare professionals. Additional information about the NFID survey and other resources are available at www.nfid.org. With new tools on the horizon, we must work to raise awareness about the burden of disease and the importance of prevention through vaccination. But it is not enough to have safe and effective vaccines. NFID stands ready to work with CDC and other partners to promote vaccine confidence and ensure that vaccines are used as recommended. Thank you for your time and attention and for your tireless and dedicated service.
Thank you for your comment. We'll move on to our next public comment speaker, Dr. Robert Edmonds.
Dear committee, my name is Robert Edmonds. I'm an admin of one of the actually smaller tinnitus adverse event focused support forums for COVID vaccines with nearly 1,000 members. The topic is of course of personal interest to me because I developed chronic tinnitus after my COVID vaccination. This adverse event, though, isn't foreign to this committee. A prior member of yours, Dr. Gregory Poland, continues to experience it as well, along with variability after being re-challenged as he has communicated in news sources. So please excuse this somewhat off-topic diversion to discuss tinnitus, a symptom already mentioned on the label of some other vaccines. Note, my following comments are not being made to dissuade vaccination, but to encourage official recognition so as to lead to research and early treatment of tinnitus with COVID vaccination. With that being said, I will now review some important findings to motivate this issue. In a recent WHO pharmaceutical newsletter, we find, quote, the UMC identified hearing loss and tinnitus following COVID-19 vaccination as a preliminary signal, unquote. And in JAMA Odo, about a recent analysis of data from Israel, quote, this study suggests that Pfizer mRNA COVID-19 vaccine might be associated with increased risk of SSNHL, unquote, and quote, patients with SSNHL might experience permanent hearing loss and tinnitus, unquote. Now, while I understand the VSD has not seen a clustering of cases for tinnitus in laryngoscope, and an analysis of TriNet-X analytics network data resulted in a finding that, quote, patients with a predisposition to vaccine-related tinnitus may be more vulnerable after the first dose than after the second dose, unquote. And in Drug and Safety, and another article, but with FDA co-authors, quote, investigation enabled us to discover 2 potentially new A's, herpes zoster and tinnitus, which are yet to be recognized by health authorities, but which have overwhelming statistical support in VARS and are supported by published case reports and studies, unquote. And finally, while the prior papers mostly examined mRNA vaccines and the meeting highlights of EMA's PrAC, we have the statement that they, quote, concluded that cases of dizziness and tinnitus are linked to the administration of COVID-19 vaccine Janssen, unquote. This is supported in part by a 15 versus 4 imbalance in COV 3001 and their later recognition of another COVID vaccine of the same platform having this issue at an uncommon frequency. With these repeated signals for tinnitus, it is beyond time for U.S. federal funding of research into this adverse event for COVID vaccines, and not just to tell us rates, but to investigate mechanisms and treatments. And there may be a treatment for some with quick utilization of corticosteroids after onset, but so many miss out if so. That is why there is urgency for this issue, because we may be able to improve outcomes for others. I therefore call on you to advocate for research and recognition. Let us now help those that follow. Help them find peace and quiet. Thank you for your time.
Thank you for your comment. Our next public comment speaker is Ms. Linda Walsh.
Good afternoon. My name is Linda Walsh, and I thank you for the opportunity to represent the COPD Foundation today. The COPD Foundation is dedicated to preventing COPD, bronchiectasis, and non-tuberculous mycobacterial lung disease. We strive to improve the lives of those affected and seek cures. The COPD Foundation represents more than 16 million Americans diagnosed with COPD and countless more at risk. We strongly support the work of the ACIP and are grateful for the critical efforts required from the group. My purpose today is to strongly advocate for a simplified, age-based vaccine recommendation for the prevention of pneumococcal disease, including pneumococcal pneumonia in adults. While well-intentioned, the current recommendations, including shared clinical decision-making, has generated confusion. The current guidelines are complex and confusing to both patients and physicians. In addition, under the current recommendations, individuals with chronic underlying conditions, including COPD, under the age of 65 are not addressed. Overall, individuals with COPD have more pneumonia, suffer from more severe episodes of pneumonia, experience more hospitalizations, greater burden, and worse outcomes compared to those without COPD. The sentiment around pneumonia on our COPD 360 Social, the Foundation's online community of over 54,000 individuals, highlights the fear of getting pneumonia and the hope that it can be prevented. We understand from the July 2021 ACIP meeting that there has been a demonstrated cost effectiveness of PCV20 without the pneumococcal polysaccharide vaccine in individuals 50 and over and in individuals 65 and over. And the data also suggests a demonstrated cost effectiveness of PCV15 without the pneumococcal polysaccharide vaccine in individuals 65 and over. These data strongly support the COPD Foundation's request that the ACIP implement a simplified age-based pneumococcal vaccine recommendation that also includes a risk-based recommendation for individuals with chronic underlying conditions, including COPD, who do not meet the age requirement of 50 or 65, respectively. Now more than ever, vaccines and protecting lung health is essential. We need to ensure that we equip our community with clear vaccine guidelines that incorporate at-risk populations, including those with COPD and other lung conditions. Thank you for the opportunity to share the impact of your recommendations. We once again stand ready to assist in providing additional information.
Thank you for your comment. Next, we'll move to Dr. Matthew Ojdila, and apologies if I got your name pronounced incorrectly.
Thank you. Hello, my name is Matthew Voidilla, Medical Director for Sobi Inc. Sobi is the authorized marketer and distributor for palivizumab in the United States, which is indicated for the prevention of serious lower respiratory tract disease caused by RSV in specific high-risk infants, those who are born prematurely at less than or equal to 35 weeks gestational age, or those who have hemodynamically significant congenital heart disease or chronic lung disease of prematurity. Based on the public materials from the June 2022 ACIP meeting, we became aware that the maternal pediatric RSV work group is evaluating Nirsevimab for the prevention of RSV disease in all infants. RSV is the leading cause of hospitalization in infants aged less than 1 year in the United States, and the burden of RSV disease is disproportionately higher among premature infants and other high-risk infants with congenital heart disease or chronic lung disease. These factors each contribute to increasing an infant's risk of becoming hospitalized from RSV compared to healthy full-term children. These risk factors are not mutually exclusive. Infants who have any combination of these risk factors may be at even higher risk of hospitalization and adverse outcomes. If RSV prophylaxis becomes available for all infants, it will be important to consider how to manage this smaller but higher risk infant population, as all infants are not the same. According to a 2022 review article by Bowser et al. In the Journal of Infectious Diseases, RSV hospitalizations account for 2/3 of all RSV treatment costs, and the hospitalization of an extremely premature infant costs 5.5 times more than that of a healthy term infant. Reducing hospitalizations would alleviate the large financial burden on the health system caused by RSV disease. Pelavisumab has more than 25 years worth of diverse global safety, efficacy, and effectiveness data demonstrating reductions in hospitalizations and length and intensity of hospitalizations in these highest risk patients. At SOBI, we share the ACIP's interest in protecting the health of all infants, particularly those vulnerable infants who are at the highest risk for hospitalization and developing severe adverse health outcomes from RSV disease. We believe that any new guidance should include consideration of differential risk among different groups of infant populations. Pelavisumab was approved by the FDA for demonstrated efficacy in reducing hospitalization across those highest risk groups of infants less than or equal to 35 weeks gestational age, those with hemodynamically significant congenital heart disease, or those with chronic lung disease of prematurity. Existing and emerging data characterize these differential risks and the beneficial impact of pelavisumab in reducing hospitalization of these highest risk infants. As the ACIP evaluates new modalities for the prevention of RSV disease, we believe pelavisumab should be referenced within clinical considerations that are published along with any ACIP decision, specifically addressing its use for protecting those highest risk infants less than or equal to 35 weeks gestational age, those with hemodynamically significant congenital heart disease, or those with chronic lung disease of prematurity. Thank you for your time, attention, and the opportunity to speak today.
Thank you for your comment. Our next public comment speaker is Mr. Noah Louis Ferdinand.
Thank you. This is Noah Louis Ferdinand. I'm the communications coordinator for Voices for Vaccines. I wanted to talk about the COVID-19 vaccine for kids and the decisions surrounding it. This is a topic that has become mired in a lot of politics, including mandates, which I just want to make clear the CDC does not have jurisdiction over, but I want to move past that. We all understand that COVID is less of a risk to kids than adults, but that does not mean no risk. We know that somewhere north of 100,000 kids have been put in the hospital by this disease, and the exact number matters less than what that means in the real world. I wanted to give some examples from my local area, Metro Detroit, where I spent much of the pandemic. The city of Detroit has produced data showing parents feel less comfortable going about life than people without children, whether or not they themselves are vaccinated. To quote the report, this suggests that vaccine hesitancy does not reflect doubts about the seriousness of COVID-19. In Flint, just north of me, the public health manager has also told me they've had trouble getting kids vaccinated. But here again, that does not mean COVID isn't having an impact. And much to the contrary, their schools were closed for in-person instruction this past winter into February. Now, we all agree that's an issue, but it's also not some arbitrary decision. It's the reality that you take a district that has plenty of challenges already, and then you add a surge of disease. We have good evidence that says even a case of flu can cost hundreds of dollars in a household with kids in terms of lost productivity, medical costs, and other things. That is not easy to deal with. And COVID is, of course, much more contagious, much more disruptive and costly than flu is. We have hard evidence that it did cause disruption in these cities just from what happened. So the question we have to ask ourselves is, if we're serious about making things feel normal, how do we actually support communities across the country in dealing with COVID going forward? Because it's not going away. I think removing barriers to protection and increasing access is a key step, which is exactly what adding the vaccine to the Vaccines for Children program does. I finally want to address this point that it's not worth vaccinating kids because the risk is low. And when I hear that, I just have to pause and make sure we really have thought through what we're saying. I met a parent just 2 weeks ago who actually lives a few minutes from my house. His name is Zachary Yaksik. He's someone who lost his daughter Alana to influenza because she wasn't recommended to get the flu vaccine back in 2003, kind of with that same thinking that she was low risk. Later, the recommendation would expand. Alana's tragic death happened almost 2 decades ago, but that is obviously not something that leaves you as a parent. Zachary's been advocating in my city and others around us for almost 20 years to get other kids vaccinated, so it is clearly having an impact in his life and that of the people around him. These things do matter, right? In real world communities, we try to look out for each other. We're not just going to ignore the impact of a disease. And so I think the want to protect ourselves and each other has to take precedence over politics and secondary considerations. I appreciate ACIP's dedication to making the protection more available and more accessible for everyone. Thank you.
Thank you for your comment. Next, we have Mrs. Kim Freitas.
Good afternoon. My name is Kim Freitas, and I spoke about COVID at a meeting exactly 2 years ago. Everything the experts raised as concerns during the meeting was completely ignored, and these avoidable issues have tragically come to fruition. Efficacy, transmission, informed consent, viral priming, ADE, transparency with data, to name a few. It is a complete shame that you open these meetings up for public comment, yet you never consider what is presented, although you claim that is the intent of public comment. What is even more concerning is the amount of safety signal data that has come out of your reporting systems, which is being blatantly ignored. At what point does this committee become liable for their negligence? These EUA COVID injections cannot be added to the childhood schedule. First, it is not FDA approved. Our children should not be receiving them, let alone the adult population. The data clearly has shown that more kids are damaged by the injections than the virus. Myocarditis is not rare nor mild. It's extremely dangerous because the inflammation caused by the injection actually creates scar tissue on the heart that is not repairable. We already know this injection does not prevent infection or transmission, which makes all of us question why it's even being classified as a vaccine or being presented to this committee. This is not a vaccine. The definition of a vaccination is the act of introducing a vaccine into the body to produce immunity to a specific disease, until, of course, the CDC changed the definition on its website in 2021. It is time to stop with this morally and ethically wrong approach to a virus with such a high recovery rate. If you did not know it 2 years ago, you certainly do now. It is time for this committee and agency to pivot away from these dangerous and deadly injections and acknowledge that despite the heavy censorship, enough data has been shared and confirms that this injection is the most dangerous and least effective in history, more so than all the others combined. The strong push behind a product that has failed miserably makes us all question the motives behind this committee and agency. I am here today on behalf of all who have already been injured and killed from this injection, and for our children, demanding that you obey your Hippocratic oath and cease from doing any more physical harm and moral harm to all you recommend the pseudo vaccine to. The VAERS and VSafe data both have confirmed that this injection needs to be pulled off the market immediately. We need autopsies performed on every single person who received the injection and died suddenly, unexpectedly, or with unknown causes. We need to be forming committees with embalmers, pathologists, and every medical professional who has witnessed the massacre that has taken place since the rollout of this injection. Until then, we will not allow our children or families to be part of the biggest human experiment ever. In closing, I recommend this committee, I remind this committee of the Nuremberg trials.
Your time has
There
expired.
are consequences for crimes committed against humanity.
Thank you for your comment. With that, our public comment session has ended. I want to thank all of our public comment speakers today. We are going to move on to the next session, which is now the vote. So I'm going to ask if our team can please put up the vote language on the screen. This is for the adult and childhood immunization schedule. There's a motion on the table, which we'll review. Thank you, everyone. We're going to ask everyone to put on their cameras. And I'm going to ask first if there's any clarifying questions about this motion to approve the recommended child and adolescent immunization schedule and the recommended adult immunization schedule for 2023. I don't see any hands raised at the moment. And do we have everybody on screen? Dr. Sanchez, can you go on screen? Are you able to put on your camera? Dr. Brooks, if you can go on camera as well. Thank you. Okay, I'm going to start with our Okay, do we have everybody in? Thank you very much. We'll proceed with the vote. So as a reminder, please state your name, whether you have any conflicts of interest, and your vote. And I'm going to start right now with Dr. Bell.
Bell, no conflicts, yes.
Thank you. Ms. McNally.
McNally, no conflicts, yes.
Thank you. Dr. Lair.
Lair, no conflicts, yes.
Ms. Bata.
Bata, no conflicts, yes.
Dr. Brooks.
Brooks, no conflicts, yes.
Dr. Daly.
Daly, no conflicts, yes.
Dr. Sanchez.
Sanchez, no conflict, yes.
Dr. Shaw.
Shaw, no conflicts, yes.
Dr. Long.
Long, no conflict, yes.
Dr. Cotton.
Cotton, no conflicts, yes.
Dr. Cineas.
Cineas, no conflicts, yes.
Dr. Paling.
Paling, no conflict, yes.
Lee, no conflicts, yes. Dr. Talbot.
Talbot, no conflicts, yes.
Dr. Chen.
Chen, no conflicts, yes.
Thank you. Dr. Morton.
And the motion passed 15 unanimously in favor.
Thank you, everyone. We can now put our cameras off, and we will proceed with the next session. Excellent. We're going to next introduce the meningococcal vaccine session. Dr. Kathy Paling is our work group chair for the meningococcal vaccine. So Dr. Paling, I'll turn it over to you.
Thank you. It is my pleasure to introduce the ACIP meningococcal vaccine work group. Next slide, please. The main purpose of our work group is to review data on meningococcal vaccines and to develop meningococcal vaccine policy options for ACIP consideration. We have 4 initial projects. First, to work with the ACIP and VFC leadership to incorporate MenVO1 vial into current MenVO recommendations. More on this topic will be discussed in just a moment. Second, to develop proposed recommendations for the new GSK pentavalent vaccine. Third is to develop proposed recommendations for the new Pfizer pentavalent vaccine. And fourth is to consider whether to recommend meningococcal vaccines for people experiencing homelessness. Next slide, please. In the next slide, you will see a visual of our timeline for the 4 projects. Note the numbers toward the top of the visual signify the months of the year, beginning with June 2022 and going through June 2024. We worked hard to stagger the projects as much as possible so that we can pace and not have too many activities going on at the same time. We acknowledge we will be busy and the workload should be manageable. In the next slide, I want to talk about the meningococcal vaccine work group. And a special thanks to Lynn Bata and Jamie Lair, my co-ACIP members on the work group. And you can note that we have great ex officio liaison consultants and CDC contributors, as well as our grade and ETR. A special thanks to Sam Crow, who is our fantastic CDC lead. Next slide, please. All right, so in this slide, we are looking at the epidemiology of meningococcal disease in the United States to frame the discussion. This slide covers meningococcal disease incidence in the United States from 1996 through 2019. As you can see, there has been a sustained decline during this period from 1.3 to 0.11 cases per 100,000 persons in the population. This decline in incidence began prior to the introduction of MenACWY and MenB vaccines. When we break incidence down by serotype of a group, we see it has declined for all three primary diseases causing serogroups: B in blue, C in green, and Y in yellow. That said, the decrease has been less dramatic for serogroup B than for C and Y. Incidence of serogroup W and other serogroups, including disease due to the non-groupable meningococcal bacteria, remain low during this period. Here, we can see how incidence and serogroup distribution vary by age group. In this figure, serogroup B is shown in blue, while serogroups C, W, and Y are collectively shown in yellow. Overall, the highest incidence of meningococcal disease was observed in children less than 5 years of age and among young adults aged 19 to 22 years. Serogroup B was the predominant serogroup in children under 5 years of age. In children and young adults aged 5 to 22, serogroup B accounted for approximately half the cases, and in adults aged 23 and up, serogroups C, W, and Y caused the majority of disease. There are currently 5 meningococcal vaccines licensed and available in the United States. Together, these vaccines cover 5 of the 6 serogroups that cause the majority of invasive meningococcal disease in the world, and all of the 4 serogroups, B, C, W, and Y, that circulate in the United States. Of note, the FDA just licensed a new version of Menveo that consists of 1 vial instead of the traditional 2 vials. And Sam Crow will tell you more about this new product in the next presentation. MenACWY vaccine is recommended for all adolescents 11 to 18 years, with the first dose at 11 to 12 years and a booster at 16 years. MenB vaccine is a 2-dose series that may be administered to adolescents and young adults 16 to 23 years of age based on shared clinical decision-making. The preferred age for MenB vaccine is 16 to 18 years. This slide covers the ACIP recommendations for persons at increased risk for meningococcal disease. The risk groups are listed in the first column on the left of the slide. MenACWY vaccine recommendations for each risk group are listed in the middle column, and the recommendations for MenB are listed in the column on the right of the slide. All right, thank you. We're going to move on to the next presentation.
Thank you so much, Dr. Paling. You are the queen of complicated slides. Very pleased to introduce Dr. Crow. Dr. Crow, please go ahead. And I think you're presenting first on Menveo's solution updates, after which we'll take clarifying questions, and then we'll move on to the terms of reference for pentavalent vaccines.
Great. Thank you for the opportunity to present today on GSK's new 1-vial version of Menveo. As a reminder, this is the first main project on the meningococcal vaccines workgroup. This newly licensed product will be available in the spring of 2023. The original and new versions of Menveo are nearly identical, so the ACIP Secretariat determined that grade and ETR are not required, and that ACIP and VFC votes are also not needed. The main consideration for today's presentation is that the 2 versions of the vaccine are licensed for different age ranges, raising an important provider communication and vaccine use challenge. Before turning to that challenge, here's a comparison of the 2 presentations of the vaccine. The original presentation, our Menveo 2-vial, is presented here in the center of the table. The new presentation, our Menveo 1-vial, is presented on the right. Note the difference in age ranges in the second row of the table. Menveo 2-vial is licensed for 2 months through 55 years, and Menveo 1-vial is licensed for 10 years through 55 years. More on the importance of this difference in a moment. In rows 3 and 4, we see the active ingredients, adjuvants, and preservatives are the same between the two formulations. Finally, there are only a few minor differences in the excipients. The different age ranges for the two Menveo presentations will be an important factor when vaccinating very young children who are at high risk for invasive meningococcal disease, particularly when considering the two other MenACWY vaccines that are currently licensed in the US. Menactra, which is licensed for 9 months through 55 years, was discontinued as of this past summer, and Menquadfi is licensed for 2 years and older. After the last Menactra doses are administered, Menveo 2 vial will be the only currently licensed vaccine that can be given to children less than 2 years old. GSK plans to maintain a consistent but limited supply of Menveo 2 vial for children less than 10, but the challenge will be to ensure that providers reserve Menveo 2 vial for those less than 2. To help address this challenge, GSK will send a letter to clinicians to ensure they understand the differences between the two versions of the vaccine. They also will update their website with new product information and post the provider letter. GSK will provide Menveo 2 vial through their traditional channels, which include VFC, wholesalers and distributors, and GSK Direct. CDC's Immunization Services Division is updating the VFC resolution, and as you heard this morning, the 2023 Child and Adolescent Immunization Schedule to include the new vaccine presentation and age ranges. ISD also will conduct outreach with provider groups. So thank you for listening. Before we turn to questions, I'd like to welcome Dr. Scott Priest from GSK to say a quick word about the new vaccine presentation. Dr. Priest.
Thank you very much for the invitation, Sam. My name is Scott Priest and I'm the US Medical Affairs Leader for GSK's meningococcal vaccines. I can say that GSK is pleased that the Menveo 1 vial presentation has been approved by FDA for individuals 10 years through to 55 years of age. And this approval of the Menveo 1 vial presentation means that Menveo will be available as a single vial, giving healthcare providers a more convenient option. Now, we're very cognizant that some children under 10 years of age are at increased risk of meningococcal disease, and that meningococcal ACWY vaccination is recommended by ACIP for these children. We plan to maintain a sufficient supply of Menveo 2 vial to ensure that HCPs have the option to use an ACWY vaccine that's indicated for young children under the age of 10 down to the existing lower limit of 2 months of age for the indication for 2 vial. We'll monitor volumes and adjust if required. In addition, a Dear Healthcare Practitioner letter will be sent outlining the differences both in the age indication as well as the vial appearances. In addition, we're also changing the presentation of the 2 carton boxes for the 2 different presentations with different colour stripes to ensure that they can be distinguished visually as well. Thank you very much for your attention and time.
Thank you very much. This presentation is now open for clarifying questions. Dr. Talbot.
What if you're over 55 years of age? We have plenty of adults over 55 who are asplenic and would be recommended for meningococcal vaccination.
Dr. Crow, could you take that, please?
Yes, ma'am. Menveo currently has an off-label use for over 55, and presumably that would apply to this new formulation as well.
Thank you. Dr. Chen?
Are there differences in shelf life between these two products?
Could we ask the manufacturer, perhaps? Would that be appropriate?
Yes, ma'am. Dr. Priest?
Yeah, certainly, Sam. There are. So upon launch, we expect a shelf life to be, well, we do have a shelf life, sorry, I correct myself, for 18 months. We are submitting data to expand that to 24 months. This will be shorter than the existing Menveo 2 vial shelf life, which I believe is 36 months.
Thank you. Dr. Daly?
I'm sorry if I missed this, but I guess my question is the why question, sort of, and there's a long-term Is this a short-term issue or a long-term issue? And I guess the related question would be, would we be concerned if a child under 10 received the one vial from a safety or effectiveness standpoint? Thank you.
Dr. Priest, did you want to comment, and then I can follow up? This is Sam Crow.
Yes, certainly. Happy to comment. We don't have any specific data in individuals under the age of 10 for this specific formulation or presentation. As stated before, the differences in the formulation are limited in terms of no longer having a lyophilized meningococcal A polysaccharide conjugate and instead having that in the liquid. But we don't have an indication under the age of 10 or any specific data for this presentation.
Dr. Crow, do you want to add anything else? No, nothing else? Okay.
Nothing else, thank you.
Thank you. Dr. Paling?
Yes, I wanted to ask, are there plans to study this product down to 2 months, and what is the time frame? Thank you.
Dr. Priest?
Yes, thank you for the question. So at the moment, we've made no determination or decision on whether we will be pursuing further clinical trials to extend the indication under the age of 10. We're currently assessing regulatory feedback and looking at what type of studies would need to be completed to actually achieve that, and we'll make a decision on that at a later date.
Thank you. This committee prefers simplicity in general. Dr. Freihofer?
Sandra Freihofer, American Medical Association, asking a question as a practicing physician. I've had some patients that have needed meningococcal vaccination that are over 55, as was mentioned earlier. And because of their insurance coverage, I've had to send them to the pharmacy, and I've really had a hard time getting the pharmacist to administer the vaccine, even though I've written a prescription. In fact, I've had to take a screenshot of the adult schedule and send it with the patient to show to the pharmacist. So is there any educational part of any education that we're doing to try to make some of these off-label uses known, and any suggestions how we can make that process easier for patients to get the vaccines that they need and that are indicated?
Thank you, Doctor, for the questions. I should note that Menquadfi, one of the 3 vaccines currently licensed in the U.S., is actually for ages 2 years and up. So that hopefully will be an option regardless. In terms of clarification, we do have it in our ACIP documentation, but I can work with the work group chair, Dr. Paling, and others to investigate that issue further. Thank you.
Thank you. Dr. Paling?
Dr. Cruz, I want to ask one more question. I appreciate that you have said there's going to be some color coding differences between the 1 vial and the 2 vial. Recognizing that a portion of the United States is colorblind, is there going to be other, could you describe what the changes are, and is there any other indications to make it obvious for people who are colorblind? Thank you.
Dr. Priest?
Yeah, thank you for the question. So there are a number of different differences that we've made between the 2 presentations to ensure that there are multiple opportunities to visually identify the differences between the 2 presentations. On the cartons themselves, they clearly state whether you require 1 vial per dose or 2 vial per dose. In addition, the colour strip down the 2 vial presentation is purple, whereas the colour strip down the 1 vial presentation is a dove grey. In addition, we clearly state the age indication on the box carton. We also state on one that reconstitution is required, and on the other, the 1 vial, that reconstitution is not required. When we get into the boxes themselves, the 2 vials for the 2 vial presentation, 1 vial is grey, and that is the liquid containing vial. A second vial is orange in terms of the cap lid, and that is a lyophilized powder, a white powder. For the 1 vial, there's obviously only 1 colour lid, and that is pink, but the contents of that vial is liquid. And finally, on the vials themselves is further reiterated the age indication for the product in clear legible writing, as well as whether this particular product requires reconstitution or whether it doesn't require constitution. And in the case of the one vial presentation, it also clearly states that this is one vial of one, whereas for the two vial, we will have one vial of two and two vial of two on the respective labels for the vials. I hope that's helpful.
And this is Sam Crow for the committee as well. These materials are actually in your background materials. So if you'd care to see the images and what Dr. Priest has described, please look there as well. Thank you.
Thank you. And Dr. Priest, I just wanted to thank you for that very thorough response. We're going to move on to the next presentation on ETR, or terms of reference. Apologies. Dr. Crow?
Thank you. And so now on to our final presentation covering the work group's plans for assessing the pentavalent meningococcal conjugate serogroup ABCWY vaccines. Sorry, some technical difficulties. There we go. So as a reminder, these assessments are the second and third projects the work group is tackling in the near term. There are two new MenABCWY vaccines currently in clinical trials. One is produced by GSK and the other by Pfizer. Each vaccine is a combination of an existing MenACWY vaccine and an existing MenB vaccine. The meningococcal vaccines work group will assess each of these pentavalent vaccines separately in the coming months. The tentative goal is to have votes on these vaccines at the October 2023 ACIP meeting, presuming licensure has occurred. The GSK vaccine is comprised of Menveo 1 vial and Bexsero, which is a serogroup B vaccine. Both of these vaccines are currently licensed in the United States. Clinical trials are assessing a 2-dose schedule at 0 and 6 months. The company is studying the immunogenicity and safety of the vaccine on patients aged 10 through 25 years, and doing so in both MenACWY primed and naive patients. Longer interval studies are underway, but they will not be completed before licensure and ACIP vote. The Pfizer vaccine is comprised of Pneumococcal serogroups A, C, W, and Y, and Trememba serogroup B. Trememba is currently licensed and available in the US. Pneumococcal is not, but is extensively used in Europe and elsewhere. Pfizer's clinical trials are assessing a 2-dose schedule at 0 and 6 months and at 0 and 12 months, and another schedule with 2 doses at 11 to 12 years and a booster at 16 years. They are also assessing a single dose of pentavalent as an alternative to MenACWY vaccine. They are studying the effect of the vaccine on patients aged 10 through 25 years, and doing so in both MenACWY primed and naive patients. Longer interval studies are also underway, but they will not be completed before licensure or ACIP vote. When tackling these assessments, the work group plans to review the epidemiology of meningococcal disease, immunogenicity, and safety data for each vaccine, and the expected public health impact of the vaccines. Finally, the work group will use grade and ETR to assess the vaccines. This slide lists 3 policy questions the work group decided upon for each pentavalent vaccine. First, should the pentavalent vaccine be included as an option for MenACWY and MenB vaccination in people currently recommended to receive both vaccines? So 16-year-olds are an example of this. They're recommended to get MenACWY and can get MenB based on shared clinical decision-making. Second, should the pentavalent vaccine be included as an option for people currently recommended to receive MenACWY only? An example would be 11 to 12-year-olds. Third, should the pentavalent vaccine be included as an option for people currently recommended to receive MenB only? For example, during a serogroup B outbreak. Of note, the work group decided to add the second and third policy questions because of concern that some providers might not carry MenACWY and MenB vaccines once the pentavalent vaccines become available. The next few slides show the proposed PICOs. There are 6 in total, 3 for the GSK vaccine and 3 for the Pfizer vaccine. Not to be overly repetitive, I'll only show 3 generic versions here. This slide focuses on the first policy question and asks whether the pentavalent vaccine should be included as an option for MenACWY, MenB vaccination in people currently recommended to receive both vaccines. As noted, the PICOs are very similar to one another, so I've highlighted the key differences on each slide. The population of each of the PICOs will be all individuals aged 10 years or older, currently recommended to receive the licensed vaccines. The intervention will be the pentavalent vaccine under consideration. The comparison will be the currently licensed vaccines, and the outcomes will be those listed at the bottom of the table, and more on those outcomes in one moment. This is the second PICO, which focuses on the pentavalent vaccine, whether it should be included as an option for people currently recommended to receive MenACWY only. And this is the third PICO, focusing on whether the pentavalent vaccine should be included as an option for people currently recommended to receive MenB only. After determining the policy questions and PICOs, the workgroup members rated the importance of the 6 outcomes listed here. Meningococcal disease, short-term immunity, and serious adverse events were deemed critical, while persistent immunity, interference with other vaccines, and non-serious adverse events were deemed important. Of note, there will be opportunities to revise these assessments later in the process if needed. As mentioned, the hope of the workgroup is to complete its review of these 2 vaccines in 1 year, with an anticipated vote next October, presuming the vaccines are licensed by the ACIP meeting date. In February, we will present the epidemiology of meningococcal disease in the United States, and the 2 companies, GSK and Pfizer, will give their manufacturers' presentations. In June, we will present the grade and ETR findings and expected public health impact of the vaccines. Thank you for listening. Dr. Paling and I are happy to take any questions.
Thank you, Dr. Crow. This presentation is now open for questions. We'll start with Dr. Chen.
So maybe it's my naivete, but for the outcomes of immunity, are they based on a specific cutoff titer for serum bactericidal antibody, or is it some proportion of seroconversions of 4-fold over baseline, or some other measure? I guess I'm not familiar with what the immunologic outcome measures would be based on.
So I'm rather new at this, so we have a meningococcal disease expert who's at the table with us. Dr. McNamara, if you could comment, thank you.
Sure, yes, this is Dr. McNamara from the CDC's bacterial meningitis epidemiology team. So typically serum bactericidal assay is used for the correlative protection for meningococcal vaccines. I'm not sure if the manufacturers are on the line, they might be able to comment on exactly what will be used as the correlate for licensure for these vaccines, but we'll be looking generally at SBA data for this.
I'm happy to allow for any manufacturer input on the outcomes in the trials if that can be shared at this time. If so, please just raise your hand. Otherwise, we will move on to other questions. Dr. Lair.
I want to, as a member of the work group, I want to reemphasize something that Dr. Crow said. If you could go to slide 7, we do have 3 questions. And it's relatively important because I thought we only needed 1 when I started on this work group. We just needed to know if you could do both MenB and MenA in 1. But there was a strong consideration that some practices would only carry the new pentavalent vaccine. And so we thought it was very important to decide, is that a reasonable thing to do? And that's where the 2nd and 3rd question come from. So that's something I had not considered and I think is a valuable question.
Thank you, Dr. Lair. Dr. Long?
I think that the use of a pentavalent vaccine would convert a shared decision-making recommendation to a recommendation, and I would want to have the work group think a lot about the low burden of disease. And the low burden of disease, the trust of the American people in our policies is that they're taking a risk, however it is small, of every vaccine because there's a burden of disease that we consider worth the risk. So immunizing millions of older teenagers with a vaccine with the efficacy as it is or isn't for these vaccines and for the very low risk of disease is something that I would want to hear a lot more about.
Dr. Paling would like to respond.
I want to say a special thank you to Dr. Long and to Dr. Lair for their comments, and that is the purpose of the 3 specific questions, because we do think that each one is very important to consider, and thank you for highlighting that.
Thank you. Dr. Daly?
Yeah, one quick question about presentation and then sort of a bigger picture question. The presentation question is, it will be a true pentavalent, and the B is essentially added to the ACWY that was used, and it'll be a sort of a similar, 0.5 ml single injection. Okay. So then the other is there, it feels like there's precedent for giving a multi-antigen vaccine for an outbreak, like giving MMR for a mumps outbreak. And is that helpful or is that not helpful? Thank you.
So, thank you for the question. So actually the ACIP secretary pointed me to a document that was actually published in 1999 about this particular issue, where it noted that combination vaccines may be used whenever any components of the combination are indicated and its other components are not contraindicated. And the provider might not have in instances when the provider might have other vaccines available, or when the provider might prefer to use the combo vaccine. And it recommends that the benefits and risks to administering the combo vaccine should be considered and compared during the process. That's something we will be doing, I think, in the work group deliberations. But there is some precedent for that. Thank you.
Thank you. We're going to go to Ms. McNally, and after that, Dr. Sanchez.
Thank you. So I just want to make sure I am understanding these policy questions. And in trying to understand them, I'm thinking through a scenario where you would have someone who is vaccinated with the 2-dose series against ACWY at 11 or 12, and then again at 16. And then that individual chose to get vaccinated against Men-B, let's say at age 16, but they only have 1 dose so far. So is the consideration that they may then get this pentavalent vaccine? And if so, what harm is there to the revaccination with ACWY, if any? Thank you.
Thank you, Dr. McNally. Those are actually the questions I think the work group will be deliberating on over the next year. There is some precedent, as I was saying, for having combined vaccines, but the approach of the work group at this point is to look at how the pentavalent vaccines can fit within the current ACIP schedule. And if changes to that schedule are warranted in the future, we'll turn to that then. Thank you.
Dr. Sanchez?
Thank you for that presentation. I guess what I would like to see also is a reassessment of the 11 to 12-year-old vaccine with a meningococcal vaccine. And I don't know if that's something the work group will take up, but do we need to give meningococcal vaccine at 11 to 12 years? With the low burden of disease, and should we just advocate for the 16-year-old pre-college? And I would like to see whether the work group can either reconfirm that recommendation or reassess, at least reassess it. Thank you.
Thank you, Dr. Sanchez. That's an important question and one that we've been deliberating on. The work group has, at least, excuse me. And at this point, the intention is to look at the pentavalent vaccines first, just given the complexity of addressing both vaccines at the same time, but independently from one another. But as you can imagine, these types of questions are arising throughout the process, and I'm sure will over the next year. So we'll be back in touch with the committee as we learn more. Thank you.
Thank you. So I'm gonna, we're doing last round. So Dr. Talbot, then Dr. Sineas. We'll go to Dr. Balmer and Dr. Goldman, and then we will move on to the next session.
I'll be fast. Just for clarification, I thought the idea was to create a second vaccine period so that they would come in early adolescence and get multiple vaccines to facilitate higher vaccination rates. Is that correct?
Sorry, Dr. Talbot, I'm not familiar with what you're
Because
describing.
don't they get HPV at the same time? And
HPV starts at 11, can start as soon as 9.
The fundamental question is about the adolescent platform. Does it need to sit at that adolescent platform, or do we have a late adolescent platform? Is fundamentally the issue. Dr. Sineas?
Thank you. As a follow-up to Dr. Long's question about the shared decision-making on the Men-B for after age 16, do we know what the current uptake of Men-B vaccination is in that age group?
Thank you, Doctor. I think it's around 30%. That was what we reported last year for a single dose, and I don't believe we have data for 2 doses, although it might be lower. Dr. McNamara?
Yes, I was just going to say, I think the data that we have on the complete 2-dose series for Men-B, it's usually about half of people who start a series appear to complete it.
Thank you. Dr. Balmer? Dr. Balmer, you're from Pfizer. Just want to...
Thank you, Doctor. Yes, I just wanted to go back to the very first question. I think it was from Dr. Chen on the actual outcomes. And just to add to what Dr. McNamara gave the committee in terms of information, the Pfizer pentavalent vaccine will be based on licensure criteria, which is looking at seroresponse, so a 4-fold seroresponse of HSBA titers for all 5 serogroups. And for our Men-B component, we're also doing an additional licensure endpoint of a composite HSBA response, which is an HSBA titer against all 4 Men-B strains that we're testing. Thank you.
Thank you, Dr. Balmer. And Dr. Goldman.
Thank you. I'll be brief. One of the things that you may want to look at is the dosing schedule if the manufacturers want to look at that in the future. You know, I stock both types of vaccines in my practice, and what I find is, you know, many of the pre-college physicals, they're in a panic to get their vaccines in, and having a schedule where you get it at 0 and then 1 month later, they can fit it in the summertime, but if we're at 0 and 6 months, they may not be able to get all of their vaccines in that they want before they get off to college. So it would be very helpful having a pentavalent, but if we're doing a extended dosing schedule, that may make it more difficult to implement. I don't know if that's something that can be looked at or if that's more manufacturer driven. Over.
Thank you, Dr. Goldman. I'll ask the work group to take that under advisement. Dr. Priest, I wanted to give you an opportunity to respond from GSK if you would like.
Yeah, thank you for the opportunity. So in terms of our pentavalent study, looking at non-inferiority in terms of Men-B responses, we'll actually be using a panel of 110 diverse wild-type strains to look at the effect of the antibodies at actually killing those strains within the context of an endogenous complement assay. Which we'll discuss more about. In terms of non-inferiority for ACWY, we use the standard assays for that for a 4-fold.
Thank you. And then my last 2 quick questions, if you can just define what short-term means. It means many different things to many different people. So, and then the last is just to make sure, of course, that we're incorporating equity in many of the domains. Thank you so much for that presentation. We are going to actually move on in a moment to the influenza session. I want to thank all the presenters for the meninge session. We're going to give just a couple of minutes for this transition to happen, and then we'll reconvene in just 2 to 3 minutes. Thank you, everybody. Thank you, everybody. We're ready to get started. I'm pleased to introduce Dr. Kip Talbot, who's chair of the ACIP Influenzas Work Group. So please go ahead and give us an introduction and overview. Get our slides up in just a moment.
Okay, super excited to talk about flu. Okay, I am. All right, next slide. Okay, I have an awesome group that I work with. Other ACIP members include Camille Cotton and Jamie Lair. And then we have a large number of ex officio and liaison representatives. So, thank you. Next. Oh. All right, so we've been busy. Many of you know, I think everybody's been busy. But anyway, so there's been the completion of the 2022-23 influenza vaccination recommendations, and those can be found in the MMWR. And then we've had discussions of US and Southern Hemisphere seasonal influenza activity, like RSV. It's been an upside down kind of year. We've talked about US influenza vaccine effectiveness updates from the 3 CDC networks, and we've also talked about influenza vaccination and pregnancy. And so today, we're going to talk about clinical trial data to compare safety of the recombinant influenza vaccine versus the inactivated vaccine in pregnancy. And Dr. Geeta Swami from Duke will be joining us to discuss that. We're going to have influenza activity updates, also one of my favorite topics, from Ms. Lynette Brammer and Dr. Pareen Mersenak. I should have asked beforehand, my apologies. And then we'll talk about influenza vaccine effectiveness. And Ms. Jessie Chung, Ms. Samantha Olson, and Dr. Lewis will be joining us for those. So next slide. All right, Dr. Swami, are you ready?
Good afternoon.
Great, thank you.
I think Dr. Grosskopf is going to be pulling the slides up and advancing them. All right, I'll go ahead and get started. I know that everyone's time is short, so thank you for the opportunity and the invitation to present some of the results from our study that was funded by the Clinical Immunization Safety Assessment through the CDC. And we're going to be talking about data from our randomized trial to look at the safety of recombinant influenza vaccine versus a standard inactivated influenza vaccine, both quadrivalent during pregnancy. Next slide. This is just a disclaimer to note that the findings and conclusions are those that I'm presenting here, not necessarily the official position of the CDC. And I mentioned the funding support as well. Next slide. These are my personal disclosures to note that I do serve on DSMBs and have consulted for vaccine companies in clinical trial design. Do have funding from the CDC, as well as serve on various committees for our advocacy organizations and federal advisory committees. Next slide. So just a quick point of rationale for why we were looking to conduct this study. So as you all know, that we currently recommend influenza vaccine for anyone ages 6 months and above, including pregnant women. And we wanted to look at whether there was any difference between the standard inactivated vaccine and the recombinant vaccine or flu block. Pre-licensure studies for the recombinant vaccine excluded pregnant people. And while there's no specific reason to expect that it would be unsafe, there really is no data looking in a systematic way at the safety of recombinant influenza vaccine in pregnancy. So we felt that a rigorously implemented randomized controlled trial would help to provide some of that information, both on the safety during pregnancy as well as infant health outcomes. Next slide. So the primary objective of the study was to look at adverse birth outcomes between the two groups, individuals randomized to recombinant versus standard inactivated, with a hypothesis using a non-inferiority study design that the birth outcomes in the group receiving the recombinant vaccine would be no higher or no worse than those receiving the standard influenza vaccine. Next slide. Additional secondary outcomes were to then take each of the component factors from that composite outcome of looking at adverse birth outcomes and look at them individually. Those component parts are preterm birth, defined as less than 37 weeks gestation at the time of delivery, looking at fetal deaths as well as neonatal deaths, looking at spontaneous abortion or early pregnancy loss, and then also looking at local and systemic reactogenicity, looking at comparison of moderate to severe responses following each of the vaccines. Next slide. So we enrolled individuals into this prospective double-blinded randomized trial where subjects were randomized 1-to-1. We had enrolled 382 pregnant women, all adults who were less than or equal to 34 weeks gestation. Our goal was actually to enroll about 430, but there were things that curbed the enrollment time period. We also again, we're looking at the less than 34 weeks, not because of anything related to safety or concern, but to actually be able to have adequate time to follow the pregnancy and to then see whether there were any impact on outcomes. Subjects were recruited across the 3 sites in our CISA-funded study at Duke, at Cincinnati Children's, and at Boston Medical Center. Next slide. So after randomization, participants received one of the 2 vaccines, again, in a double-blind fashion. We collected data on local and systemic reactions starting on vaccination day through day 8, using a memory aid that was provided to them that they could then provide the information back through REDCap electronic data or record that on paper and provide that information to us either in person or over the phone. Serious adverse events and other outcomes were followed through the course of pregnancy and 90 days following delivery. We did collect samples to look at immunogenicity both on day of vaccination as well as approximately 4 weeks post-vaccination. We collected maternal samples and cord blood samples during the delivery hospitalization whenever feasible as well. Next slide. So I mentioned this a bit earlier, but the primary outcome measure was defined as adverse birth outcome that was a composite, including preterm birth, spontaneous abortion, fetal death, or neonatal death. Next slide. And similarly, for the secondary outcome measures, we looked at preterm birth, a combination of fetal and neonatal death, a spontaneous abortion alone, and then the local and systemic reactogenicity events. And all of the outcome measures were assessed in our modified intent to treat population, which I'll describe, I think, on the next slide. Yes, so the modified ITT population were any participants that were enrolled, randomized into the study, and received study product. We also had a per protocol population, which was a subset of those that excluded participants who had any sort of serious protocol violations. Statistical testing was done from a non-inferiority analysis approach with the upper bound of the stratified through Newcomb binomial confidence intervals with a Cochran-Mantel-Hansel weighting those differences. We did look at other comparisons as well, and you'll see those. Next slide. So following our enrollment of participants, you can see that we approached 430 participants. 387 of those were screened. 3 were determined to be, apologies. So we had 430 participants as our target, but 387 were screened, 3 then ineligible, and none of those that were actually screened declined. So we had 384 who were enrolled and randomized. There were 2 who were excluded for eligibility criteria that were identified to be incorrect or not assessed correctly from the start. So there were, as you can see, randomized in the modified intent to treat, 190 that received Flublok, 192 that received Fluvaval. And then you can see there were some withdrawals and loss to follow-up based on lack of delivery data, as well as another participant who did not meet eligibility criteria that was identified following randomization. So the end result was based on 188 participants in the Flublok group and 187 in the Fluvaval group. Next slide. So demographic data was fairly consistent between the two study groups. We had about 33% of our participants as self-reported Black race, and the remaining you can see here. There was, again, by self-report, about 12 to 13% of participants identifying as Hispanic or Latino ethnicity. About 34% to 40% in each of the two groups were enrolled prior to 20 weeks gestation. And we were deliberate in enrolling individuals early in pregnancy to be able to have participants that we could monitor for that spontaneous abortion early pregnancy outcome. Gestational age at enrollment was roughly around 22 to 23 weeks. Next slide. So in looking specifically at the primary outcome, again, the proportion of adverse birth outcome is based on that composite definition. You can see that there was approximately 9% in the Flublok recombinant group and about 11% in the Fluvaval standard inactivated vaccine. So this, the null hypothesis of inferiority was rejected, so that the rate of adverse birth outcomes in the recombinant influenza vaccine group is considered not worse or not higher than that of the standard inactivated group. Next slide. Then breaking that down into each of the component outcomes, you can see here for preterm birth that there was about 7.5% preterm birth incidence in the Flublok group and about 10% in the Fluvaval group. That was not also not statistically different. Next slide. Combining fetal and neonatal deaths, but important to note, there were no neonatal deaths. There were 2 fetal deaths that occurred in the recombinant vaccine group, 0 in the Fluvaval group. But as you, without having any events, that's something that's not estimable from the standpoint of comparison, but would not be any higher than we would expect based on background as well. And then looking at spontaneous abortion, again, that early pregnancy loss, we looked at that amongst only the participants that enrolled prior to 20 weeks gestation. And you can see here again that there was really no difference between the two groups. Next slide. So then if we looked at the local moderate to severe reactions amongst the two groups, the blue bars are the Flublok group and the red bars are the Fluvaval group. Swelling was not identified in any participants, so there are no bars present. But you can see here that while it does graphically look that there was maybe a bit higher on the tenderness, that was not statistically different between the two groups. Next slide is going to be the systemic moderate to severe reactions. And similarly, there was no fever identified. Participants were given a thermometer as part of study procedures and were asked to record their temperatures. So there was no recorded fever and no note of significant numbers of chills. You can see here there was a few percent, or a little around 1.5% or so in each group, but no difference between them. Again, looking just graphically, it would appear that there was a higher incidence of headache amongst those in the Fluvaval group than the Flublok group, but again, that did not achieve statistically significant difference. Next slide. So we did also look at some exploratory outcomes as well. One of the things was to look at maternal serious adverse events. And you can see here listed, this is all maternal SAEs by group. And again, no difference between the two groups receiving the Flublok or Fluvaval vaccines. And all SAEs were deemed not related to vaccine as judged by the study investigators. I've listed here essentially what the categories or the diagnoses were for the majority of participants. Many were antenatal hospitalizations, including common pregnancy conditions such as preeclampsia, preterm labor, premature rupture of membranes, hyperemesis, substance use, end-stage renal disease, and some sort of vaginal bleeding. And in the postpartum hospitalization that occurred, again, it was for preeclampsia or some sort of postoperative infection. Next slide. Additional exploratory outcomes were also no different between groups, but you can see here we looked at small for gestational age or fetal growth restriction, defined as less than the 10th percentile of birth weight by gestational age. We looked at clinical chorioamnionitis, which did utilize the diagnostic criteria of fever plus additional signs of clinical chorio. And then we also looked at preeclampsia or eclampsia amongst the groups, and you can see there were no differences here either. Next slide. And then we also looked at serious adverse events among the infants and followed them out again to that 90 days of life. All SAEs here were also deemed not related to vaccination as judged by the study investigators. There were some other serious adverse events such as medically attended events like respiratory infection or whatnot. But I listed here for you the congenital malformations, as that's something that is often of interest to many individuals thinking about enrolling participants during pregnancy. And there was no pattern. There were really only, as expected based on background, several highly common, unfortunately, highly common congenital malformations as they go with regards to renal anomalies, a case of trisomy 21, VSD, renal abnormality and absent thyroid, all in one individual infant, and then the other things that you can see listed here. Next slide. So in summary, this was to date one of the, we think one of the first or maybe first randomized trial to look at the safety of recombinant influenza vaccine versus standard inactivated, both quadrivalent dosing. We enrolled 382 participants, which was 89% of our targeted goal enrollment. We were able to demonstrate that recombinant influenza vaccine is not inferior to a standard inactivated vaccine with regards to adverse birth outcomes, which was consistent with our study hypothesis. The safety profile for both vaccines appears similar for moderate to severe reactogenicity events, as well as maternal and infant health outcomes. So from the standpoint of safety, the study would support the ACIP's recommendation to include recombinant influenza vaccine as an option for pregnant individuals. I did mention that we collected blood samples at baseline following vaccination and then at delivery. And so those analyses, preliminary analyses have been done, and we're just reviewing all of those to finalize analyses there. So that is also in progress. And I think the next slide is the last slide to just acknowledge the tremendous number of people who've contributed to this study across all of our study centers, as well as our CDC colleagues and collaborators. So thank you all.
Thank you very much, Dr. Swamy, for that presentation. This presentation is now open for questions. Dr. Paling.
Dr. Swamy, thank you for a great presentation. One of the questions I'd like to ask you is, did any of the infants of the pregnant women that were vaccinated during pregnancy, were they hospitalized with an influenza illness or had a diagnosis of influenza in the subsequent 6 months? Thank you.
Yeah, absolutely. We didn't do any active surveillance for respiratory infection, but there were no hospitalizations specifically for influenza infection.
Thank you. Ms. Hayes?
Yes, Carol Hayes with the American College of Nurse Midwives. I just want to thank you so much for this research. It's just so incredibly beautiful to look at. And I did have a question. You had in the congenital anomalies that were found, was one of them your fetal death or no?
You know what? That's actually a very good question, and I should know that. But I am not. I'm blanking on that. But I could find that out and pass that along to Dr. Groskopf to give you all as the working groups and whatnot as well.
Okay.
Thank you for that question. I just don't have it right on the front of my memory.
I think it would be good to say if it was,
Yes.
if the fetal death was related to a malformation, that would be great. And will you be publishing this?
Yes, ma'am.
Great.
That is
Thank
our
you.
intent for sure.
Thank you so much.
Dr. Paling.
I've got one more question for you. I was doing some mental calculations as you were going through, and the background rate of each of the outcomes seemed to be in the expected. And I would like to, for each of your different outcomes, and I wanted to verify that I was doing my math appropriately. Thank you.
Yes. So I think you mean for the individual sort of pregnancy complications. Is that right?
Yes, ma'am.
Yes. So yes. So in the United States, preterm birth is ranges somewhere around 10 to up to or so 15% depending on group. So ours depending on various risk factors and so forth. So yes, we saw a rate around 7.5 to 10% between the two groups, and certainly the outcomes related to fetal death and spontaneous abortion would be comparable as well.
And the prevalence of identified fetal anomaly also was in the consistent with the national rates, if I was doing my math correctly.
Yes, that is correct. That's correct. We expect a background rate somewhere around, a few percent of all live births as well. And so I think the point that Ms. Hayes brought up is a good one to look at what our fetal death was if it was related to those as well. But yes, all of those would be consistent with background rates, including the things related to the exploratory outcomes. For example, preeclampsia or eclampsia was around 6 to 7%. You'll see things quoted anywhere from say 4 to 8%, depending on population and so forth.
Thank you so much. Just a brief comment to state that while we know that these background rates do occur, I think it is really helpful to have them on these slides, just because I want to make sure that the public can interpret these slides in context of what background rates are. Since you had such a nice comparison group of an activated vaccine, and we didn't necessarily have a placebo in this instance, I just think that's helpful for interpretation. Ms. McNally?
Thank you. Can we go back to slide 13? My question is whether the race and ethnicity representation here is what you were hoping to have and whether it's consistent with other vaccination and pregnancy studies. Thank you.
Thank you for the question. So we didn't actually set a target goal for enrollment by race and ethnicity. But I will say that I think these numbers are comparable or are proportional to what our populations are at our clinical sites. I can speak specifically for Duke that we generally see, apologies if you can hear a siren outside my door, that we usually see somewhere close to around anywhere from 25 to 40% of our participants, of our patients identify as Black race, depending on variation across our clinics. And I know that in particular, the site at Boston has a very similar demographic and patient profile to what we have as well.
Thank you.
Thank you.
And with that, we will move on to our next speaker, which I believe is Ms. Brammer and Dr. Marcinak, speaking about the influenza activity update. So if we could please bring up their slides. Thank you.
Okay. Good afternoon. This afternoon, I'd like to present on influenza activity that occurred here in the U.S. over the summer and during the first week of the 2022-23 influenza season. Next slide, please. Thank you. This slide shows our virologic surveillance data. On the left is data from clinical laboratories. The yellow shows influenza A viruses. The green, which is very small, shows influenza B viruses. And the line is the percent of specimens testing positive for influenza. You can see we had the late season last year, and activity continued through the summer, and we've in recent weeks have seen an increase during the first week of this new influenza season. 3.3% of all specimens tested and reported to us from clinical laboratories were positive for influenza. If you look on, and I wanted to mention that this did vary quite a bit by HHS region. The range was from 0.2% in region 8, which is the mountain region, to 10.4% in region 4, which is the southeast. On the right, you can see data from our public health laboratories that show the viruses identified by subtype. The red is influenza A, H3N2 viruses. The yellow are influenza A viruses that have not yet been subtyped, and it's very hard to see, but the orange is influenza A H1N1 viruses. We have seen predominantly H3N2 viruses, but in recent weeks we've seen a small increase in influenza A H1N1 viruses, and the pie chart there just shows the breakdown of viruses for week 40. Next slide, please. Moving on to outpatient visits for respiratory illness reported by the U.S. Outpatient Influenza-like Illness Surveillance Network, or ILI-NET. You can see on the left, this is the percent of patient visits for ILI. It's hard to see, but the red triangle, right, for week 40 is our first week. We actually began the season above our baseline. The percentage last week was 2.6 compared to our baseline of 2.5%. We do always try and emphasize the fact that this is influenza-like illness, not laboratory confirmed influenza. And as always, it is a mix of respiratory viruses, but if you look on the right-hand side, that's ILI activity levels by state, and these do seem to correspond pretty well with the areas where we are seeing a higher percentage of specimens testing positive for influenza. Next slide, please. This is data from one of our new surveillance systems that we picked up during the COVID pandemic. This is the percent of long-term care facilities with at least one confirmed influenza positive test among residents. Last year, during a relatively mild influenza season, it peaked at 1.4% of facilities having a positive influenza case in a resident. And this year we're starting to see a very slow increase, but it's right now for week 40, it's at 0.3% of facilities having flu positives among residents. Next slide, please. This is our second new surveillance system that we picked up during the pandemic. This is reports from hospitals, all hospitals across the country, of the number of admissions for laboratory confirmed influenza for that week. During last season, it peaked in April at 3,481 hospitalizations during that week. And in recent weeks, we are seeing an increase. And for the week ending October 8th, it was 1,322. And I will say that in our report tomorrow, that increase is going to continue. Next slide, please. I didn't include the NCHS all-age mortality because we're not seeing anything unusual in there, anything different than what we would expect for this time of year. But I did want to give an update on the influenza-associated pediatric deaths that we saw last year. The total so far is now 43 influenza-associated deaths in children. All of these viruses were influenza A with the exception of 2 influenza B viruses. And the most recent death reported by date of death was for week 33, which was mid-August. Next slide, please. Oops. Just to summarize, influenza activity in the U.S. remains fairly low overall, but we are seeing increase, particularly in the southeast and south central part of the country. The numbers are small so far, but H3N2 viruses are predominant in the U.S., and it is, of course, too early to tell what will be the predominant virus for the season. For the sake of time, I moved the slide to the supplemental slides for the Southern Hemisphere vaccine decision, but they did update the H1N1 component. It is within the same genetic subclade that our vaccine is. So the components of our 2022-23 Northern Hemisphere vaccine at this time look appropriate for this season. In other words, similar to the genetic groups of the viruses that we're finding. And that's all I have, so I'll turn it over to my colleague and we'll take questions for both of us at the end.
Good afternoon. Today I'll be presenting an update on 2022 Southern Hemisphere influenza surveillance in sentinel countries. The surveillance data will be coming from WHO's FluNet system, which is made mostly of data coming from influenza sentinel surveillance systems, but also includes non-sentinel data. Sequencing data comes from GSAID. So I'd first like to orient you to the data figures I'll be sharing with you for each country. On the right top panel, you can see pre-pandemic historical data in gray, which are the proportion of specimens testing positive for influenza from 2011 to 2019. The dotted red line is the epidemic threshold above which countries are considered to be experiencing their seasonal epidemic, again based off of these 2011 to 2019 historical data. The dotted green line represents 2021 data, and the bold green line represents 2022 data. In the lower panel, you can see 2022 virus data by type and when available by subtype and lineage. Influenza A viruses are in the blue and green, and influenza B viruses are in the red and orange. So starting with Australia, Australia's Southern Hemisphere season started and ended earlier than in pre-pandemic seasons, starting in the month of April and as of now ending in Epi Week 35 in August. Typed specimens so far have overwhelmingly been influenza A, with H3N2 making up 91.3% of subtyped specimens. As far as the dominant clades of circulating influenza viruses, these are based off of sequencing of specimens from July of 2022. The H1 pandemic 09 dominant clade was the 6B.1A.5A.2. H3 was 2A1B.2A.2, and B Victoria was V1A.3A.2. These dominant clades for H1, H3, and B Victoria are consistent with dominant clades that we're seeing in other Southern Hemisphere countries. Next slide, please. Australia's Department of Health and Aged Care issues a biweekly surveillance report that includes antigenic characterization of influenza isolates. Its WHO Collaborating Center characterized 2,570 isolates for antigenic similarity to their corresponding vaccine component. As you can see, they found that 92.4% of influenza AH1, 94.5% of influenza AH3 isolates, and all 6 influenza B Victoria isolates characterized the year to date were antigenically similar to corresponding vaccine components. They don't yet have influenza vaccine effectiveness estimates, but do report from preliminary data in 2022 that VE is on the lower end of the moderate range. Next slide, please. Moving on to Chile, they experienced quite an atypical influenza season in 2022, starting with influenza cases increasing during Northern Hemisphere months in January through February, followed by a more traditional Southern Hemisphere season in May through August. The season doesn't seem to be coming to a close, though, with the proportion of specimens testing positive increasing as of Epi Week 40. As is the case in Australia, most circulating viruses have been influenza A, with H3 making up over 99.8% of subtype specimens. The dominant clade data is only for H3 as of June 2022, and they report the same dominant clade as in Australia and other Southern Hemisphere countries. Next slide, please. We've been fortunate to be working closely with Chile's Ministry of Health, Institute of Public Health, and the Pan American Health Organization on a summary report of their 2022 season, including influenza vaccine effectiveness. By the peak of influenza activity in 2022, Chile had successfully vaccinated 92.5% of persons in their priority groups. Their SARI Sentinel data submitted to PAHO's network for the evaluation of vaccine effectiveness in Latin America and the Caribbean influenza, or REVLAC-E, were used to estimate this vaccine's effectiveness in preventing influenza hospitalizations. And they found that VE against influenza A, H3N2 associated hospitalizations was 49%. Next slide, please. The last country I'll share data on is South Africa, who, unlike the other two countries I just showed, have presented a more typical influenza season as compared to historic trends. Their season started in April and has declined in recent weeks. However, unlike Australia and Chile, South Africa has seen high levels of AH1N1 pandemic 09 during peak activity, corresponding to over 50% of their subtyped specimens. The later part of their season now seems to be mostly dominated by H3 and B Victoria. Information on dominant clades are from sequencing data in June and July of 2022 and show the dominant clades are the same as in other Southern Hemisphere sentinel countries. And next slide, please. So in summary, Southern Hemisphere countries have seen abnormal activity in 2021 and 2022 with shifted timing of epidemic as well as changes in the magnitude. However, influenza activity has resumed in these sentinel countries following disruptions and changes in transmission during the COVID-19 pandemic. These countries have seen mostly influenza A, H3, and 2. However, South Africa did report significant circulation of AH1 and B Victoria viruses. Next slide, please. And I'd like to thank a number of people, but specifically would like to extend a lot of thanks to the Chile Ministry of Health, Institute of Public Health, and PAHO for their collaboration on a report for the 2022 influenza season, which we hope will be published to MMWR shortly. And with that, I'll end. Thank you.
Thank you. This presentation is now open for any questions. I'm going to ask the committee to keep it a little bit brief because we're heading towards the end of the day. All right. Ms. Stinchfield.
Hi, Patsy Stinchfield, representing NAPNAP. Thank you so much for these presentations. And to all of your respiratory surveillance team, please do know we use this data quite a bit out in the field, in the media, et cetera. I just wondered if you have considered on the pediatric influenza death data, doing a similar graph or data collection related to COVID, and then also potentially for RSV as we anticipate the future RSV products. So I wondered if you've given that any thought.
That actually is the responsibility of another group here at CDC, but I think similar information would be helpful, yes.
Thank you.
Thank you. I don't see any other hands raised for the moment. Thank you. We will go on to the last presentation for this section on influenza vaccine effectiveness. Ms. Chung, Olson, and Dr. Lewis.
Hi, thank you. Can you hear me, Dr. Lee?
We can, thank you.
Wonderful. Good afternoon, everyone. My colleagues and I from the Influenza Division at CDC will be presenting flu VE estimates from last season, the 2021-22 season, using data from 3 VE platforms in the outpatient, ambulatory, emergency department, and inpatient settings. Next slide, please. You can go one more. Thank you. First, I'll present estimates from the outpatient setting among patients aged 6 months and older from the U.S. Flu VE Network. These estimates were presented preliminarily at the June ACIP meeting, although we're presenting different age groups today for the purposes of comparison with the other 2 networks. Next slide, please. The Flu VE network in the 2021-22 season included outpatient clinics, including emergency departments, at the 7 locations shown here on this slide. Next slide, please. As a reminder of the Flu VE network methods, we enroll patients aged 6 months and older who present to outpatient clinics or EDs with ARI that included fever or cough. We enrolled patients up to 10 days after illness onset, but limited our analyses here to those who enrolled within 7 days. We enrolled between October and April last season. We utilized a test negative design with persons who tested positive for SARS-CoV-2 excluded from flu VE estimates. Vaccination status was defined as receipt of 1 or more doses of any influenza vaccine using documented sources in addition to self-report. We adjusted our estimates presented today for the factors shown here on this slide. Next slide, please. All flu viruses detected in the Flu VE network in the 2021-22 season were influenza A viruses, with nearly all being A, H3, and 2 viruses. Here we present VE against A, H3, and 2 viruses overall, which was 36%, and by age group. VE among children was 45%, and VE among adults was 28%. We enrolled a very small number of cases among persons age 65 and older, and were not able to calculate an adjusted estimate for that age group. Unadjusted VE was 32% for those aged 65 and older, and the estimate was not significant. A subset of our H3 and 2 viruses were genetically sequenced, and all the viruses belong to a genetic group with antigenic differences from the vaccine strain. Next, I'll turn the presentation over to my colleague, Sam Olson.
Thank you, Jessie. Hi, I'm Sam Olson, and I lead the flu portion of the New Vaccine Surveillance Network. We are in the early stages of calculating vaccine effectiveness against influenza-associated emergency department visits and hospitalizations among children 6 months to 17 years of age. We're working on cleaning these data, and it's a top priority for the network to finalize and publish these results. So today I'll present our preliminary estimates. Next slide. This is a map of our 7 MVSN sites. These are the same sites that were included in our last published MVSN flu VE estimate during the 2019-2020 season that was presented to ACIP and published in CID. Next slide. To briefly describe our methods, we enrolled children 6 months to 17 years of age admitted to the hospital or emergency department with acute respiratory illness within 10 days of illness onset. Our flu season ranged from the end of November to early June, and we used a test negative design using both clinical and research testing to compare vaccination odds in our flu positive cases to our flu negative controls. And because of biases previously mentioned, we excluded those testing positive for COVID. To be considered vaccinated, patients received at least 1 dose of any flu vaccine according to medical records, registries, or self-report. And currently, we do not have the sample size to look at 2 doses in the younger children, but we will continue to look at this before we publish. And for our logistic regression model to calculate VE, we adjusted for site, age, and calendar time. Next slide, please. Here are preliminary estimates among children 6 months to 17 years in the inpatient and ED setting. The vaccine effectiveness was 30%. When we looked at those admitted to the emergency department, we calculated a VE of 19% with the estimate crossing the null. And among inpatients, we observed a VE of 31% with the estimate crossing the null. And now I'll pass the presentation to Nathaniel, who will share the IV results.
Much, Sam. So as Sam mentioned, this is specifically a network focusing on adults who have been admitted to hospital with acute respiratory illness. Next slide, please. So this network, the IV network, consists of over 20 large medical centers, usually those associated with academic institutions as well. This particular analysis focuses on 16 of these sites, which are shown here on this map. Next slide, please. So the methods used for analyses in this network will be familiar to many of you who work in flu and other respiratory illnesses. As I mentioned, this is specifically focusing on hospitalized patients aged 18 years or older, admitted with acute respiratory illness, and tested within 10 days of illness onset and admitted to hospital within 14 days of illness onset. The dates for this analysis period are sort of well into the middle of the previous flu season, so basically comprising the first half of 2022. As I mentioned, this is a sort of familiar test negative case control design in which we're comparing odds of vaccination among those who test positive for flu versus odds of vaccination among those who test negative for flu. Vaccination status was determined as receipt of at least one dose of any of the seasonal flu vaccines. And this was based on source documentation primarily, either in the form of medical records or immunization registries, and secondarily by self-report. If source documentation was not available, though self-report alone accounted for less than 5% of participants. For analysis, we calculated VE, again, as 1 minus the adjusted odds ratio times 100%, with logistic regression models adjusting for study site, age, sex, race and ethnicity, and calendar time. Next slide, please. So as you can see here, a familiar trend in that low VE was observed, low VE against hospitalization was observed both overall, so among everybody age 18 years or older, which comprises everybody in the study, as well as when broken down by specific age groups. All of the VE estimates cross the null, essentially suggesting null to very low VE. However, of note, when we break out specifically immunocompetent adults, we did see more moderate VE of 50% in adults aged 18 to 64 years, and an estimate which did not cross the null. Next slide, please. So basically, looking at all three of these networks, sort of in comparison and contrast to one another, sort of gives us a more robust, bird's eye view of VE during the previous flu season. So if I could have the next slide, you can see in these VE plots, we've specifically organized by age group, and then looking at the different settings within each age group. So first, outpatient as represented by the flu VE network, ED and inpatient as represented in NVSN, and then specifically inpatient alone as represented by IV. So looking at all of the estimates across all three networks, we again do see very low VE. This is consistent with previous seasons in which H3N2 had predominated. I forgot to mention, but the IV network analysis where sequencing was done on 129 specimens also showed that all of them were H3N2 virus. So this is this is typical. However, we do see higher VE in outpatient settings as opposed to ED or inpatient settings. Interestingly, thinking about the IV network results, if we're looking at immunocompetent patients alone, we see that VE of 50% for 18 to 64-year-olds. If we put this in contrast with, outpatient VE for the US flu VE network, it's sort of in line with what we might expect, where we see higher VE for the more severe outcome. So putting these estimates in opposition to one another sort of allows us to tease out some of those differences. If I could have the next slide. So to summarize, we can say that influenza vaccination provided low to non-significant protection against influenza in a season where AH3N2 predominated. This was similar across pediatric ED visits, pediatric hospitalizations, and adult hospitalizations, though we did see low to moderate VE in outpatient settings, as well as when looking specifically at immunocompetent hospitalized adults aged 18 to 64 years old. This is similar to previous seasons where H3N2 predominated. And again, we see higher VE in outpatient settings, and looking across all three networks allows us to sort of think through some of these differences and why they might exist. Thanks.
Thank you very much. This presentation is now open for questions. I have one quick question, which is, and I might have missed this, so my apologies. Do you know what proportion of adults 65 and older received a higher dose vaccine?
I can say for the IV network, it's about essentially 95% of older adults receive some sort of enhanced vaccine, whether higher dose or adjuvanted. And conversely, those under 65, about 95% are receiving the standard vaccine.
And for the flu VE network, the outpatients, for the 65 and older group, about 80% of 65 and older people received high dose or adjuvanted. Only 14% of that age group received standard dose IIV4, egg-based.
Thank you. Dr. Paling?
Thank you for these great presentations. It's really important to study flu every year. And I wanted to ask, do you have a sense of vaccine coverage by age group in the population so that we understand that perspective? Thank you.
Yeah, for the flu VE network, our vaccine coverage among controls is what we would kind of look at for that. In our enrolled population, overall last season, it was about 60%. And when we compare that to what is observed in the community reported by CDC, it's a little bit higher for adults compared to the community, and maybe a little bit lower for kids in those communities. So maybe on average, similar.
Ms. Bata?
I don't think I have a question. I just want to lament. This is really discouraging data. And I think even more discouraging is the lack of efficacy against hospitalization. And I know we can't solve this, but I think we just really need to take note and somehow send a message that we need to be finding better products.
Thank you. Dr. Long?
Thank you for that. I agree with you entirely. It seems to be on the way down annually, and I'm sure the work group has considered this notion with some evidence that repeated immunizations may be disadvantageous. So I wonder about that. Yeah, people are surprised about that, but there's the thought about, I'm not going to say this immunologically correctly, but what it is that you have seen this before your immunologic system sees certain antigens or certain epitopes or acts in a way that has to do with your original influenza infection or vaccine, and that it may cause interference with the organism being seen. So I'm sure you're thinking about this and looking at this, but it is, since you commented, I mean, we can't just say year after year, this is a good thing and everybody needs to get influenza vaccine and have a decreasing efficacy and effectiveness.
Thank you. Dr. Cotton?
I just wanted to say that this is not as, the vaccine efficacy is not what we would hope it would be, but I would still say that I often view vaccines to be like seatbelts. It's much better to have a vaccine than to not have any vaccine. And we're looking specifically at measured disease incidence and hospitalization. But if you think about it, for all of us who maybe haven't had influenza for the past few years because we've been masked, there are a lot of ramifications of not developing influenza, not having influenza in your home. And when we can decrease the risk of disease, even if it's not as much as we might have hoped for, I still think that there's a pretty positive impact from vaccination. And Dr. Long, I don't know if scientific data within the influenza vaccine field, that concept of what I understand to be antigenic sin has been more discussed with COVID, but I don't know it to be true with influenza. I don't know if there are other experts in the room, but before we push forward that idea that repeat influenza vaccine could be dangerous, I think we want to make sure there's pretty robust science behind that.
Thank you. Dr. Talbot?
Yeah, I can probably talk to that. And so the idea of imprinting is the first flu that you saw as a child, presumably, because most people get infected fairly early, is what your body responds to the most. So the population who's at highest risk for flu disease right now is imprinted with H1N1, which means they are more likely to get sick from H3N2. So when we have H3N2 seasons, we typically see much lower VE just because this population was imprinted with H1N1. That being said, we had a mismatch this year, which complicates an already lower VE to an even lower VE. So the hope is we have the right strains for this year. And we are actually seeing a mix of H1 and H3, at least in Tennessee at this point. And so I think it'll be very interesting to see what this year's are. But yes, what you saw as a child has great impact on how you will do as an older adult.
Thank you. Dr. Long, your mic is on. Did you want to say anything else? No? Okay, thank you. Dr. Anderson.
Hello, Dr. Anderson from PEDS. Question would be related to the timing of the influenza season. It's very likely that there may have been some waning of the immune response that may have happened for many of these infections, which likely were happening March, April time period. And I was wondering the extent to which that could be adjusted for in the analyses that were performed and how that did impact the overall vaccine effectiveness. Thanks.
Yeah, that's a great question with the extended flu season, and I can speak to that a little bit from the Flu VE network perspective. One thing that we did to sort of look at this was to go back to our mid-season estimates and remove persons who tested positive for SARS-CoV-2 and came up with a very similar estimate to what we observed when we looked at the whole time period. So we're not sure that waning is really the biggest factor for our lower than we would like VE estimates, but it is something to consider.
Thank you very much. I I do not see any additional hands raised, so I would like us to move on to the last two sessions of the day. We have a dengue vaccine session and a monkeypox vaccine session. If we could please pull up this, oh, magic. I'd like to turn the floor over to Dr. Wilbur Chen, who will provide an introduction, an overview on today's session on dengue vaccines.
All right, congratulations to me for leading the penultimate, session for the October meeting. So let's go to the next slide. So these are dramatic pictures that are meant to convey the image that climate is going to continue to, we think, increase dengue incidence. Humans, I say, continue to encroach on kind of natural habitats, and we'll continue to expect to see increases in possibly Ebola, monkeypox, malaria, arboviruses in general, as we continue to progress through, humans encroaching into nature and also having climate interact with our space as well. Next slide. So just to remind you that Dengvaxia was licensed in 2019, and the ACIP provided recommendations just last year. This is a vaccine that is a 3-dose regimen that is given at 0, 6, and 12 months in children who are 9 to 16 years of age with laboratory confirmed previous dengue infection. And these children are children that are living in endemic areas with dengue. Next slide. So the dengue work group recently reconvened. We've been reactivated, and we're reviewing now a new dengue vaccine, which is Takeda's TAK-003 candidate vaccine. It's a vaccine that's completed phase 3 trials. The plan is for us to present the safety and efficacy data in the February ACIP meeting. Next slide. So our work group has an agenda of course, we've been reconvened since August 30th of this year. We have been reviewing our own kind of work group schedule, and we are formulating and going through the PICO questions and reviewing right now the vaccine safety and efficacy data as we speak. Next slide. So presentations today, we plan to have Dr. Laura Adams present the dengue epidemiology to reacquaint us with this particular pathogen, and then Dr. Paz Bailey will provide us an update and an overview of Dengvaxia, basically the safety, efficacy, and implementation that we had planned in Puerto Rico. Next slide. So I just wanted to thank my work group colleagues, my ACIP co-members, Drs. Palin, Bell, and McNally, my co-leads, Drs. Paz Bailey and Adams, and then all the other ex officio members, consultants, liaisons, and many CDC contributors as well. So thank you very much.
Thank you, Dr. Chen, and we'll now turn the floor over to Dr. Adams. If we can please switch the slides, thank you.
Good afternoon, and thank you, Dr. Chen. Today I'll be going through a brief